Welcome back to day 2 of SPARC for EGPGs. Yesterday was filled with enriching sessions, insightful discussions, and a lot of learning to sharpen our preparation. Today promises to be just exciting with another round of power-packed lectures and guidance from our esteemed speakers. Let's gear up with the same enthusiasm and make the most of the opportunity. With no further delay, let's begin day 2.
It's my privilege to introduce Dr. Trophimus Gnanabhagam, currently serving as the reader in the Department of Pediatric and Preventive Dentistry at SRM Dental College, Ramapuram, Chennai. He's completed his BDS from Saveetha Dental College and Hospitals, Chennai, and his MDS in Pediatric and Preventive Dentistry from Meenakshi Ammal Dental College, Chennai. His area of expertise include preventive dentistry, management of children with special healthcare needs, and innovative pediatric endodontic techniques. He has authored and co-authored numerous research papers in topics ranging from topical anesthesia, behavior management, to restorative materials in pediatric dentistry. He's a life member of the Indian Society of Pedodontics and Preventive Dentistry and the International Association of Pediatric Endodontics. He has been actively involved in postgraduate workshops and scientific writing sessions. It gives me pleasure to introduce him today as an alumni of Saveetha Dental College. We're delighted to welcome him for the program. Thank you, sir.
So, very good morning to all of you here. I take it, I'm really happy that the college has invited me here to be a part of this rapid revision program. I thank Deepa ma'am, Mahesh sir, who are my teachers during my undergraduate period here at Saveetha Dental College. And yeah, today we're going to talk about preventive pediatric dentistry. So, what comes to your mind when you look at all these pictures here? So every day in our practice, we come across patients like this. They come to us and the parent says that my child was bottle fed or breastfed for a long time, or even up to 4 years, the child is bottle feeding. So what happens that if it is left untreated, it progresses. So it progresses and it becomes like a root stump. Right? So this is where when we have to go ahead with a root canal treatment, give them a post, and then restore it with an aesthetic restorative material and give a crown. And then we fill our pockets also by doing that. Right? So how do we prevent all these things? So during this lecture, we're going to learn about the importance of prevention, when to prevent, how to prevent, and the advancements of prevention. So the structure of my presentation is going to be, we're going to talk about first dental visit, perinatal and infant oral health, pit and fissure sealants, and fluorides. There are a lot more in pediatric preventive dentistry, which I have not included because considering the time. So let's see about each thing. So the basic things which are available in the textbook, I'm not going to put in the slides. This presentation is basically for you to take points and include in your paper. A lot of research I have included in the presentation, which will help you in writing your paper. So the first thing is the first dental visit. First dental visit, as far as I know, they've not asked in any questions in the university exam, but according to the AAPD and the ADA, it recommends the first dental visit should take place within 6 months of eruption of the first primary tooth, no later than 12 years. This was also accepted by the AAPD and the ADA. This is an interesting article which you can cite in your paper. The age 1 visit. So this was proposed by I will share all these articles with you. I've put all these articles as a PDF and I've kept it. Once the presentation is over, you can take it. So this important article was published in the year 2024, the Age 1 policy. So this policy was designed by Indian dentists for Indian dentists. So this includes the dentists, the physicians, the allied health workers. They all can work together and they can deliver dental health care for the patients. So what is this Age 1 policy? It talks about establishing a dental home, which I'll be talking to you. Parental counseling, okay? How the parents need to be prepared, to encounter whatever oral health problem the child is going to go through. The chronology, the eruption time, age-appropriate toothbrushing. When do you have to start finger brushing? When do you have to start with a toothbrush? What toothpaste to use? And fluoride adequacy. When do we start with topical fluoride application? Topical fluoride application with APF gel. Clinical examination, the knee-to-knee examination. Dietary analysis, what the diet chart to be taken. Caries risk assessment and injury prevention. I'm sure if a question on first dental visit is asked, this Age 1 policy will help you to answer the whole question. Next, about the perinatal and the infant oral health. So perinatal period is a period between the child is born till 28 days after the child is born. So the establishment of dental home is very important. Novak in the year 1999, it can be asked as a Viva question. Dental home was introduced by whom? Novak, 1999. It was adapted by AAPD in 2002 and ADA in 2005. So what is this dental home? It is the ongoing relationship between dentist and the patient, inclusive all aspects of oral health care, delivered in a comprehensive, continuously accessible, coordinated and a family-centered way. So some of the characteristics of dental home are accessibility. It should be, people should be able to access it. It should be near their house. Family-centered, the parents also need to be encouraged or educated about the importance of oral health. It should be continuous, not only, when the child is small, even when they become adolescents or grow older also, there should be an ongoing relationship between the dentist and the child. Comprehensive, 24 hours availability of the dentist should be there, and any emergency, dental emergencies are there, the child undergoes a trauma, immediately they want to come, they should be available there. Coordinated, okay, the families also should be involved here. Compassionate, dentists should be, very kind and polite when they talk to the child. Culturally competent, so we need to accept the child, okay. Cultural backgrounds and the values of the child also need to be understood. So, taking the child to the dentist and, establishing a dental home may be difficult. So, the University of Pacific, the Arthur A. Dugoni School of Dentistry has introduced the virtual dental home. This article was published in the year 2012, a virtual dental home. So it is a community-based oral health delivery system. So here you see that on-site there are allied health dental professionals, like say the dental hygienist or the dental assistant. They are there, they examine the child and they take photographs or radiographs, and this data is stored in a cloud-based electronic health record. And this is going to be reviewed by dentist who is off-site. And this dentist who is off-site is going to give a plan. So if the treatment is required by the dentist comes on-site and the treatment is done. If no treatment is actually required, if just basic counseling or education is needed, the people who are there, the health educators at the site can help them. So this is a virtual dental home. So if a question on dental home, I think they've asked in few papers, you can include this point on virtual dental home also. So what do you do in a dental home? Okay, something called as anticipatory guidance is given. It is a process of providing practical and developmentally appropriate information about children's health to prepare parents for significant physical, emotional, and psychological milestone. This is the latest guideline given by the AAPD in 2022. Some of the topics covered here are oral hygiene, diet and nutrition, injury prevention, non-nutritive sucking, oral development, teething. So most of the parents, at one point, when the child puts the finger, maybe say a 7 or 8-month-old child puts the finger into the mouth, what does the mother do? She removes the finger from the mouth, okay? This reason is because teething happens and the child, feels the gum so itchy. So that is why. So we need to educate the parents about teething. There are a lot of parents who do not know which tooth erupts at what time. So this education has to be given. Fluoride adequacy, at what age do we start top fluoride varnish? What age do we start fluoride with APF? Speech and language development is also a part of anticipatory guidance. So we as pediatric dentists can identify this problem, okay? The parent may bring the child to you and then the child is not talking. The parent will say, my child is talking at home, but not talking to you because, she is scared of you, because you're somebody new. But no, as pediatric dentists, we need to be able to identify if the child has any speech and language disability. So the next important question which we will discuss is about pit and fissure sealant. It's a very, very vast topic. So always remember, when you write an answer, write something called as an outline, or your synopsis, or you call it structure, whatever you call it. Always put that in front, okay? Because the examiner who is going to correct the paper has to know what is there in your paper. So when you're going to write something on pit and fissure sealant, include the definition, the history, types of pits and fissures, the ideal requisites of a sealant, indication, contraindication, classification, clinical procedure, evaluation, whether to seal or not seal, sealants in primary molars, and recent advances. So all these basic information which are there in the textbook, I'm not going to mention. I'm going to talk only about the studies which are available during each step of applying a pit and fissure sealant. So the basic definitions you're supposed to know about what is pit. Ash in 1993, it's a pinpoint depression at the junction of developmental grooves or at terminal of those grooves. Fissure, deep clefts between the adjoining cusps. And this person called Simonson plays a very, very important role in pit and fissure sealant. If somebody asks, if a question on pit and fissure sealant is asked, definitely Simonson has to be included in your paper, okay? So pit and fissure sealant can be defined as the material that is introduced into the occlusal pits and fissures of caries susceptible teeth, forming a micromechanically bonded protective layer, cutting access to caries producing bacteria and their sources of nutrition. So once the definition is over, you move on to the classification, where you talk about the resin-based sealants, the glass ionomer-based sealants, and the polyacid modified resin sealant. So once classification, you will talk about the indication, contraindication, types of fissures, all those things are there available. Next, moving on to the clinical procedure. Before you apply a sealant, you have to do something called as a preparation of the tooth. So you can use the rubber cups along with pumice slurry, toothbrush with dentifrice, air abrasion, elimination of fissures with burrs, sandblasting. Topical fluoride can also be applied before sealant, and the use of laser. So this is an interesting systematic review and meta-analysis which was published in 2016. Preparation before acid etching in fissure sealant therapy, yes or no, okay? So a total of 12 studies were included here. And they say that the preparation of the tooth before applying a sealant has a better retention ability, okay? But they have said that preparation alone cannot substitute the conventional etching process before sealant application. The next in vitro study, which was done using topical fluoride application. So they said that apply topical fluorides, which will help in better retention of sealant, but they say that the bonding is not that, it does not, give a better results when applying a topical fluoride before applying sealants. So whether laser can help in tooth preparation, no. They say that using a burr for mechanical preparation gives a better result when compared to exposing a laser to the tooth structure. So we need to etch even the prepare even the fluorose tooth. So the use of the erbium, yttrium, aluminum garnet laser has, for a fluorose tooth, can also be used as an alternative to the mechanically used burrs. So in preparation, there's another method called the deproteinization, that is the removal of proteins from the surface. So the most commonly used deproteinization agent is 5.25% of sodium hypochlorite. Papain can be used. Bromelain, which is obtained from the stem of pineapple. And enzymatic soap, zyme and tergazyme. So this is an in vitro study which was done, and they have concluded that the use of tergazyme, papain and bromelain as a deproteinization agent had a better bond strength values when they use the two sealants like HelioSeal F and the Diad Flow sealant. So once this preparation of the tooth is over, the next procedure is isolating the tooth. Okay. So as we all know, we've read from articles that isolation is done using cotton rolls, rubber dam, and there's another method called the dry shield method. So an RCT which was published in 2022 say that there was no significant difference between using a rubber dam or cotton rolls at the end of 12 to 22 month follow-up. And another study where the dry shield system, the photo here, that is the dry shield system, which was compared with cotton rolls. And they've said that both these methods have equivalent performance, and these are, well accepted by the school children, the dry shield as well as cotton roll. Another systematic review while comparing cotton rolls and rubber dams, 7 RCTs and 1 non-RCT was used. And at the end of 12 months, they've said that the sealant placement using rubber dam is better when compared to using cotton rolls. The marginal integrity and the performance of rubber dam and cotton rolls was equivalent at the end of 12 months. So they say that the rubber dam performed better when compared to cotton rolls. So once you isolate the tooth, the next procedure is that you etch the tooth. So the current concept that we follow is based on the IADR Symposium 1991. Primary tooth etching 30 seconds, permanent tooth 20 seconds, washing for primary is 30 seconds, permanent also 30, primary 30, permanent 30, drying both 15-15. So why is the acid etching time for primary more when compared to permanent? Because of the aprismatic structure. The prismless enamel is seen in primary tooth. That is why etching time is longer. Earlier it was 120 seconds, reduced to 60 seconds, and now it is 30 seconds. They also say that etching for fluorose tooth should be more, because the fluorose tooth have fluorapatite crystals. It is going to resist the uptake of the acids. Self-etching is better, is not recommended, but the total etch or the conventional etch is preferred when compared to self-etch. Studies which support this systematic review and meta-analysis, 10 articles were included, and they say that the conventional single bottle system is much better when compared to self-etch system. But whereas the second RCT which was published, they say that for a 6-month period, self-etch performed better, but for a long run, the single bottle system, the adhesive and the etchant separately performed better. So this is another study studying about the micro shear bond strength, okay, of primary tooth. They compared 3 times, okay, 8 seconds, 15 seconds, and 30 seconds. They used ClinPro cement. This was a laboratory study. So 3 times they used, and then they've concluded that all 3 times, showed a good micro shear bond strength between the etchant and the pit and fissure sealant. So once etchant is over, the next procedure is the application of bonding agent. So Fiegel et al. Has proposed the use of bonding agent, which will help in the retention and the sealant penetration. This was also accepted by the AAPD and the ADA. So Ansari and Hashmi in 2008 say that if the tooth, is dry and devoid of any saliva, it is not necessary that we have to seal. But there's a strong objection by Bucamp and Askarizadeh, which they say that, it is not possible for us to, keep the tooth devoid of saliva. Some sort of saliva contamination is definitely seen. So a study supporting this, an RCT 1-year follow-up, published in 2020, they say that the usage of bonding agent between the sealant and the tooth will help in increased retention. Okay. So this is an umbrella review where 15 systematic reviews were taken. dental sealing is an effective method for preventing dental caries, okay, compared to not doing anything. So applying a sealant is much better than not just leaving the tooth just like that. And it is not easy to conclude that whether this sealant is better or that sealant is better, but the usage of resin-based sealant is better, they say, based on the systematic review. And they also concluded that sealants are not superior when compared to the application of fluoride varnishes. So you can use this systematic review, umbrella review also for your paper. So once you apply the sealant, the next procedure is that you evaluate the sealant. There are a few criteria, the Simonson's criteria, which uses the marginal integrity, marginal discoloration, and anatomic form. Simonson's criteria was later modified. The Torn and Rice classification criteria, which was given in 1982, and then the CCC criteria is also a method which was used to evaluate. So next, moving on to the recent advances of pit and fissure sealant, okay, the moisture tolerant sealant. It's always important that that you include systematic reviews in your paper, because there are a lot of studies included there. So if you just read one systematic review, it is enough for you to write so much, loads and loads of answers for a question. So systematic review and meta-analysis, 2025, this article was published. 15 RCTs were taken and 3 are non-RCTs. They say that hydrophilic sealants, initially they perform better, but it is not good for a long run. That is moisture tolerant sealant, not good. And another systematic review, 7 RCTs and 15 non-RCTs were taken. They say that after 12 months, there was no significant difference between hydrophilic and the hydrophobic sealants. So some of the commercially available hydrophilic sealants are the Embrace Wet Bond and the Ultra Seal XT. So this is an in vitro study between the hydrophilic and the conventional hydrophobic. So this is in contrary to what we saw earlier. They say that the Ultra Seal XT, they performed better when compared to ClinPro, and they also showed lower micro leakage. This particular literature review, you know, there below, you can use it for writing an answer for moisture tolerant sealant. If you want to know more about that, you can read that. The next advancement is the fluoride releasing. So for some of the commercially available fluoride releasing sealants are the HelioSeal F, HelioSeal F+. So a 3-year clinical performance of HelioSeal F+ was done, which was published in 2022. And they've said that there's no significant difference between HelioSeal and HelioSeal F, right? Calcium fluoride nanoparticle sealant. This is also a new material which was introduced. This is a laboratory-based study. They've concluded that this calcium fluoride-based nanoparticle sealants, they provide a long-term fluoride release of fluoride ions, which can help in caries prevention. Colored sealants, change of color. ClinPro has colored sealants which change from pink to opaque color. HelioSeal F also has colored sealant which changes color from clear to green color. Next is the geomer-based sealant. An example of this is the Beauty Seal. So this is an RCT which was published in the year 2022, comparing the Beauty Seal and the Conceal F, which is a fluoride-based sealant. And they've concluded that there's going to be high failure rate in the geomer. Why is this so? Because in patients with MIH, why is it so? Because the etching capacity is going to be less because a self-etched adhesive was used. So they say that fluoride-based sealant is, fluoride-releasing sealant is much better when compared to a geomer. The ACP releasing sealant, okay, the commercially available ACP releasing sealant is the AGs. I'm sure most of you would have used it. And they say that AGs performed better. This study says that AGs performed better when compared to the Conceal F and the Concise Opaque White. And next is a glass ionoma-based sealant. This is a systematic review and meta-analysis. 20 studies were included on caries prevention, 28 studies on retention, and they have concluded there is no significant difference between a glass ionoma-based cement and this compared to a resin-based sealant. They say that the retention can be compromised in a glass ionomer cement based sealant when compared to the resin based sealant. So can we use sealants for primary tooth? Yes, we can use sealants for primary tooth considering the age of the child. Maybe the child's age is from say 4 to 6 years. High caries risk, we can apply sealants for primary tooth. A split mouth randomized clinical trial published in 2020, they have said that at the end of 2 years, they say that primary tooth does not retain sealants. The sealant, comes out of the tooth. So effectiveness is going to be very, very low. Another umbrella review comparing primary and permanent tooth, they say that using 7 systematic reviews, permanent tooth, the adhesion is better, whereas primary tooth, the retention of sealant is not that much. Maybe because of, the improper oral hygiene or the food the child takes or the parent not giving proper care to it. This also can be a reason for it. So these studies you can use. I know that it is very difficult for you to include all studies, but it is good that at each point of applying a sealant, if you can mention at least one study, it would be great, and your examiners will be really impressed about your paper. The next question which was asked is preventive resin restoration. Okay, Simonson installed it in 1977, which was revisited in 1985. So this is a conservative treatment which involves limited excavation of removed caries tissues, restoration of excavated areas with a composite resin, and application of sealant over the surface of restoration and remaining sound and contiguous pits and fissures. Another term for PRR can be conservative adhesive restoration, right? So as you know, there are 3 types of PRR which can be applied. This is a study where comparing a compomer and a flowable composite for doing a preventive resin restoration. They have concluded that at the end of 4 months, the compomer and composites, flowable composite, had similar results when compared to the conventional composites while doing a PRR procedure. So this is about pit and fissure sealant. Now we move on to fluorides. So fluorides, according to WHO in 1958, has said that 1 ppm of fluoride is needed in drinking water to reduce the amount of caries in children and make it as a preventive action. The few studies that you have to remember are the Grand Rapids Muskegon study, the Newburgh Kingston study, Evanston Oak Park study, Dale Cullenborg Dutch study, Brantford Sarnia Stanford study, and Hastings New Zealand study. So an explanation of all these studies are available in all the basic pediatric dentistry textbooks. I'm not going into it. The mechanism of action of fluoride. So when fluoride is going to be applied onto the tooth surface, the first thing is, as you all know, the hydroxyapatite crystals are going to be replaced by the fluorapatite crystals. It helps in enhancing the remineralization, okay, process, and then by some bacterial enzymes also can be inhibited, and this will help in prevention of new carious lesions to be formed. Defluoridation. So defluoridation is the process of removal of fluoride out of the water. So the commonly used defluoridation methods are change in water supply, adsorption, ion exchange, reverse osmosis, electrolysis. So these are things. So the most common method and accepted method is the adsorption method. So what can be used for adsorption? Aluminum-based adsorbents can be used, calcium-based adsorbents can be used, metal-based adsorbents, and natural adsorbents can be used. Some of the natural adsorbents available are red soil, charcoal, brick fly ash, serpentine, plant parts, natural polymers, and polysaccharides. So this is an interesting article which you can read for advances in future perspectives of water fluoridation by adsorption method. Another method which can be used for adsorption is, which is the newer method published in 2023, the nanoadsorbent. They say that nanoparticles help in adsorption process and it gives an excellent result for defluoridation. Next is the fluoride toxicity. This can be asked as an viva question. What is the safely tolerated dose? 1 milligrams per kg. Potentially lethal dose can be 5 milligrams per kg, and certainly lethal dose 32 to 64 milligrams per kg. So as we all know, there is acute fluoride toxicity, chronic fluoride toxicity. In acute fluoride toxicity, you know that there's nausea, vomiting, diarrhea, and all those things. Chronic fluoride toxicity, skeletal fluorosis and dental fluorosis. In acute fluoride toxicity, chronic fluoride toxicity, we also have there's a systematic review which was done and meta-analysis targeting on the neurodevelopment. They say that increased fluoride exposure can cause decreased IQ. And this is an interesting article which you can read. 33 studies were included. And they've concluded that increase in above 1 milligram of fluoride actually reduced the IQ of the children. So adequate amount of fluoride has to be intaked by the children to avoid fluoride toxicity. So the next important question asked in many papers are topical fluorides in preventive dentistry. So what is this? This is the application of fluoride onto the tooth, where the tooth topically onto the tooth, and the tooth uptakes this fluoride. And this helps in remineralization, strengthens the enamel, and prevents the tooth from any acid resistance by bacteria. Types of fluorides: professionally applied topical fluorides and self-applied topical fluorides. Under professionally applied, we've got sodium fluoride, stannous fluoride, acylated phosphate fluoride, fluoride varnish, and intraoral fluoride releasing devices. Self-applied topical fluorides, we've got fluoride dentifrices, fluoride mouth rinses, and fluoride lozenges. So this is the comparison between fluoride gel, which is an RCT, where fluoride gel is going to be applied onto the tooth surface with a toothbrush. And they say that applying fluoride varnish onto the tooth surface using a toothbrush, when compared to sodium, fluoride varnish shows better results in reducing caries at the end of 24 months. And biannual application of this proved that it shows a good result. Under fluoride varnish, we know that fluoride varnish, when applied onto the tooth surface, it's a lacquer-based product. When applied onto the tooth surface, it forms a depot here. And this fluoride, which is present on the tooth surface, gets slowly released over a period of 6 to 7 months, and thus helps in preventing new carious lesions. So this can be asked as the examiner can ask you, can tell me some of the commercially available fluoride varnishes in the market. Durafat, Fluor Protector, Duraflow, and Fluoritop, Voco, Flow Fluorid. These are all commercially available fluoride varnishes. So this is a systematic review of fluoride varnish in dental caries preschoolers, systematic review. A total of 20 trials were taken here. But they say that there's hardly any difference in applying a fluoride varnish in a child for developing new carious lesions. So there's no difference in applying fluoride varnish for a patient who has already caries existing in them. Comparison of pit and fissure sealant and fluoride application in school children, systematic review. 4 studies were included here. Total of 1,249 subjects were taken between ages 6 to 8 years. And they have concluded that there is no significant difference between the pit and fissure sealant and the fluoride varnish. They say that fluoride varnishes are going to be affordable, so it is better that we use fluoride varnish when compared to pit and fissure sealant. Another advancement in fluorides are the silver diamine fluoride. Okay, so all of us use SDF in our day-to-day practice. A child, the picture which I showed you at the first slide, the parent comes to you, bottle feeding, child is not cooperative. The immediate thing what we do is we tell them the disadvantage, and then we apply the fluoride, silver diamine fluoride onto the tooth surface. Easy to apply, but the thing is the concentration is going to be very high, 44,800 ppm, pH is 10. So what happens when you apply silver diamine fluoride onto the tooth surface? Okay, so it forms, the hydroxyapatite crystals are replaced by the fluorapatite crystals. Something else is formed, silver phosphate and calcium fluoride. So this is going to act as a reservoir. So this is called that zombie effect. So this silver is going to be taken up by the bacteria. If there's going to be any new bacteria coming and attacking the tooth, this silver particles are going to attack the new bacteria and then help in reducing the caries. So anti-cariogenicity is going to be there, remineralization and reduction of dentin collagen matrix. So silver diamine fluoride always to be applied only for a cavitated tooth. Okay, for primary tooth you can apply to the interproximal surface, occlusal surface and the facial and lingual surface. For a permanent tooth you can apply it on to the root surface as well. So some of the commercially available, even the examiner can ask you what are the commercially available SDF in the market. Kidzi has it, FA Gammon, Kido, and Rivastar, which was one of the initially introduced one. New Smile also has. So are there any dosage or toxicity based on SDF? One drop of SDF contains 0.05 ml of SDF, and this is going to be adequate for you to treat 6 teeth. Okay, so you can earn actually good money by applying SDF for patients. The average lethal dose can be 520 milligrams per kg. So silver poisoning can happen only when you apply more than 400 SDF for the patient. So some of the common adverse effects can be bitter tasting, discoloration. So make sure that you don't apply onto the mucosa because it may cause irritation. Though it may cause irritation, it will reverse after some time. Sometimes you apply, it falls on your skin also, immediately, I don't know how many of you have encountered, immediately it turns black in color. And always remember that RDT is very important when you apply SDF, and increase pulp cell death if the RDT is going to be less. So this blackish discoloration can also be reversed by this. This is a beautiful RCT which you can read, published in 2022, where potassium iodide versus silver diamine fluoride alone. They've said that when you apply potassium iodide onto the silver diamine fluoride applied tooth, it forms tripotassium phosphate, which is a white delinquent powder, and silver iodide. So this blackish discoloration can also be masked by silver modified ART. So this is a minimally invasive dentistry procedure where SDF and ART together, SDF to arrest caries and remineralization, ART, which is a non-invasive process, it releases also fluoride. So do we have to really restore a tooth after SDF? Yes. Because once you apply SDF onto the tooth surface, it is not going to restore the form of the tooth. Okay, there's going to be a depression which is going to be there, and it can also harbor microorganisms, food particles, and it can thereby it will nourish whatever microorganisms which are there. So for a conservative approach and to maintain the vitality of the tooth, it is good that you give a restoration over SDF, which will also mask the discoloration of SDF. To do single visit SDF, or to do single visit smart or 2 visit smart. This is an interesting article, RCT, published in 2025. Okay, they say that both single visit as well as 2 visit SDF gave good results. Comparison between smart and SDF, they say that smart is much better when compared to SDF and it is cost effective also. These are the 2 RCTs which you can read about smart versus ART. So these are few papers which you can read for preparing your answers on SDF. Next, moving on to fluoride dentifrice. Okay, so all of us would have seen during our childhood this advertisement on the TV, brush 2 times a day. So brush with what? It's interesting that we have to definitely use a fluoridated dentifrice for a tooth. So some of the commonly available fluoridated dentifrice are sodium fluoride, stannous fluoride, sodium monofluorophosphate, amine fluoride. Okay, the concentration of fluoride in the kids' toothpaste is around 500 ppm. The guideline policy given by EAPD is available. Okay, so they say that children below the age of 4 years if they are exposed to more of fluoride, in future it may affect the permanent tooth. It may cause even fluorosis. So it needs to be used carefully. But whereas there's a recent guidelines which recommend 1000 ppm usage of fluoridated toothpaste for children with high risk. Okay, to be noted, only children with high risk to be used 100,000 ppm. So how much toothpaste do we use? First tooth up to 2 years, they say that 1000 ppm fluoride, a grain of rice can be used. 2 to 6 years, 1000 ppm, pea-sized. Over 6 years, up to the full length, you can use 1000 ppm fluoridated. So some of the commonly available fluoridated toothpaste in the market are Pedodont, Pediflor. Recently, Pediflor has introduced 1000 ppm fluoride also. Even Colgate, the purple one, has 1000 ppm. So there are even CPP, ACP, remineralization toothpaste. This is an 1-year clinical trial where in primary anterior tooth they have used CPP, ACP daily. Whenever the child came to school, they applied the toothpaste. After the end of 1 year, they found out that there is no superior differences between applying a CPP, ACP toothpaste onto the tooth surface. How did they analyze this? They used the QLF. And another in vitro study where fluoride dentifrice and the CPP, ACP tooth cream was used. And they found out that ACP paste along with fluoride helped in the subsurface demineralization of enamel. Next, moving on to the mouth rinses. So these are the commercially available. So daily use of 0.05% of sodium fluoride, 225 ppm shows good results in reducing caries. An interesting systematic review where they've used 28 articles. Daily or weekly use of sodium fluoride mouth rinse had a significant caries reduction in children and adolescents. And they've also said that 39% DMFS score was reduced when compared to those children who did not use sodium fluoride mouth rinse. So before you end the answer on a topical fluoride, so we see that undergraduates also apply fluoride. So what is their knowledge on this? So a study published in the year 2018 say that dental students showed deficient knowledge on the understanding of pit and fissure sealant. So leave off student, what about the practitioners? This is a study where knowledge and attitude of Indian dentists, they've seen that the knowledge of applying topical fluorides is average. The attitude is favorable, but most of them, fail to apply topical fluorides for patients. So this is all about topical fluorides. These are some of the important essay questions which are asked in this chapter on preventive dentistry. I've mentioned which year they've asked. I was not able to get from other universities. For whatever I was able to get, I put it in the slide. And these are the short note questions. So I'm sure most of the speakers yesterday would have given you some tips. So I too would like to add something. So it's important that you review previous university exam question papers from your university especially, and prepare notes. I don't know how, maybe your exams are there in the next 1 month. It's difficult, but if possible, prepare your notes. Plan your answers once you read your questions. Don't directly jump into a conclusion and just start writing. Plan your answers. And most of the examiners, may not be interested to read paragraphs and paragraphs of answers. So include flowcharts, mind maps, and diagrams. Include relevant literature, especially literature from PubMed, has good weightage. Systematic reviews, RCTs. So when, I was like you sitting here 8 years back listening to lectures here, one of the speaker, spoke that, examiners who correct the papers are interested to read about authors. They want to know names. They want to see names. So include a lot of authors in your, especially regional studies, national studies. If you know the examiner who is going to come for your exam, you can include their studies also, which can increase your score in your paper also. So please include authors. If you do not know the author's name, please do not cook up authors and write in your paper, because examiners are very smart. And they may even Google up, and you may lose trust. And highlight important points using highlighter or pens or whatever. And end the answer with an apt conclusion, okay? Abrupt conclusion will not fetch you much marks. So what is your conclusion? Or what is the current scenario? What is the current benefit for clinical practice on this question? So this type of conclusion will help you to score good marks. So do your best, and all the very best for your exams. Thank you once again, Deepa ma'am, Mahesh sir, for inviting me. Deepa ma'am was my teacher. She's seen me grow as a student from first year. I've seen here, ma'am here. And thank you, ma'am, for inviting me here. Thank you.
Thank you so much, sir, for such an informative presentation. I would like to ask Deepa ma'am to come and present the momentum, please.
Thank you, Trophimus. Though I came for your lecture at the end, I trusted Trophimus, who I've known him from his first year. So, last 13 years? Yeah. So when the other staff, Dr. Vignesh, suggested his name, it was actually, why did not we call him earlier itself? That was the thought I had for him. Because he was really, really good as a student. And now as a faculty also, I know him, he's doing well, not in our college. We are not fortunate enough to have him here. But yes, thank you so much, Trophy, to come here. And thanks to all of you all to have come here by 8 o'clock. It's great of you all. Thank you once again.
It gives me immense pleasure to introduce Dr. A.J. Sai Shankar, Professor and Head of the Department Pedodontics and Pediatric Dentistry in SPARC Institute of Dental Sciences, Guntur. With over 26 years of teaching experience, including 18 years of postgraduate training, he has mentored and inspired countless budding pediatric dentists. Dr. Sai Shankar completed his BDS from SDM College of Dental Sciences, Dharwad, and MDS from Bapuji Dental College, Davangere. He has delivered numerous guest lectures at national and international platforms, published extensively on pediatric endodontics, preventive dentistry, and innovative practice management, and holds life memberships in both IDA and ISPPD. On a personal note, it's special for me to introduce you, sir, because we share the same alma mater, SDM Dental College. We are privileged to have you here, sir.
So, good morning. So, welcome to the 7th session of SPARC. As the name suggests, it's not the abbreviation, it sparks, ignites new information to you. This is a novel thing that Saveetha is doing. So, let me introduce myself. I am Dr. Sai Shankar, working as Professor and Head in the Department of Pediatric Dentistry. This is my college in Andhra Pradesh. So the topic given to me is Preventive and Interceptive Orthodontics. I have a habit of teaching lectures in this way. That is, generally when we offer sweets to someone, we give it with a wrapper. But I have a habit of opening the wrapper and giving the sweet in your mouth. So I am not here to teach preventive and interceptive orthodontics in an 1 hour session. So I think all of you means all the exam going PGs at least, they will be well aware of all things that are there in interceptive and preventive orthodontics. So I just want to brief up with few of the things, right, which will help you for writing the exam successfully. So basically this interceptive and preventive topic, usually they ask in part 2, paper 1, rarely in part 2, paper 2, and very means less often in as part 3 question. So 50 marks question they ask little bit rarely, but most of the times it is the clinical topic. 70% you can be sure that you will be getting a essay out of it, or a short notes at least. So the common things what we ask in chair side viva, 100% people will be asking chair side viva multiple questions on this topic. And lastly, this will fetch you a lot of money in your private practice. Once you go out, it will fetch you a lot of money. Presentation itself, it's not a presentation as such, but the points you have to remember. These are my observations over my almost 2.5 decades of my academic career as a undergraduate and a postgraduate teacher. What I have seen is most of the times the notes that is prepared by your super seniors will be just transferred. And nowadays, fortunately, unfortunately, it is all digital era that everyone are just transferring in a seconds, whether it is LDA, whether it is a thesis, whether it is an essay question. But during our times, usually we used to write, sit in the library, prepare our own notes, and we used to share between ourselves, means our batchmates. But nowadays it is fast spreading. Hardly people are reading the textbooks. I have been to so many colleges where for PG exams or even for undergraduate exams, no one are going to library. Everyone have their digital connection and they are doing it in the house. Or luckily they have that Google, so everyone is being done with that. I don't know whether these questions can be done with for undergraduates or +1, +2. They have means if you feed the question, they will give the answer. That details I don't know, but I'm not a technique savvy, so I'm poor in that. So my request here is try to read standard textbooks. When you say preventive and interceptive orthodontics, which textbook you refer? Standard textbook. Yes. So, means if you have the privilege of opening it, it is nice because the basic core will be given in Stewart and Barber, and all the remaining textbooks, whether it is Finn, whether it is McDonald, all those things will give you the inputs, but the standard information will be given in Stewart and Barber. So prepare your own notes. And see, the basic thing of preparing your own notes is, the advantage is you have to read the things before you write down. So that means one reading is over. While writing, you will read once again. And before the exam, you can write, and you can, once you get, it's not like Swiggy and Zomato where you get the notes from some other people and start reading it. It will be quite difficult. And most importantly, as our colleague has told, it is like the sequential presentation of the answers is very important. I have seen in most of the paper evaluation, nowadays it is digital, so they don't write the question number. So we have to search whether they have written it or not. If we say not attempted, there is always a chance that you may fail. So it is always better you write the question properly. Write the question, 1 minute will take. And after that, you plan the answer. Okay? And before doing that, read the question properly. I have seen so many people, if you say interceptive and interceptive orthodontics, or if they see somewhere space, they'll write space management or space maintainers, different space maintainers, indications, all those things, which may not be required. So just read the question properly and plan the points accordingly. And always avoid paragraphs. Let it be in point-wise manner. And most importantly, draw diagrams wherever it is required. Or, and most importantly, if you just want to pass, this is sufficient. And if you want good marks, yes, you need to quote articles. And usually I divide the articles into 3 parts. One is the old or the basic topics or the landmark studies, then the recent ones, and the examiners will be interested to see their own names. So add few Indian studies also. There are good number of research articles that have been published. So it is always better in all the topics, whether it is interceptive or preventive, means all the topics what been covered yesterday and today. A lot of studies are there. You can quote one of them. So, and also writing clearly. Don't scribble. And most of the times it should be appealing to the examiner, because he will take just 10 minutes to correct your paper. So make sure that you get more marks. And few universities say that you should not underline with color markers. So because it will reflect on the back page and the scanning will be a problem. So try to highlight that with the same color pen. Don't waste your time. Just retrospect whatever you have written. Most of the people, they write pages together. We don't measure and mark. Okay, as a senior person, generally we check whether the person has the idea or not. So taking all these things into consideration, I have taken an effort to find out, collected few of the question papers from different universities and sorted out few questions. There are straightforward questions like if someone asks you like a chin cup or serial extraction or Dwell's method or direct questions are there, you need to write accordingly. But I am going to discuss few questions and what all things are expected out of you. I am not going to teach what is interceptive, what is preventive, orthodontics, all those things. So this is the first question. Usually is a common question, even for undergraduates they'll ask, but this is a PG question that has been asked in a few of the universities. So define preventive orthodontics and enumerate the procedures carried out in preventive orthodontics. So you will be knowing all those things, right? So whether it is, when it is, a question is like that, just think what they have asked. Define preventive orthodontics. That is, you have to give the definition first. Then, what is the rationale behind preventive orthodontics? Then third one is list out. When you say enumerate, that means you have to list out what all things that comes under preventive orthodontics. So all the things that are there, patient education, caries control, I just don't want to read all those things. You just list out all those things and start writing one after other. Whether it is parent education, that is the importance of preventive managing the teeth. That means proper maintenance of the teeth. If there is proximal caries, usually there will be space loss. For that, they have to come for regular, means they have to maintain the hygiene properly, and also the caries control, as I said, restorations, crowns accordingly. Care of the deciduous teeth, it is whether it is restorations or pulpal therapy to avoid space loss. Extraction of supernumerary teeth or over-retained teeth, always maintain or check. You have to have an what you call timetable, whether the eruption sequence is happening properly or not, because that is one of the indicator of future malocclusion. So if if there is premature exfoliation of primary teeth or delayed exfoliation of the primary teeth, it is suggestive of future malocclusion. So you need to monitor that. And even the occlusal equilibrium, you have to see mesial step, distal step, flush terminal plane, whether it is maintained or not. If there is early mesial shift, all those details you have to write here. Maintenance of tooth shedding timetable, as I told you. Management of ankylosed teeth. This usually, if the patient comes to you with a missing teeth, when you go for an OPG, you will come across with this ankylosed teeth or impacted teeth or supernumerary teeth. So these things has to be taken care of prior so that the future complication doesn't occur. Also abnormal frenal attachments, high frenal attachments, there is always a possibility that will be spacing. Main thing, doing the oral habits checkup. Most of the parents will not, they feel it is okay. But you need to tell till what age these oral habits are okay. Like for example, if it is a thumb sucking habit, then most of the times they will be neglecting mouth breathing habit. They feel that because he is having common cold, he is breathing through the mouth, it will be okay. But how long? Means till the morphology changes, they will be waiting. And once, if they look odd, they will come to the practitioner. So coming to space maintenance, if there is premature loss of primary teeth, yes, you need to go for space maintenance. So finally, you need to conclude giving a remark saying that these are the things which you have to taken care in case of preventive orthodontics. And the key here is one has to go to a dentist quite often. Generally, most of the time we just check for the carious teeth. We don't bother about the teeth eruption sequence or the alignment of the teeth. You need to have a keen observation, the eruption pattern, and it gives a main clue. And also you should be aware of the jaw growth also. You have to not only dental but also the skeletal system. So the second question is, what do you mean by interceptive orthodontic? Discuss various procedures that are undertaken under interceptive orthodontic. This is a straightforward question. So here, same thing, definition of interceptive orthodontics, serial extractions, what are the indications of serial extractions? You know what are the serial extraction indications, right? So the basic idea is, if it is a class 1 condition with severe crowding, ideally you have to go for a sequential extraction of the primary and the permanent tooth, enucleation of the permanent tooth, so that the proper alignment takes place. Yes, you should be aware of the consequences or limitations of serial extractions also. And second thing, it may be space regaining procedure. In what all conditions? Usually, if there is premature loss of primary teeth and there is space loss, and to accommodate the newly erupting permanent teeth, you need to go for space regaining procedures. Don't write what all space regainers you have in the market, how it works, all those things. Here, they want it as a superficially, you just need to mention that. Crossbites, it may be dental or skeletal, you have to write the consequences and also how to manage that. Even open bite, what are the reasons, what are the problems you come across in case of open bite and how to manage that. And control of oral, abnormal oral habits. It may not be thumb sucking, mouth breathing or tongue thrusting. It may be bruxism also. It may be self-inflicting injuries also. You need to check all those things. So, keen observation, examination of the patient, not just for carious regions, for all other abnormalities in the skeletal and dental system has to be taken care of. Simple myotherapy exercise will reduce the possibility of future complications. And most of the times, if there is any skeletal discrepancy, you need to check. Every patient is a patient for myofunctional appliance. I'm a good fan of twin block. So there will be tremendous improvement if you give twin block, except for horizontal grower, vertical growers. It will be very nice if you give twin block. And the basic here is you have to know what is VTO. I think most of you know what is visual treatment objective. So if you know that, you can have a better idea how the skeletal system works. So this is the third question. In the end of my presentation, I'll give you a QR code. You can just check in that. I have put up a good number of articles. Landmark studies are there. New recent journals articles are there. You can download directly. And there are multiple questions that have been collected from different universities. You can check out all those things. In the last slide, it is there. I'll show it to you. Meanwhile, this is management of lower anterior crowding in mixed dentition stage. This is the question. It may be 10 marks or 25 marks question also. This is a big clue. See, not to forget my friend Dr. Joby Peter. All through the corona period, he was bombarding with the lectures on online dentistry. And he was mentioning, always he used to show one slide with crowded lower anterior teeth. What will be your line of treatment? Do you think it is self-correcting or it is going to go, do you require any orthodontic treatment? So I didn't put this slide actually for that, but still, you just find out the etiology. You have to write the etiology, possible etiology. One is narrow arch palate, maxillary constriction will cause lower anterior crowding, altered eruption sequence, premature loss of primary teeth, delayed eruption of the permanent teeth, and if there is tooth size variation, jaw side tooth size discrepancy is there, there is a possibility, and almost having habits. Also, these are the possible etiology for lower anterior crowding. So there are different methods of assessing the crowding. I think most of you will be knowing arch perimeter analysis and Boltell's analysis. So even the caries lower arch perimeter analysis will also help you in diagnosing the disparity or the amount of tooth size variation that is seen when compared to the skeletal system. So whenever you are going with the management, there are certain things we have to keep in mind. There are the general principles of management. The first one is whether the patient is in a transitional stage, whether it is self-correcting or you need to correct. So waiting period is there. You cannot rush up doing the treatment for this condition. And also, second thing is, after doing the analysis, you have to decide whether the discrepancy is minimal, or what we call MMS is nothing but mild, moderate, and severe. Depending on the severity of the condition, you can initiate the treatment procedures. And assessing the growth potential of the individual, how you will do it? Hand wrist radiograph. Okay, you can opt an easy one. Hand wrist is, I feel, a little bit difficult for me personally. I always follow CVMI. Or the simplest is, what is this? This is MP3, okay? So, middle phalange, okay? So, treatment options generally depends upon the severity of the condition. Most of the times, if the discrepancy is 1 mm, you can leave it like that. If it is up to 2 mm, you can consider or think of doing a proximal stripping. And if it is more than that, I mean, like more than 3 to 4 mm, you may have to, if it is in mixed dentition period, you have to think about serial extractions. Or if this condition is quite severe, that is more than 7 mm, usually we go for extraction of the first or second premolar. So that we have to decide depending upon the severity of the condition and also the stage of development. So that's how you have to write the question. So we'll go for the 50 marks question. This is my favorite question. I have, I don't think I should mention here, but I have given question paper to one of the South Indian states, and this was another essay I have given. I don't know when it will come. So this is the role of pediatric dentist in management of sleep disordered breathing. Just to give a twist, okay? So sleep disordered breathing. when there is lack of sleep because of difficulty in breathing, this patient is having a problem. Usually, it is nothing but OSA. If it is in pediatric dentistry, we call it as POSA, pediatric obstructive sleep apnea. So, just a twist in the question. Only thing is, one has to differentiate where is the origin of this problem. So, the first one is when you say introduction, I mean to say what is the role of a pediatric dentist here in assessing these patients. Because the kids will be coming to the dental operatory and they will be quite sleepy and they will not interact much with you. They will not have eye-to-eye contact or they will not respond to your questionnaire. So it is one of the suggestive features that he may be apprehensive or he may be having this breathing problem. So next one is you have to ask the mother whether there is any sounds when he is sleeping, whether he is having sound sleep or not, is there any disturbed sleep. All those things you have to ask when during the clinical examination. So when you are writing this, yes, you have to define the terms apnea, then what is sleep apnea, then what is obstructive sleep apnea and what is pediatric obstructive sleep apnea. And what are these factors that are affecting sleep and breathing patterns? You tell me how many stay in hostel? All stay from, come from the home or someone is staying in the hostel. So how much time you spend with your deadly mobile, the bomb of the decade, all because of Ambani, Karlo Dinia Muttime, he has given a handful of mobile in our hand. So people will be spending a lot of time. Screen time is one of the reasons for disturbed sleep. And if I go and it is one more interesting topic of mine. If I just go into that, it takes a lot of time. But the basic thing is there are people, the reasons for increased sleep time. One is obesity. Obesity leads to increased sleep time because people will be watching and eating. So whether it is TV or mobile. So increased sleep time will disturb the sleep pattern and also they sleep late night and they will be inactive in the morning. So coming to this topic, this is the reason for this alteration in sleeping pattern could be lead to oral and facial skeletal system abnormalities. Usually it may be genetic or environmental, and most of the times it is because of the muscles. These muscles are responsible. You have to go and recollect the functional matrix theory by Melvin Moss. So if you remember, it works in tandem, skeletal system and the soft tissues. So the soft tissues plays an important role in causing these abnormalities. Did you come across any patient with obstructive sleep apnea during your post-graduation period? So I'll just see, means if you see these patients, you will be confused with mouth breathing habit. So mouth breathing is an initial stage. Worsened condition is obstructive sleep apnea. Generally, typical condition is the patient will have a blank face and most of the times they will have a retrognathic mandible. And see the features, it will be quite odd. They will be dull and inactive. Most of the times obese. And if you see the nostrils, it is smaller ones. Sometimes it may be DNS, deviated nasal septum will be there. And how many check the tonsils? Do you remember Malampati's classification? So this is then a prerequisite for assessing a patient before going for general anesthesia. Do anyone do the pre-anesthetic evaluation before sending the patient to general anesthesia? So the one of the criteria here is checking with the tonsillar the pharyngeal space. If there is narrowed pharyngeal space, is a possibility that the patient will have sleep apnea. High arch palate or narrow arch palate will cause the tongue will fall on the lower anteriors. Most of the times, the lower anteriors will be flared up. So these are the classical findings you come across. When you come across, when we talk about the behavioral pattern, behavior is most of the times the patient will not be cooperative, will be quite sluggish. They say obesity leads to obstructive sleep apnea and even the loosening of the neck muscles. Loosening of the neck muscles, the patients will have snoring. Most of the times the patient complaint means usually the tongue falls behind and it pressurizes on the wind tube, causing difficulty in breathing that leads to snoring. So these are, most of the times, mouth breathing is quite noisy. That's the reason why we ask the parent whether there is noisy breathing and is there any disturbed sleep. Sometimes it may be difficulty in breathing, like that they will be breathing. So there will be episodes of apnea. That means the carbon dioxide level increases and the patient will wake up suddenly. And most of the times because of that, there will be disturbed sleep. So, and finally they land up in obstructive sleep apnea. So all the findings I have mentioned in this, nightmares, bedwetting, anxiety behavior, poor school performance, stunted physical growth, all those things are the classical findings. I don't think these slides are clear. Okay. So most of the times, usually in sleep apnea cases, you come across a lot of malocclusion. This malocclusion is mostly because of the narrow airway. Because of the narrow airway, they will have this mouth breathing initially, they will have difficulty in breathing, and finally it lands up in obstructive sleep apnea. And when most of the times, because of the malocclusion that you come across in these patients, there will be difficulty in having food, chewing, mastication, so the growth will be altered, physical growth also will be altered. Coming to the speech, usually as the teeth are irregular, their self-confidence will be poor, their phonetics will be bad. And lastly, aesthetics, yes, because of their poor appearance, they will be not confident about to move around with the people, and all these things once again land up in malocclusion. So there is a sequence of managing these conditions. So one is early diagnosis of the condition, let me know when I have to stop, okay? So early diagnosis is very important because when you diagnose the case properly, it is always, there is a bit confusion between mouth breathing and OSA. OSA is an extreme condition. So you may or may not come across these many cases in the clinical practice. But nowadays, the first indicator is obesity. So you generally check the BMI, height and weight you will be measuring once the child comes to the operatory. So just calculate the BMI, whether he falls into obese candidate or not. It is clue number 1. Clue number 2, history from the parent. 3, sleeping pattern. 4, the behavior in the dental operatory. 5, clinical examination. All these things will give you a clue whether the patient is going to sleep apnea or not. Then the best, easiest method is take a lateral cephalogram. See the airway. I think most of you know how to assess the upper airway and lower airway, the position of the hyoid bone. So the simple and easiest method or economical method is going with lateral cephalogram. And nowadays, there are studies which they are coming up with CBCT, and also the best diagnostic method is sleep test or polysomnography. Maybe we may not be able to do that. You have to refer it to an ENT person. But the easiest method to assess whether there is having difficulty in the airway pattern is lateral cephalogram. Then multidisciplinary approach. It is not that you only doing the whole procedure. You require the help of the speech therapist, you require help of an audiologist sometimes, you require the main output from the ENT person. All of us has to come in tandem and work in managing these patients. There are some appliances given by the lab people where just repositioning the mandible forward. The one reason is you can give a twin block also, but twin block works otherwise, but just the basic idea here is to put the mandible forward so that the tongue doesn't fall back. So in those conditions, appliance therapy is that one, or you can think about most of the times it will be a narrow maxillary arch. So you need to require, I am a good fan of Hyrax appliance also. So it works wonders, particularly in these patients. As the maxillary arch expands, usually it will be narrow maxillary arch. So when you expand the arch like this, as the arch expands, the nares or the nasal apertures also increases, and the breathing pattern will improve. So obviously, the breathing pattern improves, this condition will nullify. So even orofacial muscle exercises, lip exercises, or what do you call nasal breathing exercise should be initiated. And surgical intervention, yes, sometimes even what do you call doing surgery to the tongue, reducing the size of the tongue sometimes, even orthognathic procedures has to be initiated. So this concludes the 50 marks question. You need to write it little bit elaborately. There are good number of studies. All these studies have been, all the articles I have put up in the group. Means you can check it out in the ending. So, can I have some water? The next question is role of pediatric dentist in preventing and managing the development of malocclusion in children. It can be a 10 marks or a 25 marks question. The basic idea here is, read the question, role of pediatric dentist in preventing and managing the developing future malocclusion in children. So what is the role of a pediatric dentist? So first thing is early detection and monitoring the occlusal development. That means the eruption sequence, whether it is happening properly or not, by clinical examination or through radiographs, periodic radiographs. Generally, in other countries, usually they have periodic radiographic evaluation. But unfortunately, in our place, usually people will come only when they have problem. So even having dental models will give a better idea of the eruption sequence that is happening. The basic idea is we are not going to handle only the primary teeth. We will be monitoring because we have the choice of 0 to 14 years is our domain. So we will be handling primary teeth, mixed dentition stage, and also the permanent dentition stage. So except for the third molars, we will be monitoring all the teeth, right? So this is the occlusal development, how it is taking place. I'm not going into the development of occlusion, the different stages. That is, all those stages you don't require to mention here, but I just need to mention what all things you are going to do as a pediatric dentist. Second thing is preventive and interceptive interventions, what you are going to do. So first thing is detecting early and identifying the problem early so that you can intervene the condition prior. That's the basic idea. So whether it is an oral habit or a space loss. So the basic idea is to monitor. We are just like a monitoring batch. So sometimes I feel if we as a periodontist monitor the teeth and also the skeletal system till adolescence, I don't think ortho people will have much of work. Unfortunately, patient doesn't come, not to curse the department of ortho, they are ready to screen the children right from the age of 6 years. Even if you see the IOC website, they have given that early detection of the child as early as 6 years for orthodontic evaluation. There is a lot of controversy between early, late, and late orthodontics. I don't want to go into details of that, but at least we as a periodontist should have the privilege of examining the patients and identifying the problems prior, not only dental, but also the skeletal system. And to be frank, when we studied way back, when I think most of you are not born also, 1999, I have completed my post-graduation. So during that time, that means I have done from 97 to 99. For us, 2 years only that time. So fortunate enough, you have 3 years to learn. So that time, maximum thing what we used to do is giving an habit-breaking appliance or a space maintainer. And I'm happy and I'm proud of myself that I have learned most of things with my PGs. During our time, we used to do pulp therapy with stainless steel files. Now I am doing with rotary files, that's a different thing, but I learned with my PGs. So not only teaching the students, but we also learn a lot. So it's not that one way, it is learning is a continuous process. So coming to the third one, space maintenance and guiding of eruption of the teeth. That is, if there is any premature loss of the teeth. Only thing is, I have just elaborated the headings so that for a 10 marks question, what all things you have to write. So the red headings are for the, what I call, you can elaborate on those points. And management of harmful oral habits. Main thing here is, most of the parents, as I was discussing prior, the parents will not know whether the condition is severe or not. You need to counsel the patient. Whether it is an functional appliance, an orthopedic appliance, all these things you have to counsel the parent. That is the big issue here. And timely managing the condition, and if the condition is severe enough, you have to send it to a pediatrician or an endocrinologist or sometimes an orthodontist or an ENT person. According to timely referral is important, because growth pattern means you cannot wait till the growth completes. So you need to evaluate in between. Most importantly, having a good rapport when you have discussed all the problems and monitor the patient time to time. No need to take photographs, all the presentation I am giving it to you. Just listen, means if you can. Okay, everything is there in one shot. You can take a photograph. I don't require to present, but still, okay. It's self-explanatory. I just want to, with zeal I am doing it. So parent and child education, with a good rapport, the concept of dental home, there is a possibility of a short notes. If myself and my boss, Shivakumar sir, is there, the common question is anticipatory guidance and dental home will be a question, short. So having a good rapport with the full family and knowing their health problems and monitoring them periodically will have a good rapport with them. And holistic benefit of early intervention has to be given. So just to summarize what all things, early detection of the condition, initiating interceptive and preventive orthodontics, space guidance and habit breaking management, and also referral and collaboration with other departments and patient education. These are the key points which you have to write when the role of a periodontist is given in preventive and managing dental developmental, managing the development of malocclusion in children. So the next question, once time is off, you tell me. There are a good number of questions. They will be tired of listening to it. So discuss various mixed dentition analysis. Critically evaluate the various systems of mixed dentition arch analysis. So it is a bit twisty, but just be confident what you are writing. And discuss the applicability of various mixed dentition analysis, or a straightforward question, mixed dentition analysis. So first thing is, if it is a 25 marks question, then you have to write the purpose of doing mixed dentition analysis. then what are the basic ornamentarium that you require, and also the principles of space analysis, that is, the space is less or space is more, or that means you require space or the space is sufficient enough, or what are the expected changes that you are coming across with this individual. Then there are different methods of evaluating the mixed dentition analysis. It may be dental cost radiographs or both. And when you talk about different mixed dentition analysis, if you are doing it on the CAS, if you are doing it on the radiographs or in combination, these are good number of mixed dentition analysis you come across. All the journals, at least in a year, 2 or 3 articles will come regarding applicability of so and so Moyer's analysis, Tanaka-Johnson's analysis, 600-year-old father in population of Guntur or Chennai or Tamil Nadu, wherever it is. So usually these are good number of studies, but the red ones, Tanaka-Johnson, Moyer's analysis, Nance analysis, 600-year-old father, and Hakuba analysis are the common things are of acceptance. And also, when you are writing about each of these, you need to describe each method, the interpretations, that means how you calculate that, and finally, the limitations of each of those. So that completes the 25 marks question. These are a good number of studies. You have, you can find at least reliability, acceptability, all those things, applicability. These are the 3 common terms used for mixed dentition analysis. Every college, every person will have 1 or 2 presentations on their name. So this is the next question. This is management of space in developing dentition. It's a tricky question, right? Developing dentition. So coming to this, you will be discussing under these headings, that is introduction. You need to write development of dentition, the what you call development of dentition, and also write down the eruption sequence and eruption dates, also chronology, and what is the premature loss of primary teeth, what all discrepancies you come across if there is premature loss of primary teeth, and the amount of malocclusion that can happen. These all points can be written in the introductory part. Coming to the importance of space management, once again, maintaining the arch integrity, guiding the permanent teeth into proper occlusion, and also avoiding complex orthodontic treatment thereafter. So etiology can be hereditary or environmental, or development will be from primary, mixed and permanent dentition, and also the eruption sequence. How do you diagnose this condition? Doing space analysis and classifying the crowding depending upon the Bolton's analysis, what you are doing the tooth size discrepancy. Then clinical considerations depends upon the age and development of developing stage of the child and amount of space loss, and also cooperative levels of the child and the, I wrote the other word, parents. This is a big thing. They think that inka time undi kada, oh, I should not talk in Telugu. Okay. Generally they say still time is there. We went to the other doctor. He said all permanent teeth didn't come. So I think it comes at around 14 years. That stigma is there. 14 years you should go for an teeth evaluation for correction of the teeth. So that has to be broken. And management strategies, it is space maintenance, space regaining procedures, utilizing the leeway space appropriately, and relieving the crowding time to time. So these are the points. Questions, all these things are there in that. So next question is, discuss the management of anti-crossbite in primary and mixed dentition period. So once again, this is a straightforward question. You need to write what is the definition of crossbite. Then what is the rationale of early intervention? What happens if it is not intervened prior? Usually what happens? If a single tooth crossbite is not correct, what happens? It may cause, if it is a single tooth, it may cause what I call resorption of the ulnar bone, or what is gingival repositioning, or sometimes the attrition of the teeth, or sometimes the sequence will be so severe that the mandibular growth will be stunted sometimes. So those things has to be written in a brief manner. Then classification, it may be skeletal or dental, or it may be a pseudo crossbite. So it may be anterior or posterior also, but as we are discussing here, anterior crossbite. So diagnosis will be clinical examination. It will be checking the number of teeth, inclination, crowding, midline discrepancies. Midline discrepancy, this is an important point. You have to check whether the midline is shift or not. So it will give you a clue. Then study model analysis, radiographs, OPG, lateral cephalogram. Management of the primary dentition is basically eliminating or extracting any supernumerary teeth or over-retained teeth or abnormally sized tooth. Posterior teeth will cause lower anterior crowding. So management in mixed dentition stages, managing dental crossbites. So the simple one, if it is in a developing stage, it is to tongue blade therapy or using a Z spring, or you can think about if the teeth are erupted, the anteriors are erupted and the molars are erupted, you can think about 2x4 appliance also. When it is a skeletal condition, yes, it is, if there is retrognathic maxilla, it is face mask, reverse headgear, and my favorite thing, rapid maxillary expansion appliance. And for mandibular excess, it may be chin cup and functional appliance, Frankel's appliance. And nowadays, Invisalign company has come up with one of the idea of expanding the arches if there is maxillary deficiency, the recent advancement, which is they come up with an appliance where you give an Invisalign aligner, which will help you in palatal expansion. So the next question is growth spurts and their role in interceptive orthodontics in children. Yeah, more. Okay. Which slide it is? Oh, I'm just halfway around. Okay. So, coming to introduction, there is a defined growth, factors affecting growth and development. I don't want to go into details of this. You know the growth spurts, 3 different growth spurts, pre-pubertal, pubertal, and post-pubertal. And how do you assess that? Clinical indicators of growth spurts is most of the times age estimation, you know, right? So age estimation, the best ideal thing is going with skeletal age assessment rather than dental or chronological. So CVMI, hand wrist radiographs or MP3 radiographs or secondary sexual characters in children. So these are the treatment options. If it is skeletal growth development, means whether you have to manage it early or late, it depends upon the condition of the patient. And usually orthodontic treatment planning usually use growth spurts accordingly and give myofunctional appliances. This will work wonders for the patient. And the limitations of these growth spurts is usually the growth varies from individual to individual. Gender differentiation in timing. So appropriate all the guidelines what we are taking, CVMI or MP3 or hand wrist radiographs, are predictions only. It's not the same. And patient compliance issue because you are going in an younger age individuals. And sometimes the patient will miss out with the treatment procedure and land up in a worsened condition. I think this regarding myofunctional appliance, classify in detail various appliances used in preventive orthodontics and write in detail the rationale and importance of myofunctional appliances. So if this is the question, what you will write? Classify various appliances used in pediatric preventive orthodontics. Okay, the appliance you have seen in this slide. Write in detail the rationale and importance of myofunctional appliances. What is the rationale behind myofunctional appliance? How it works? Only mandible? We'll discuss. It has dual action both on the skeletal, dental, and also the soft tissue. So it is a combination effect that is happening. The outcome will be not only on the skeletal, not only on the dental, but the final thing is also on the soft tissue. So when you are managing these patients for myofunctional appliances, most of the times you expect these three changes to occur. So when you say classification of myofunctional appliance, it may be passive appliance or an active appliance. My favorite twin block is there in the active appliance. Herbs appliance works when the growth is about to cease. It's a fixed appliance. Herbs appliance works wonders. I don't feel like giving these functional appliances, the Frankel's functional regulator, they say 1, 2, 3, just for demonstration it's fine, but patient compliance is very, very poor. You can go with actuator and bionator. Bionator is also a little bit tough, but the best thing is the active appliances, twin block. So it may be tooth-borne or a tissue-borne, fixed or removable ones. So what are the effects? We are talking about the effects, right? Orthopedic effect, that means on the skeletal system. Dentoalveolar effect, that is on the teeth. And myodynamic effect is on the soft tissues. So it improves the profile of the patient, the lip contour. So ultimately, the profile of the individual improves when you are handling the patient in a growth period. So that is the reason I am mentioning the appropriate timing of the treatment is important. We'll skip this. So coming to the limitations of these myofunctional appliances, the growth, as this is more growth dependent, so appropriate timing, as I told you. Compliance, the patient has to wear it a longer duration. Initially, what is this Mester effect? Did you use any of you given twin block during your PG curriculum? Twin block. So generally, when the patients start wearing, the Mester muscle will stretch. So obviously, the patient will have pain. When the patient comes for the first visit, you can always check for the Mester muscle activity. Usually, if the patient is not wearing it, the patient will not complain of any pain. So whether you can know whether the patient is using it or lying. So that's one method of assessing. And another thing is, once they start wearing it, they cannot reposition the mandible previously how they have done it. So it moves forward. So it is just like stretching the mandible forward. So there will be deposition of the bone on the posterior aspect and repositioning of the muscles takes place. So I'll skip this. So this is one rare question. Discuss various diagnostic aids used for management of orthodontic problems in children and adolescents. So we'll just run down fast. This is the clinical examination. It will be extraoral or intraoral examination. It will be on the study models also. What are the advantages? All those things I have given in the slides. You can read afterwards. The photographs, intraoral and extraoral photographs. These are all things what you do in the regular protocol when you are managing a patient orthodontic, preventive and interceptive orthodontic procedures when you are carrying out in the department. These are the protocols you have to follow. The radiographs, the best thing is OPG to find out any abnormalities or any anomalies in the teeth. Lateral cephalogram, airway space assessment, and also the class 1, class 2, class 3 relationship. Bite wing and periapical to assess the caries status. Cone beam CT to find out once again the airway assessment. And the cephalometric analysis, usually the Stenner's analysis, Ricketts tweets, these three are the common ones we come across when we are going with mixed dentition period. Growth assessment with hand-wrist radiographs and CVM. Space analysis, it will be Moyers or Tanaka Johnson. Tooth size analysis, it is Bontel's analysis. And habit analysis is nothing but the the mouth mirror test or the mirror test or the water holding test what we do, the chair side, these are the habit analysis tools. And nowadays, we are not going with impressions. Nowadays, 3D intraoral scanners are there to give you the impressions of the patients. So this is the nutshell. You can read afterwards. Time is not there. So one more question. I think I'll wind up with this. Discuss the pathophysiology and diagnosis of mouth breathing habit. I think yesterday Daya madam has given a good explanation of the oral habits. I was listening online in my place. So she has given a good presentation. So management of the condition she would have explained, but I just briefly, pathophysiology of mouth breathing, what is the etiological factors, whether it is obstructive, whether it is habitual. So you have to write regarding that. A diagnosis of the mouth breathing habit, that is clinical examination, physical examination, case history and physical examination, and effect of orofacial complex, what all effects you see, skeletal and dental abnormalities, or the functional consequences you come across. And finally, the management of different mouth breathing condition, whether it is medical management, surgical management, or sometimes it may be pharmacological management. Pharmacological management is because of if there is any history of allergies that has to be corrected. Then surgical management, it may be DNS also, it may be appliance therapy. Thereafter, means if it is habitual, myofunctional appliances, and different treatment stages are there for that. And finally, orthodontic appliance it may be, and sometimes multidisciplinary approach is required. So, this is a rare odd 10 marks question that is trickily asked as orofacial myofunctional disorders or soft tissue disorders. It's a tricky question, right? So generally they ask orofacial myofunctional disorders. So myo means muscle, function of the muscle is altered in the orofacial region. So what is the reason? Because nowadays everyone are using cooked food. So hardly just put it in the mouth, you can just swallow. Increased feeding habit, usage of pacifiers, seeing the screen time means they are busy seeing the screens and they eat, gobble whatever they eat. And mouth breathing, oral restrictions, and also skeletal and soft tissue dysfunctions will lead to this. There's a nice article that is in an American Journal of Orthodontics, 3 M's that are responsible for malocclusion. Muscles malformation and malocclusion. I think this article is also there in the sequence. So this is another 10 marks question, very rarely asked. Study models, how to prepare this. What is the definition of study models? What is the purpose of study models? What are the ideal requisites? And how do you construct the study models? Part of a study model and uses of study model, methods of disinfection and storage, and recent advancements is just scanning. Okay, with all this, I just want to say there is no shortcut for success, so you need to work hard. It's hard to say that in the last minute we are saying you need to work hard. It is the first class which we have to say when you join as a PGs. It's not just a cakewalk, so you need to learn things because nowadays patients are Google patients, so whatever terminology you use, even before you, they will do the Google thing, and if it is impacted, whatever term you use, they just check it, and they will answer you back. So that is the reason why you are supposed to know the theory properly. You should have the habit of examining the patient properly, and when it comes to the exam point of view, all the best, write your exam properly. Hope to see you in future ISPPD conferences as faculty or good practitioners outside. And my regards to my big boss, Navala Sukumar. He is the backbone of my confidence. Whenever I talk, whenever he is my guide who gave me the chance to for public appearances and also for my publications. Deepa, MJ, Mahesh, Jiva, each one of you. I feel coming to my home place, coming to Saveetha. And thanks to the contribution by all my faculty members. So this is the QR code. You can take a photograph. And one bonus is there for you. One Word document is there on chair side Viva voice questions during your PG exam. This is a few of the things which I have compiled. The PPT, the present PPT, and also few more answers have been deliberated there. Question from different universities on this topic, and something around 70 to 80 articles are there for your reference. You can pass it on to your juniors also. Thank you. Hope I didn't overshoot the time, but the topic is so vast that I have to constrain myself. If I start talking about all the aspects of preventive and interceptive, it takes a day or two.
Thank you so much, sir, for an insightful and inspiring lecture. Now I'd like to invite Dr. Mahesh to come and give a token of appreciation to sir. Moving forward, we'll break for tea now. Tea is being served on the left side. Thank you.
Moving on, we are honored to welcome Dr. Pallavi, Associate Professor in the Department of Pediatric and Preventive Dentistry at Krishna Devaraya College of Dental Sciences and Hospital, Bangalore. She completed her BDS from Rajarajeshwari Dental College, Bangalore, and her MDS in Pediatric Dentistry from AECS Maruti Dental College. Dr. Pallavi is a senior consultant in exclusive pediatric dentistry at NABH Accredited Confident Dental Care, Bangalore, where she routinely performs pediatric treatments under general anesthesia, conscious sedation, and chairside procedures. She is also a consultant pediatric dentist at the Center for Human Genetics, Bangalore, treating children with metabolic and genetic disorders, and was a key team member of multidisciplinary epidermolysis bullosa clinic. A recognized postgraduate guide under RGHS, she has been a guest speaker at national and international forums and has presented a series of notable papers on rare pediatric conditions and innovative caries removal methods. Dr. Pallavi is a
At the outset, I would like to thank Dr. Mahesh sir, Dr. Deepa ma'am, who graduated from our Saveetha Institute. At the outset, I did have an interaction with some of the postgraduate students here, asking them what kind of crowns they've given in their practice or what are they doing during the 3 years of their post-graduation course. My presentation today, I will try to answer most of the questions based on zirconia crowns, bioflex, Edelweiss, so that you have a clear outset of the questions that are going to be asked and what you need to answer during your Viva OC. I will limit my presentation to stainless steel crowns with the understanding that you would have all read Mathewson, which is the gold standard. Okay, so we shall begin the presentation with, this is my first slide. Before any presentation, I always have my gratitude to God, to parents, which we need to, and to the patients' parents who allowed us to learn on these children. Otherwise, it would have been so difficult for each one of us to pick up our skills. Looking at these kids, I started my practice with exclusive pediatric dentistry in 2011 at Confident Dental Care. As you all know, it's the manufacturers of the Confident Dental chairs who have a practice which is at the exclusive practice for me alone for pediatric dentistry, where we do all kind of treatments required for the children. Your answer on pediatric endodontics, if they ask you, what is the newer concepts on pediatric endodontics? Your answer will be incomplete if you do not write about crowns. How many of you, even if your mock examination, have thought of this, that if they ask you on endodontics, don't just limit yourself to pulp therapy, but your answer is complete only when you write about the crowns. Okay? So that is the first thing that you all should understand when you're understanding the topic. So how did practice change for me? When we started as a postgraduate student, I remember, we had only stainless steel crowns and strip crowns. Then it was the pedo jacket crowns that we got from Space Maintainer Laboratory, USA, so that we did a couple of research activities on those crowns as well. I found pedo jacket crowns to be better than strip crowns, but the only disadvantage was the jacket crowns were left over on the tooth surface. And you know, when it is left on the tooth surface, because of the composition what it had, the discoloration and wear and tear was evident. So then came the advancement with zirconia crowns. Patients as well as parents these days, like you can see the kid on the right hand corner, she was very particular that she has only aesthetic crowns in her mouth. So you can see the anteriors, we've used the zirconia crowns for 5'1", 5'2", 6'1", and 6'2". And then with practice, we did evolve to use Edelweiss and Bioflex crowns as well. So technology and innovation, as we can see in this institute, I want to say this, that students who have been studying in Saveetha Dental College, I can see a handful of you there. Can I have a raise of your hands? I think with technology and innovation, you guys are way ahead, very impressed with the way it is going. It is mandatory that we also, all of us, include this in our practice. So stainless steel crowns, you all know, are functional, durable, and cost-effective. However, they're least attractive to children and to parents because of the silver color of the metal. Then came the zirconia crowns, which are highly aesthetic. They are biocompatible, we all know. They're durable and functional. What is the disadvantage with these crowns is the higher cost that is there. So you know when you're practicing with zirconia crowns, we keep it a minimum average of about 10,000 per crown. So feasibility becomes an issue. And abrasiveness of zirconia can be considered a significant drawback. Commercially available zirconia crowns these days, you know, are the Cheng crowns, the EZ, the Kinder, the New Smile, as well as our Kids E crown, which is indigenously produced in our country. So currently the most active area in dentistry today is the CAD-CAM technology. How many of you have been exposed to using your CAD-CAM for crown fabrication? Any of you in your institutions? So what happens in our practice is we have an in-house milling unit that is there. And children who see those crowns being milled in the launch have come to me and asked me, why can't you do that for me today? Can't you do the milling of the crown and give it to me immediately, give it to us immediately? So that is when we started practicing CAD-CAM technology and doing the zirconia crowns. Then came the significant advancement with the hybrid materials that, you know, it is a combination of zirconia as well as your composite materials, yeah? So that's how technology advanced. This is a very basic classification. You can add many other classifications for your crowns. I would divide it as crowns that are luted onto the tooth surface and crowns that are bonded onto the tooth surface. So those which are luted on the tooth surface, you know, these are your resin veneered stainless steel. I haven't practiced this, to be honest with you guys. Facial cutout crowns, pedo pearls, yes. And crowns that are bonded onto the tooth surface. Which are these crowns which are bonded onto the tooth surface? You have your strip crowns, your jacket crowns, your new millennium art glass, polycarbonate crowns as well. When it comes to zirconia crowns, so let us start our discussion mainly on zirconia crowns. These are relatively recent in dentistry. Your Viva question, what is zirconia also referred to as? It is referred to as your ceramic steel. Okay, so it's a crystalline dioxide of zirconium, which is sometimes referred to as ceramic steel. So how did these zirconia crowns, how are they formed? They're basically formed by a single densely sintered block of crystals. EZ got about with the EZ crowns were the first zirconia crowns that were brought into the market. That was in the year 2008. Later on, companies like your New Smile, Kinder crowns, Signature crowns are available. The shape, size, color, pattern, and retention component varies among these prefabricated crowns. There is some amount of variation that each manufacturer brings about. We'll discuss that. And these are characterized by the absence of any components that could debond. That is why these are especially useful, because they are having highly polished surface, that's the glaze that you have, and they demonstrate less plaque accumulation than the materials which are used. So what is the composition of these zirconia crowns? These are the three brands that are generally available. You have your New Smile, EZ crowns, as well as your Kinder crowns. Can any of you tell me, you know the main component is zirconium oxide. Now what is this yttrium oxide? Why is it used? All of you have been exposed to zirconia crowns? Yeah. Have you bothered to find out the composition of the zirconia crowns? No? Can you tell me what is the role of yttrium oxide? No? Yeah. So please, you should know the composition of your crowns, very important. Your zirconia crowns, the New Smile crown has something known as the yttrium oxide. Zirconia oxide basically is an unstable compound. So when you add yttrium oxide, it gives the strength to the material and the durability of the material. That's the function of yttrium oxide. Now what is the role of hafnium oxide? Can you see the description? You can see that all the crowns have zirconium, yttrium, and hafnium. There are little variations with the other crowns with other things. You should know the composition of the crowns. So hafnium basically reduces the porosity in the crowns. Okay, and the need for colorful pigments is less when you add hafnium oxide. So it improves the aesthetics of the crowns. You should know this composition as well as what is the role of each of the things. There is a little bit of variation with the addition of boron and aluminum, sodium and potassium in Kinder crowns. Most commonly used crowns are your New Smile crowns. Can you see the picture of New Smile crowns? There are two images, one which is white and one which is pink. What is the pink color? Yeah, those are the trial crowns. Now, what is the difference? I said there are some properties which are of variation in the crowns. So what is that variation? Can you observe the new smile crown? Can you see any grooves in the new smile crown inner aspect? You don't have any grooves on the new smile crown, okay? Whereas you have grooves that are present on the inner occlusal aspect and the axial aspect of your zirconia crowns, which are the crind crowns. Can you see the grooves? Are they evident? On the axial aspect as well as on the occlusal aspect, right? And you can see the EZ crowns. Can you see the EZ crowns on the extreme end on the right side? The grooves, the distance between the grooves is of greater length as compared to the kinder crowns. So that is the major difference between these three crowns when it comes to the properties, okay? Color matching, of course, I feel new smile crowns are the best. Availability is also easy with new smile crowns. And the fact that you have the trial crowns makes it very clinically adaptive, okay? So shall I move to the next slide? You've understood that the presence of grooves makes the difference. What is the need for the grooves to be present? Retention. Okay. Now, indications for zirconia crowns. You all, when you structure your concept map, what you write in your examination, if you get crowns, each of your crowns should have in your concept map the general features, like how we describe the crowns. Then move on to what are the indications of the crowns. Indications, you all know, it is when multiple surfaces are affected, then you have post-pulp therapy, then you have fractured teeth, then you have in children who require general anesthetic procedures, and abutment as a space maintainer, and many such requirements, and also discolored primary teeth. Some of them come for aesthetic reasons as well as these days. Now, what is the preparation for these zirconia crowns? What comes to your mind when you speak of zirconia crowns? It's extensive preparation, and it is subgingival preparation. You should, in your answer, mark things which are of importance, okay? Most of the paper valuation these days are digitalized valuation. So nobody has the time to sit and read each point. It's always better if you mark, you use your clouds. I think yesterday in the introductory lecture on EGPG, Take It Easy, he did mention about the butterflies and the clouds and other things, which is of importance. As much as diagrammatic representations makes very good sense in any of the papers that are being used. It catches the attention of every examiner. So what is the preparation? Reduction in the incisal wall of around 1.5 to 2 mm or occlusal reduction of 2 mm. I'll show you the slide for the diagrammatic presentation. And it's a knife-edge subgingival preparation of 1 to 2 mm. So once the crown is selected, you can use any of your resin-modified GICs or calcium aluminate cements, and removal of your excess cement is the final step. So is it visible? You can see the dotted lines that are present on the crown surface. That indicates the amount of occlusal or incisal reduction that you need to do for your preparation. So it's, as I mentioned, is about 0.75 to 1.25 mm is your lingual reduction, and you have buccal reduction of about 0.5 to 1 mm or up to 1.5 mm you can do that. Incisal reduction, I would still limit it to about 1.5 mm and 2 mm on your occlusal reduction, okay? What are the drawbacks of these zirconia crowns? So we finished with the indications. Now we're moving on to the drawbacks. What are the potential drawbacks of the zirconia crown? Like I have highlighted the things, it's better you underline it in your answer script. So it is the additional tooth reduction. So dental professionals must prepare the teeth to fit the zirconia crowns. It's actually a passive fit for zirconia crowns. You know that. You cannot give an active fit. How many of you, while using the zirconia crowns, have experienced cracks on the tooth? Yeah, very much, correct. So it is because of your under preparation. Every crown preparation that requires a zirconia crown should be a passive fit. So you know the amount of tooth preparation has to be additional. Then as a result, primary teeth are getting these crowns need more preparation than teeth that are getting stainless steel crowns. The inability to crimp or contour the crown resulting in difficulty of adaptation. Because most of these crowns we know, we rely on the mechanical adaptation. So it's an inability in these crowns. And you have the potential drawback of the zirconia crowns is the difficulty of adjustment to provide mechanical retention in contrast to your stainless steel. The limitation of the shades. How many of you have experienced this? Yeah. So shade is another drawback. So, and also the prolonged procedure time. They also noted that in some cases there was pulp exposure and post-operative complications which were noted during the preparation of the zirconia crowns. Even when the variety of companies and aesthetic demands have been increasing in our country, still zirconia crowns are considered to be expensive. You know that the new smile crowns are way more expensive compared to our Kinduri crowns. So when compared to other alternatives, you need to write review of literature for every answer. So this is the review of literature for your zirconia crowns, dated from 2013 to 21. You can add the latest studies to it, which are all the studies I've indicated in the slides can be added to it. What did Janus et al. Say? They said that the force required to fracture stainless steel crown was greater than that compared to fracture a zirconia crown. So the fracture resistance is greater. Then you have Valia et al. In 2014 who said zirconia crowns are retentive, they're biocompatible, and they have low-grade abrasion. Then you have in 2015, Daniel et al. Said they are clinically appropriate restorations. New smile zirconia crowns demonstrated the best fracture resistance. That was said by Manar et al. Then you have Zing et al. Who said the retention force that prefabricated zirconia crowns is proportional to the occlusocervical height. Then, of course, stainless steel crowns require less tooth reduction than posterior zirconia. And when aesthetics is of prime concern, preformed zirconia crowns can be an option for the complete preparation restoration. And according to many studies conducted, we know that the parental and child satisfaction that was said by Hamra et al. Was acceptable in the primary maxillary regions. Whenever an answer for crowns is asked, you should be mentioning the primary outcomes and the secondary outcomes. That is the structure of your answer that should be there. Now, what is your primary outcome? Many of you fail to add this content in your text. You should be in your answer. You should have your primary outcomes and secondary outcomes. Your answer for any crown is not just the composition, indication, preparation. It is also, as a clinician, or a researcher, you want to know how the crowns are performing, right? So what are the primary outcomes of any crown? The first primary outcome is the absence of major clinical and radiographic failures. That is your pain, pulp infection, dental abscess, or periradicular pathology. When you are practicing over a period of time, you will start mind mapping it in your mind that which crowns are failing on an incidence of which are the obturations that were failing. Like that, you also start mapping yourself in practice as to which are the crowns that are failing. So that is your primary outcome. Primary outcomes are generally less if your endodontic procedure, your choice of the tooth, preparation, everything is perfect, then primary outcomes are very less. But your secondary outcomes are not in your hand, right? So what are these secondary outcomes? They are your retention, your fracture rates, the gingival condition, the wear of the antagonistic treated tooth, as well as the parental and child satisfaction. So I'll move on to the next slide. We will discuss about the secondary outcomes. So there was a study that was conducted on 272 new smile crowns, okay? And this study was basically to evaluate, it was a follow-up study to evaluate the clinical success rate. And they checked the gingival health, levels of plaque, the restoration failure, and marginal integrity. The basic reason why I have placed the try and correct with the zirconia crown images is, in this zirconia crowns, you have the advantage for a clinician is he can pick up the individual crowns whichever he wants, whether it's a first molar, second molar, canines, incisors, whichever is the tooth. What is the advantage? Why did this company come with the try and kit? What was the need for a try and kit? You don't want the contamination. You know the wettability of the crown. If there is moisture, then you know the adaptation of the cement becomes an issue. And bleeding, basically. That's another thing which can cause pigmentation over the aesthetics concern. That's the reason why the try-in crowns were established. I think most of us do need to have a try-in kit available. That will make practice even more successful. So let's move to the first thing. What do you see in this image? You see a zirconia crown on the lower mandibular molar, and you see another opposing tooth of the maxillary molar. You can see that the plaque accumulation or the staining is more on the maxillary molar when compared to the zirconia crown. Why does this happen? This is your Viva question. You need to answer this. The new smile prefabricated zirconia crown utilizes a proprietary injection molding technique, and it has hand polishing method. So what happens with this hand polishing method of the zirconia crown? It lowers the surface roughness. So RA is your surface roughness. It is about 2.8. And the mean gloss angle, okay? The gloss angle is about 42.7. So the glass angle will give you the definition for why it has the high polish on the surface, as a result of which why there is no plaque accumulation. Can you see this image? In the present study, they found that the traumatized teeth that were infra-occluded, see the right-hand image, that it was infra-occluded and restored with the zirconia crowns, they re-erupted along with the natural tooth spontaneously, suggesting a favorable prognosis. This is another additional point that you need to mention. Next comes the restoration failure. What is a restoration failure? In a crown, when you lose the crown en masse totally. So complete loss of crown was higher for the incisor crowns. When they did it for about 270 crowns, they found that the anterior crowns fractured more when compared to the posterior. Why was that? Because the posterior crowns have a larger surface area compared to your anterior incisor teeth. So in all cases, the restoration failure happened at the crown to teeth interface and not to the cement to crown interface. So what do you mean by crown to teeth interface? The entire crown came out fractured completely. But you did not see cement to crown interface. That means there's no luting cement that is left on the crown and only the crown getting dislodged. That did not happen. That's the advantage with these zirconia crowns after debonding it. Then you find the marginal integrity. So we finished gingival health, that is plaque accumulation. Then we spoke of loss of restoration. That's the second parameter for your secondary outcome. Now the third parameter that we are going to talk here is your marginal integrity. Very important. When you placed your zirconia crowns, over a period of time, have you evaluated the crowns? When they come up for a follow-up or any other incidents of caries or for a follow-up visit, they found that there was a marginal vertical gap between the restoration and the prepared tooth abutment. It is clinically visible. Can you see what is the image? So that is what they found. So the minimal vertical gap was found in these new smile zirconia crowns compared to the other crowns. So this is a meta-analysis. Any answer, your essay answers are incomplete if you do not place your meta-analysis in your answers. I think those of you in Saveetha, you have a paper for that particularly. So this is one of the meta-analysis where a total of 5 studies were included in the review. I think the font size is very small. You can take down the referencing that is there and go back and read the article. They found that the count of Streptococcus mutans was considerably less with the pre-veneered crowns compared with the stainless steel crown. The count of Streptococcus mutants and lactobacilli, again lesser, was written by Walk et al. And then you have Matthew et al. Also speaking about the zirconia crowns where there was a lesser count of the Streptococcus mutants. And so basically what did the study infer? The meta-analysis revealed a statistically significant difference in the microbial adhesion between your aesthetic and the SSCs, with aesthetic crowns showing lower levels of bacterial colonization. Specifically, the main difference was in the colony forming units. So as I said, lower microbial adhesion compared to SSCs suggests a potential advantage in reducing the risk for secondary caries as well as microbial related complications. Okay. Now we finished marginal integrity, we finished bacterial adhesion. Now we are moving on to the most important parameter, that is your wear resistance. Very important for any zirconia crown. The objective of this study was they compared stainless steel crowns, they compared the new smile zirconia crown, CAD-CAM technology zirconia crowns, as well as the hybrid crowns. So in this study, what did they find was they wanted to evaluate the wear resistance along with zirconia crown, along with stainless steel crowns being the control group. So compared with stainless steel crowns, the aesthetic crowns induce more wear of the antagonistic primary enamel. CAD-CAM zirconia crowns, what is the inference of this study? Is that the CAD-CAM zirconia crowns induce the greatest amount of wear, followed by the new smile zirconia crowns. The CAD-CAM hybrid crowns, however, is an aesthetic tooth colored crown that causes less wear of the opposing enamel than zirconia crowns do. Why is it? What is the reason for the hybrid crowns? Anybody? Why does it cause less wear resistance, the hybrid crowns? Have you used any of the hybrid crowns? You would have used your Bioflex crown, right? What do you observe on the surface? A dimple. That's what it's called. So that is the reason why the wear resistance is lesser. So do you understand how you need to structure your answer? You need to write the primary outcomes as well as the secondary outcomes. How did they evaluate the wear resistance? So you can see this image which is on the extreme right hand corner. Can you note that the mesiopalatal cusp of the maxillary second molar is taken into consideration? So one tooth is taken into consideration. What did they do? To assess the wear of the natural enamel of the antagonistic primary molars, they took the images like a scan, intraoral scan at cementation, 6 months, and after 1 year after cementation. They compared the images. What did they do? They compared the images. The software of the scanner was transformed into the tessellation. Yeah, the software of the scanner was transformed into a standard tessellation language, that is the STL file, which produces a 3D image. So both the 3D images, what is present at the time of placement along with your 6 months is compared. And then it's the ExoCAD software was used to measure the height of the cusp tip, which was worn off. So they take one tooth for comparison, and they check that the wear resistance was higher in case of the zirconia crowns. So do you understand the procedure, how it is done? It's an intraoral scanner. Now you know how technology has advanced. Once you take the intraoral scan, you do it as a comparative. You take one tooth as a parameter. Here they've taken, you can see the image, the mesiopalatal cusp of the maxillary, second molar was taken into consideration, and they observed the wear of the tooth. Okay? So the next parameter is your aging and fracture resistance. Very important. Many of you, when asked in the Viva as to what is the fracture resistance of the zirconia crowns compared to your stainless steel crowns, failed to answer because you are not aware of the fracture resistance and the classification. So what is the purpose of me quoting this article is, Ogas et al., what did he do? He compared the fracture resistance and survival of various aesthetic primary molars, crowns which were given for primary molars, after artificial aging via a chewing stimulation. How did they bring about this chewing simulation? It's a typhodon tooth was prepared to receive 5 of these different crowns. What were the 5 crowns? The fiberglass crowns, zirconia crowns, CAD-CAM, zirconia crown, the CAD-CAM resin ceramic crowns, composite strip crowns, that is written as CS, and the prefabricated zirconia crowns. What did they do? They subjected it to 750,000 cycles of thermomechanical loading to artificially induce 3 years of wear and tear. Correct? For the clinical service. Strip crowns did not survive at all, so it was a failure. So what were the other crowns? The surviving crowns were evaluated via micro-CT, and they evaluated the micro-crack formation. I will give you the fracture classification. You should memorize this fracture classification. Can you see the first diagram? These are the cracks. This is Ogas classification. You should know your fracture classification, the different types of fracture that are present. How was it evaluated? Again, by your software. So what did they see? They found that the cracks that are not visible to the naked eye was found under a stereo microscope, that is the class 1. The type 2 is visible cracks that are present on unseparated margins. That is your type 2, the left side images. Can you see the type 3 image where there is a longer fracture line, that there are cracks that are present on separated margins? Then you have class 4 where you have crown fractures that are less than half of the crown displaced. Can you see the image on the right side? You don't have the crown that is displaced. The second diagram here, what you can see that there is crown fracture that is more than half of the crown displaced with the supporting structure still intact. Then your last image is your crown fracture involving the supporting structures. So we evaluated from the recap that I'm going to do. We did microbial adhesion, then we did wear resistance, then we did fracture, loss of restoration, as well as marginal integrity. Okay, so that completes your answer for your zirconia crowns, as well as the primary, as well as the secondary outcomes. Okay, so now I'm moving on to the next crown, that is your bioflex crowns. Can you just raise your hands? How many of you have done bioflex crowns? Most of you, I understand, have done bioflex crowns. Recent advancement, what are these crowns? Compared to other crowns, what is this bioflex? It's a biocompatible hybrid resin polymer. So what is it made up of? They are metal and bisphenol A glyceryl methacrylate free. They are fiberglass reinforced composite crowns. Okay. So bioflex crowns offer a flex fit, very important. You require less tooth preparation, and they can also withstand to high loads and exhibit more resistance to fracture than do zirconia crowns. So why have I put this diagram? If in your exam you just place this diagram, the examiner understands that you know the complete in and out of your bioflex. Its self-adaptive technology allows the crown to modify in areas of slight high occlusion. That's your first pointer. Radio opacity of 1 mm, that is, it permits evaluation of the crown margin and pulp capping materials. Where is the radio opacity present? At the margins, right? About 1 mm. Laser marking on the inner occlusal aspect, that is for easy identification and optimal aesthetics. So you don't have the crown size present outside. Then you have a strong yet flexible for easy placement and a snug active fit. Then you have sandblasted Intellego surface for enhanced retention for the resin modified glass ionomer cements, and can be seated using a bite stick and trimmed if necessary with crown and bridge scissors. That's the most important advantage. So your diagram is self-explanatory. If you just put the points, it's easy for us to read and easier for you people to answer also. So this is your for your easy understanding, you have, it's a snug fit or an active fit, distinctly flexible and versatile nature for easy placement. Then you have chair time. The tooth preparation and handling properties are very similar to SSC, saving valuable chair time as compared to your zirconia. It's not recommended for Hall technique, very important. You should know this. Not indicated for bruxism or manipulation by crimping, not allowed. Why is the manipulation for crimping not allowed? We just spoke of the 1 mm margin that is present. Durability, wear resistance of Bioflex crown is similar to or better than traditional SSCs. Self-adaptive technology, rather than wearing off, Bioflex has self-adapt technology where a dimple is found in areas of high occlusion. So color stable, stain resistant with no visible discoloration after or greater than 1 year, intraorally or when placed opposing SSCs. So again, when it comes to wear resistance, you should mention secondary outcomes. So other things being the same, I'll speak about Bioflex particularly. When it was subjected to 800,000 cycles of wear testing at 80 newtons, what did you find? That you found a dimple present. Okay, so it is much better than SSCs. Aesthetics, new era, metal-free, monochromatic tooth-colored crowns made of a completely biocompatible material, and it can mask the arrested caries. Biocompatible material, again, bisgamma-free and contains no metal. Aesthetic laser marking on the inner occlusal surface for easy identification and optimal aesthetics. So you can see the identification of the tooth that is present. Another advantage of this Bioflex is the presence of Bioflex narrow, which is not there in other crowns. What is the advantage of this Bioflex narrow? It is ideal for space loss cases. So 0.75 mm more narrow mesiodistal width than the regular Bioflex is your Bioflex narrow. And first primary molars are available in narrow for first primary molars only. So cementation, enhanced cementation, I would always vouch for resin modified glass ionomer and GIC luting cements available with your Kitac. And it should be sufficient for cementing the Bioflex. Why is a light cured cement not recommended? Can anybody answer that? Yeah, the opacity of the crown does not permit the light cure unit for using the light cure cement. So these are some of the clinical cases that you see. You can see the dimple formation on the occlusal aspect. You can see some of the incisor crowns that are So again, for your Viva OC, I've made it simple. What material is Bioflex made of? You know, it is a resin, hybrid resin polymer, which is high impact biocompatible material, high strength, flexibility. Can we crimp, contour and trim the crowns? You cannot crimp. I saw somebody nodding. Yeah. Crimping is not allowed, but you should not attempt to crimp Bioflex crowns, but you can contour it with your hoe pliers, trying to make it narrow, especially when you're using it adjacent to your permanent molars, right? So how do we describe the fit of Bioflex crowns? It's a snap fit or nor a passive fit. What is it then? It's a slight resistance that can be described as a snug or an active fit. Remember the words. It's not a snap fit nor a passive fit. Snap fit is for your SSCs. Your passive fit is for zirconia. So here it is snug or an active fit. Okay. Can we adjust the occlusion of Bioflex crowns? It is not recommended to use any kind of rotary to adjust the occlusion of Bioflex crowns. Just because it's a hybrid material, don't go about trying to trim it. Yeah, the occlusal surface of the preparation should be reduced by 1.5 to 2 mm. The Bioflex crown should never be the first point of contact in occlusion. Now, I'm sure in your at least practical examinations, you're all going to do bite registration and then start your crown preparation. All of you follow that procedure? At least for your examination, you have to do that. You should have your wax bite registration and then start up. So what is the faculty is laughing because I'm sure you're all exam going PGs by now. When you're doing your crown, since you've attended a rapid review, so you have to make it a point to do your bite registration before you start your crown preparation, okay? So what is the wear resistance of Bioflex crowns compared to stainless steel crowns? You found that clinicians may see a dimple develop on the Bioflex crowns in areas of heavy occlusion. The dimple appears to be a self-adaptive technology of the material. Then it, of course, self-adapts. What cement should you use? A light cure cement should not be used because the opacity of the crown will not let the light pass through to set the cement. Are Bioflex crowns radio opaque? Yes. Radio opacity of Bioflex crowns is similar to the radio opacity of enamel. You should say that it is similar to that of enamel and should allow radiographic evaluation of adaptation of the crown margins as well as pulp therapy. Okay? So these are your common questions. Let's move to the most advancing thing, 3D printed crowns. Shambhavi, can you tell me the time, dear, if you don't mind? I still have? Okay. I'm halfway through the presentation. Your 3D printed crowns, are you all getting bored? Okay. You don't have a choice, do you? Okay. So, with your 3D printed crowns, how many of you have done 3D printed crowns? I'm interested to know. Any of your research activities? Yeah? That's your research activity. Can you throw some insight to us?
It was my thesis topic, so I...
Can you introduce yourself so that people know?
Hi, I'm Dr. Arulika. I'm from SRM Dental College, Ramapura, and my thesis was on 3D printed crowns, where I compared two types of crowns. Both were 3D printed, but the design was different. One was a full coverage crown, and one was an endo crown.
One was an endo crown. Okay. What did you infer in your study?
So both had good success rates. The only difference was the endo crowns. The height of the crown was slightly shorter.
So your marginal integrity was an issue.
No, the fracture resistance, like
Okay.
the endo crowns encountered fracture in the distal portion.
Did you quote the same classification of the fractures?
We followed the FBI criteria for
Fracture classification. Okay. Okay. Fine. Thank you so much. So with the rise of 3D printing techniques in pediatric dentistry, it represents a transformative step in how dental professionals approach restorative treatments for children. Like I already said, the patients who sit in our lounge, they observe that the crowns are being mulled over there. Since the mulling is done over there, they ask for the crowns to be given at the same time. They also want aesthetic crowns. With enhanced aesthetic dentistry, refined mechanical property, measurement results, and faster treatment rounds, 3D printed crowns are set to redefine modern care for pediatric patients. So what are the different things that were compared? The 3D printed crowns when compared with stainless steel crowns and zirconia crowns, you know that the aesthetics is high for 3D printed resins. The durability is, however, moderate when compared to stainless steel and zirconia. The cost effectiveness is also a little moderate, low for stainless steel and high for zirconia. Ideal use, again, aesthetic restoration of primary teeth. Molars, stainless steel crowns are still considered to be the gold standard. Aesthetic and durable restoration needs, again, for zirconia crowns. So what is this PEEK? Have you heard of PEEK? Yeah. So PEEK is a polyethylene ketone material which is a semi-crystalline polycyclic aromatic polymer. So PEEK is a result of reaction between difluorobenzophenone and disodium salt of hydroquinone in a polar solvent. So how is this PEEK gaining importance in dentistry? You know that your space maintainer materials are made of PEEK. It is biocompatible, it has low plaque affinity. The mechanical properties, that's the Young's elastic modulus, is similar to dentine and enamel. Wear and chemical resistance is considerable. It has good dimensional stability. It provides radiolucent imaging and can be therefore used in MRI scans and CT and X-rays. It has remarkable aesthetics and polishing qualities. So with newer advances, even your materials can come as your short notes. If those of you who are from Rajiv Gandhi University, you'll realize that the trend of pediatric dentistry question papers have changed drastically. They're asking for newer techniques, newer inventions, and other things. So you should know about PEEK now. in your papers. You should answer about peak with relevance to space maintainers as well as your stainless steel crowns. So this is an image of a 3D printed primary molar crown, of course not finished. It's one of the prosthetic restorations, unpolished 3D printed crowns for primary molars using a 3D printer. I'll move on to the next topic of importance, that is your Edelweiss pediatric crowns. Have you been using Edelweiss crowns at Saveetha? You people have used Edelweiss crowns? Other institutions, have you used Edelweiss? You've used, which college is this? RB College, okay. Any others who have used Edelweiss? Okay. Edelweiss, you should know, picking up trend, easier to adapt, and the cost factor is also considerably less. I think around 1,100 or 1,000, less than 1,000. 800, 700, some of the dealers are handling it at that cost. So a little more considerably used these days. The composition of Edelweiss pediatric crowns contains barium silicate glass, aluminum oxide, carbon, zinc oxide and fluoride. Any crown, you should mention the composition of the crown. So you know the barium silicate glass, optimum aesthetics and better bonding tooth structure, strength and optical properties by aluminum oxide, carbon of course provides the resilience, zinc oxide antibacterial, no biofilm formation, and fluoride again for your hydroxyapatite regeneration and antibacterial effect. Indications, let's run through, used for anterior and posterior restorations. Then you have morphological deformation cases, developmental defects, poor enamel quality, increased caries activity, severe bruxism, erosion, all these cases. And contraindication is just allergy to any of the ingredients. Edelweiss pediatric crowns, again advantages, highlight what is of importance. Zero bisphenol A, all of us are now talking about materials which are less sensitive to the patient. So cuts like natural tooth, it's easy to adjust in the mouth, can be easily repaired. So you have the option for easy repair. It can be easily handled by the practitioner, less chairside time needed for crown placement, cost effective and prefabricated to fit all the sizes of milk teeth. So what is this thing on one size for all? So the company advocates that based on the study of all shapes and sizes, what are the different sizes that are available? Have you used the template before you use the crown? So you have the small, medium, large and extra large size of the crowns that are available. See, these are some very basic questions that they can trap you. You know it, but you don't know how, it doesn't flash during the exam. So you have small, medium, large and XL sizes also available. So can you see the second diagram? That is a template that they have used. Second diagram on the right side on the quadrant of 7.3, 7.4, 7.5, there is a template, right? You have various templates that are present. That is your pediatric crown sizing guide. The sizing guide is positioned over the teeth to be restored, in which the visible profile allows for proper selection of the teeth fitting the Edelweiss crown. Adjustment can be illustrated directly on the template. Now, coming to the shade. Did you people use it with the size guide? When you use, yeah. So coming on to the shade, all Edelweiss pediatric crowns consist of the shade enamel, Vita enamel A0. That you should know. It's Vita enamel A0. The respective dentine and enamel shades used to cement pediatric crowns will determine the final shade tone of the restoration. You're using the composite below it, right? So which is that? If you use A0, that is dentine A0, you will get that A0 of the shade of the tooth once you're finishing the crown. Then if you use A1, then you get that. If you use A3 below the one's color, that is, it's universally available as Vita enamel A0, but below that, depending on the composite color, based on the shade that you use, that gives the color to the tooth. So example, Edelweiss pediatric crown, Vita shade A0, cemented with dentine shade A3 will give you Vita dentine shade A3, which will result in the Vita dentine shade A3 itself. So your universal shade of the crown is A0, but depending on what composite you're using below that, that's the dentine shade, will determine the final shade guide of your restoration. Clear? So this is one of the representations of the case. A retraction cord is needed. If needed, is placed following the previous caries removal. Enamel etching is done for 15 seconds and the dentine for 7 seconds. You rinse thoroughly. Can you see that? So bonding the inside of the pediatric crown with veneer bond, you know that the disadvantage of this Edelweiss is it comes with that veneer bond. You have to use that veneer bond. So that veneer bond is used on the inner occlusal aspect of the crown, and it is light cured for about 20 seconds. Clear? What is the next procedure? The Edelweiss Nano Hybrid Composite is placed on the inside of the Edelweiss pediatric crown. After you load it with the composite resin, you place the Edelweiss pediatric crown on the tooth surface. Okay? Positioning of the Edelweiss crown and removal of the excess composite is done in the next diagram. Then you do a 30-second light curing in all directions. The finishing of the margins with a fine diamond burr is done. Final polishing using the light polishing cups is done as an end of the procedure. Is it clear? For the use of Edelweiss crowns. Now, the most important is your stainless steel crowns. Stainless steel crowns, this is the second part of your examination. So we covered Edelweiss 3D printed crowns, zirconia crowns, as well as your Bioflex crowns. So let's come to the stainless steel crown. If you ask me for stainless steel crown, you should know Mathewson page by page, word by word, sentence by sentence. There is no shortcut for stainless steel crowns apart from Mathewson. Okay? So stainless steel crowns are the prefabricated crowns which are adapted to the individual primary or permanent. You know, it was introduced by William Humphrey in the year 1950. Composition, you have the nickel chrome crowns, authentic stainless steel, available in various sizes. Now, what is the difference in the sizes between the crowns? Answer that question for me. Somebody says 0.2 mm. Anybody else would like to try? What sizes are available? Huh? 2 to 7. 1 is not there? Okay. Even I don't know why it is not there. We've all learned it that it is there from 2 to 7. Yeah. So what is the difference between 2 and 3? What is the difference? 0 point? 0 point? You try 3, it doesn't fit, then you go to 4. You never bother to find out why it doesn't fit, right? So please memorize this diagram. Can you see this? It starts with, it's your upper first primary molar, your mesial distal width in millimeters, as well as your crown sizes. It starts with 7.2 mm, okay? And the next crown, that is upper D, the next crown size is 7.6. So somebody was trying 0.04020, it's 0.4 mm of difference. Can you get it? Just observe the chart. It is 7.6, 8 mm, 8.4, 8.8 millimeters, and 9.2 millimeters. Yeah? Sorry? Observe it carefully. 7.2 is size 2. 7.6 is size 3. Okay? 8 mm is size 4. What's the difference? 0.4 mm. That's your scale. That's your scale which is there on the extreme end. But I've placed the crowns against the sizes. Can you observe that? So what is the difference that is there? 0.4 mm. Yeah? You should, this image should be in your mind all your life. You should never have any difficulties in answering this question at any point. Okay? So you know it's 8 mm is size 4, 8.4 is size 5, and 8.8 is size 6, and 9.2 is size 7. Clear? Again, move on to the upper second molars. It starts with 9.2 mm. Supposing the examiner, you're holding an upper molar or a lower molar, suddenly asks you, what is the mesiodistal width? You should know the dimensions. At least depending on the tooth that you have chosen, the crown that you're going to choose. Generally, it is 4 or 5, right? The sizes that we use. So you can memorize those images. Coming to the lower primary molars. The lower primary molar starts with 7.3 mm. So the next size 3 is 7.7 mm. This is exclusively for primary molars. Can you see what is written at the extreme end? Oh, that's not visible. It's for the 3M stainless steel crowns. Clear? And I think most of us use only 3M crowns. At least I do in practice. So this is the, you can firmly say that this is the chart that is published by 3M, and this is the difference that is noted. Clear? Have I made myself clear? Any doubts in this? Again, on your second primary molars, it starts with 9.4 mm. That is your size 2. 9.8 is your size 3. 10.2, size 4, 10.6, 11 and 11.4. Clear? So what are the mechanical properties? Again, you have to speak about the tensile strength, the yield strength, good formability and ductility. Heating does not increase their strength. They can be work hardened, soldered, adequate hardness and wear resistance. Types of stainless steel crown, which is this image that I have put there. It's your Rocky Mountain group. That is your untrimmed crowns or the straight side crowns. It's neither trimmed nor contoured and require extensive trimming and much adaptation. Rarely used when extra length is needed for cervical located lesions. That's when you pick up these untrimmed crowns or the straight side crowns. Whatever I'm talking about cervical located lesions, when your stainless steel crown, regular crowns, what is available, falls short of the margins because your cervical lesions are way beyond, then you can use these crowns. Then comes your pre-contoured crowns, that's your 3M company crowns, which are festooned and pre-contoured to loosely resemble the natural tooth. Minimal trimming and contouring may be required. So what does the diagram speak about? The broader occlusal table, better defined. Then you have the optimized contour and shorter height of the New Smile pre-contoured stainless steel crown helps save the chair side time, and you also have laser etching is indelible and easy to read. It stands up for autoclaving and helps eliminate errors. Then it has high micro hardness. It has the same surgical grade 316L stainless steel that is used in high stress orthopedic implants. So it is strong, easy to trim and crimp, and is of course biocompatible. Indications, again, you know, large carious lesions, ECC, infraocclusion, reverse anterior stainless steel crowns in children for single tooth crossbite. But of course, now for crossbite, we have better appliances and treatment protocols. These are all which was published way back, and we still remain reading the same thing. What are the contraindications? It causes tooth nearing exfoliation of 6 months, not indicated. Pre-shedding mobility, tooth showing more than half the root length resorbed. Inability to adapt a primary molar crown due to the amount of tooth tissue remaining. And ability of the patient to cooperate. Now, supposing a tooth has supra-erupted, which crown are you going to think of now that I've spoken of so many of these crowns? Which do you think is better? If you have an opposing supra-erupted crown and you have very minimal of the crown structure in the lower arch, which crown would you think is feasible in such crowns? I would vouch for Bioflex crowns. At least it helps because of the occlusal wear resistance that it exhibits the dimple. So keep these small things in mind when you're doing your practice. Don't stick to the same old ways of handling patients. Permanent molar crowns, these days children have been asking, you do have your Bioflex for your permanent molars. I think you've all started using it. Then you have your gold color crowns for your permanent molars, and you also have your stainless steel crowns. Why is it called a semi-permanent restoration? Do you know that the permanent molar crowns are referred to as semi-permanent restorations? Why is it? Because eventually you're going to replace it with either your zirconia, your porcelain fused to metal, or any other crowns. So in your treatment plan, you will make a mention of semi-permanent restoration, indicating it for your permanent molar crowns. Cervical caries in failure of other restorative materials, affordable restorative option for remote areas without access to dental care. Those are things. Advantages, outcomes of pulp therapy are best in treated with stainless steel crowns. That's what Randall et al. Says. Higher survival rate compared to multi-surface restorations, and PMCs show greater longevity than amalgam restorations. I don't think any of us are practicing amalgam restorations now, right? I didn't do it as a postgraduate myself. Any of you still doing amalgam restorations? So it's all outdated, yeah. So advantages for use in permanent molars, reduces the risk of recurrent caries, retains the arch length, and higher success rates in molars affected by molar incisor hypomineralization. So the survival rate of stainless steel crowns, you can take down this table. It has all the review of literature. Like I said, any answer, once you speak about the composition, indications, contraindications, crown preparation methodology, you have to speak about the survival rate of the crowns. Armamentarium, again, Mathewson describes it with your 169L or your 69L FG burrs, your number 6 or number 8 round burrs. Then you can use your green stone or heatless stone, rubber wheel stone for finishing and polishing. Then you have your wire wheel for finishing the crowns. Then your cement, I'm sorry. Then you have your tongue blade or orange wood stick for wax bite recording, and your calipers for determining the size of the crowns. Again, the pliers, you should memorize the plier numbers, your Johnson contouring pliers, your crimping pliers, your Howe pliers, and your Gordon pliers. Occlusal evaluation, as I said, prior to rubber dam application and tooth preparation, examine the cusp fossa relation bilaterally, check the dental midline, extrusion of opposing due to long-standing carious lesions, like I said, supraerupted teeth, mesial drift as a result of carious lesions, presence of spacing and crowding, examine the occlusion directly in the oral cavity or indirectly with the dental cast for incisor, canine and molar lesion on both sides, record a wax bite if required. Selection of the crown. Smallest crown that covers the preparation closely fits the tooth and restores the interproximal contact. It's your trial and error method that you all follow. Administration of local anesthesia mandatory. I think some of you still avoid using local anesthesia. If you see the Western world, even for a restoration is done without local anesthesia, it is not accepted, right? So I think for stainless steel crowns, it's any of the crown preparation, I do follow my aspirating syringe, so it is convenient to administer the local anesthesia. Are you guys using your aspirating syringes or you using the conventional syringes here? Both, yeah. So the tooth and adjustment soft tissues should be sufficiently anesthetized to prevent pain. Local infiltration is considered a better choice than topical anesthesia. Preparation, two schools of thought, you know, it's the occlusal preparation or the proximal preparation. I would advise finishing off the occlusal preparation first and then moving to the proximal. Invariably, the proximal preparation is a little painful, so the child also becomes uncooperative. So if you finish your occlusal preparation, it is, from a clinical perspective, I'm saying that, it is better you do your occlusal and then go to the proximal extension. So you have proper preparation of the preformed metal crowns. So the dashed line shows the amount of preparation of 0.5 to 1.5 mm that is required. Then your proximal reduction using a thin tapered fissure burr at high speed mesial and distal contacts. One more word of caution that I would like to give in this is, please keep both your blue abrasive as well as your green abrasive in this case. What am I talking about? The burrs, right? Don't just stick to your blue burrs. When a little minimal preparation is required, especially I give this advice when you're doing it with a permanent molar, make sure that you have banded, I mean you use a matrix band between your permanent molar and your primary molar. You should not be causing more trouble than helping the child, right? It's very iatrogenic to do a preparation on a 6 when you're doing a preparation on a E, right? That's the whole reason. How many of you follow that, placing the band? You do it honestly? I say it's okay. They'll come back for the 6 RC later. Please don't do that in the examination also, because all the examiners, the first thing that they see when you're doing your crown preparation is they check if you've cut the adjacent tooth structure. And all examiners, when you're doing your space maintainer, they see if you have nicked the surfaces of the gingival tissue or any other structure. Especially when you're doing your crown preparation, laceration of the tongue, laceration of the lip invariably happens during the examination day. So that's the first thing. More than looking at the crown preparation, they look at the 6 or the adjacent tooth, and they will look at any other lacerations that are present on the soft tissue. So that instead of putting yourselves in that position, make sure that you place your band and then you do it. It's easier and it is being safe all the time. So proximal reduction of minimum of about 0.2 mm and then buccal and lingual reduction only if required. Generally we do not. And then you have all line angles and sharp corners to be rounded. And you can see that the buccal and lingual proximal line angles are rounded by holding the burr parallel to the long axis of tooth and blending the surfaces together. So try crown on the tooth. It may be too long, too short, smaller in size. very important is your Spedding's principles. Principle number 1, principle number 2, memorize it. What does it say? It is the establishment of the cervico-occlusal height of the crown. Make 3 light marks with a half. Yeah, so make sure that you make 3 light marks with a half round burr to mark the height of the gingival crest. Remove the crown and trim it in a straight line about 1 mm below the middle mark using a crown and bridge scissor, and repeat the procedure until the adequate extension of 1 mm beneath the gingival margin is achieved. They say you can use a sharp explorer to mark it. I personally find it difficult to spot what mark it makes with the kind of explorers we have these days. So if you can approximately use that 1 mm as your reference line and trim the crown, that is adequate. The second principle, the buccal and lingual marginal gingiva, the second primary molars, outline of the marginal gingiva on the buccal and lingual surface resembles a smile. First primary molar stretched out as, all proximal margins should resemble a frown. Okay? So these are your forceps, you have your contouring forceps, then you have your Abel pliers, then you have your crimping pliers that are available. How do you, if you fit the crown on the tooth surface and your examiner observes it and says, now you remove the crown, what are you going to use to remove the crown? So that's the standard everybody is going to say is your spoon excavator. Even on those minor things, invest on the right spoon excavators that you have. I would recommend a GDC instrument of variable sizes. You have your spoon excavators. Invest on the right materials. It makes it comfortable for both you as well as for your patients. Isolation and cementation, you know. Use knotted dental floss to remove off any of the excessive cement, which you generally forget to do. Once you do the cementation, you're all anxious, you want to show the crown immediately to your examiners. Make sure you use your floss. Anybody who's smart, they just see what is the armamentarium on your working table, right? So if they do not spot the floss, they know you haven't done it. So make sure you give attention to all these minor details. Both the examiners sitting opposite to me are nodding their head. This is exactly what we do. So these are the tips that I'm giving you from our side. So make sure that you have your floss intact with you, okay? Check for occlusion. Articulating paper at the end, check for it. I know before cementation of the crown, make sure your radiograph is taken. You show the examiners. Once you've crimped it, then you show it. Invariably, you show it without crimping. And again, the examiner says, go crimp it and come back. Avoid all such things. Make sure that you do follow all the procedures stepwise. Crimp your crowns and then take your radiograph and then show it before cementation. So the choice of luting cement, again, glass ionomer. I've stuck to glass ionomer, GC type 1 gold standard, given good results to us always. So you can, even resin modified GICs can be used depending on the availability. Retention depends on the tooth preparation, crown adaptation, and the luting cement. Most important is your aspiration or ingestion of the crown. To be on a safer side, I would always prefer a ringed crown if your patients are uncooperative. Okay, so you should have, you don't know, you cannot predict if your patient is going to become uncooperative on the day of the examination. So it is always advisable to have your ring crowns in place. Safer, if patient has been cooperative, easy, then you can use your regular crowns. Any of special children, I do not touch if I do not have my ring crowns in hand. Earlier they would make the hole for the crown and then place the floss and all those. Availability in the market, make use of it. Rocking of a crown, canting onto one side can be due to uneven reduction of the occlusal surface. Correct by rounding the occlusal line angles. Okay. Loss of space, these are pictures from your textbook, so you know when there is loss of space due to extensive caries, you have your modification. Who's given the modification? It's Nash's modification in 1981, when the adjacent stainless steel crown with more than one crown is required in a quadrant. Both teeth should be prepared. Always start with the proximal most tooth, then come to the anterior aspect. Restoration of adjacent stained crowns which require deep subgingival caries, then what do? You extend apically of the crown margin, restoration to be done before the eruption of the first permanent mandibular molar to prevent unnecessary crown margin overhang. If there are no adjacent teeth, measure the available mesiodistal dimension and precise proximal tooth production is done. So you have the Mink and Hill modification for oversize. You will know what is the modification, but you will not know who said it. So please memorize this. It's Mink and Hill. So you have oversized and undersized crowns. So two names, Mink and Hill. Remember it that way. So try the crown. Then if it is big, what do? You cut it, and then what do? You overlap each of the thing and you spot weld it. And if it is undersized, then you place a little bit of your band material. We don't do any of these, but because we have all the crowns, but for knowledge, for textbook, you need to write the answer. So Mink and Hill's classification, whatever they said, modification is required. Nickel allergy, most important, you can quote this, very widely used text literature is the delayed hypersensitivity reaction to a stainless steel crown, published in Journal of Clinical Pediatric Dentistry. This is what we quoted during our examination. Nickel allergy, inflamed hyperplastic gingival tissue around the restoration or space maintainer can cause, it's a delayed hypersensitivity reaction induced by your T lymphocytes. Failure, you know the main reasons for failure is your poor tooth preparation. It can be because of your cement, or it could be because of your failure of your pulp therapy. Another important topic, to summarize, your answer will be incomplete for stainless steel crowns if you do not talk about Hall technique. Do not forget to write about Hall technique, described by Dr. Norna Hall. You have indications and contraindications mentioned. Occlusal caries, proximal caries, and sufficient sound tooth structure to retain the tooth. Tooth with signs or symptoms of dental infection, crowns severely destructed with caries, very, very young patients who do not understand the procedure or tolerate biting the crown into his position without LA, children at risk of bacterial endocarditis, and immunocompromised patients, you don't do it. So you all know what is Hall technique. I'll not go into too much of those details. Concerns of Hall technique, use of orthodontic separators required because it's time consuming. You cannot place the crown immediately if the contacts are very intact. So the need for orthodontic separators. No occlusal preparation before cementation could lead to premature contacts. Occlusion might be temporally opened but equilibrates rapidly, usually within few weeks. And children need to withstand biting a rigid metal crown into its place across relatively tight contacts without any local anesthesia. So there are evidence-based studies for Hall technique. You can look up the literature to all these which are mentioned. Posterior when your stainless steel crowns, of course, we've not used it of late these days, but there are studies which have documented. So the clinical performance of the crowns was successful for 3 years. Facing fracture occurred in 47% of the crowns. With so many advances, we've stopped using all these kind of crowns, I guess, these days. But for writing an answer, you should mention. So what are the failures of SSC studies? You have marginal discrepancy caused by continuous tooth eruption. So small ledges are present. Significant increase in both the indices and subgingival microbial counts. Macrophage inflammatory proteins increased in the gingival crevicular fluid. That was one of the studies that was being performed. So this summarizes my presentation on crowns in pediatric dentistry. I'm open for questions from your end. Anything that you would want to know? Generally, this is the advice that I give for all students when I go as examiner is practice pediatric dentistry, uphold our fraternity. The other thing that I would want to say is when it comes to cost, do not compromise on the cost factor. You know you're putting in so much of effort. You know how difficult it is to handle these patients. So do not compromise to people who say, see, we've all evolved. When we were practicing, they would say these teeth are going to fall off. That's not the trend anymore. They accept treatment these days. The next level is the kind of materials they choose. There are still people who say we are not happy using the expensive ones because of their own limitations with the socioeconomic status. But I think whatever may be the reason, you should hold your pricing at what it should be. So I always say this, do not compromise. Even if you're going for consultation, if your doctor, general dentist says, doctor, this is how much they can pay, Say, no, this is what we charge and this is what we are going to stick to. If you don't uphold your costing, your treatment, give good treatment, then only you will be eligible for the cost factor. And only then your practice will be looked upon. That's my advice to pediatric dentists. Practice the field. It's a wonderful journey. And I thank sir, ma'am. And I'm very impressed with the way the entire conduct of the institution. I've always wanted to look at it. And thank you to giving me this opportunity. I hope I've made justice to travel from Bangalore to teach you all. Thank you so much.
Thank you so much for such an informative presentation on crowns, ma'am. I would like to request Dr. Sai Shankar sir to present the memento to.
I now welcome Professor R. Kavita, an accomplished pediatric dentist and an exemplary researcher with near 2 decades of academic and clinical experience. A graduate of the Tamil Nadu Government Dental College, she obtained her MDS in Pedodontics from Raga's Dental College and went on to earn a PhD from SRM University, becoming the 6th pediatric dentist in India to receive a doctorate. Her primary focus today is special care dentistry and she collaborates internationally, currently with University of Technology Mara, Malaysia, on molar incisal hypermineralization research. Professor Kavita has over 30 publications in her credit, serves on the boards of studies of multiple dental colleges, and is a pioneer in integrating sensor-enabled appliances and AI into pediatric dental care. A passionate innovator and a disciplinarian, she truly exemplifies research-driven clinical excellence. I welcome you, ma'am.
Is it okay? Yeah, okay. Yeah, okay. Yeah, okay. Thanks a lot for the kind introduction. Thanks a lot, really. First of all, I would like to thank Dr. Mahesh, Deepa, for inviting me to your esteemed college. And it's very nice to see many faces over here from different institutions, from nearby universities itself. Very nice. All the best for each one of you. I think you have seen so far very interesting topics, and now we are going to go into a slightly very audital. It'll be a dull topic, but I'll tell you the very important things which you should be knowing, that is the key factors, and generally how are you supposed to appear for any of this question paper, that is anything like that, okay? So when you take up special health care needs, okay, the first thing is introduction. What you should be knowing about introduction is, this is a group of children which is actually been either they will be affected, there will be impairment, will be either a partial impairment or it will be a complete disability, and they will be requiring not the usual method of health services. So they will be requiring special health services. So they can be affected either by means of physical development, mental, sensory, behavioral, cognitive or emotional impairment. Initially, they were calling this as handicap, but it has its own societal implications. So these days, the term has been modified and it has been including these 7 categories, and you should be knowing that you are giving a special healthcare services for these children alone. Okay? What are the factors which is important? What happened? Okay. So what are the factors when you take up these children you should be knowing? So first thing is that whenever a child with a special healthcare need is coming to you, it can be either a cerebral palsy child or a Down syndrome child, or even an autistic child or anything like that. So what happens is that the parental attitude, the patient attitude, the dental attitude, and apart from this, your preventive aspect, all these things you should be keeping in mind. That's the factors which you will be writing. So any parent whoever is seeing a child who is not in a normal developmental milestone and they find that the child is having some disability, automatically their mental attitude will be something like, why me, or anything like that. So they already will be with some anxiety and emotional trauma. So it's very important, like we speak with the parents, we understand their mentality and our motivation from our side to implement or interact with them to initiate a dental treatment and to go on with any preventive measure and finally on to the prolonged period of travel, and making them understand the importance of dentistry, and apart from that even the interaction of the different drugs also, whichever they are taking it for the general condition, is very important. So that is the parental compartment actually. Then if you take up the child compartment, there it will be mostly the cooperative nature of the child, either because of inability or disability, or apart from your uncooperative nature, you can see that their systemic complications itself will be creating some amount of fear and anxiety. Generally itself children will be fearful, but here there will be more amount of fear and anxiety towards the environment, the newness, and even and as well as the dental chair and equipments and the noises and all those things, also sensations, everything. So this is regarding the children. Apart from this, that is the dentist perspective also, in the sense that mostly the dental clinics, which is associated with any medical college or anything where the parent has been taking a lifelong treatment for the child, will be not that much equipped to take care of a special child. That is very important. So the nearness of it, the equipments whichever is present, and as well as the dentist knowledge itself. There are studies which is telling that less than 45% of the dentists are having the complete knowledge about treating a special child, their medications, and what is the interactions and all those things. So all these compromise is their dental treatment. So and these are the factors which we should be aware of when we are going to write this point as special healthcare needs. Okay. Then after this, we need to concentrate about your initial examination, your preventive dentistry part. I think that you will be doing something like the dental home concept, the preventive dentistry, starting from your even feeding and the way of feeding, preventive part of it, even oral habits and all those exercises, and it will go on towards even preventive dentistry, fluorides and all those things, you will be writing it. So that part of it along with the diet and nutrition. Here diet and nutrition, one small modification is that, see, we have a specific diet for cerebral palsy, it's a puree diet, autism, Feingold diet, epileptic, ketogenic diet, and for metabolic disturbances, it's very important, like we go for restriction of specific foods like that. So this type of diet alone will be the modification. Apart from this, this is the general factors whichever you should be knowing. Okay. Once a child comes into this one, so when you come to the dental treatment part of it, the first thing which you should be having it in mind is your dental operatory design has to be acceptable for the dental child who is ready to come even on a wheelchair. So accordingly, you should be having this as specifications is very important. You just think about yourself in your dental college. First is your parking space, your walkway, then after that the transfer wheelchair lift area, then they come over towards the ramp, the door part of it, the inner corridor, then they come into the operatory area, over there the reception, And then what else? Any other telephone area or anything, the restrooms, everything has to have a proper elevation of 1:12 a minimum, with a 1:50 on the parking space like that. So the proper elevation has to be there, and it should be non-skidding in every part of it. And what else? There should not be any obstacles like doormats or anything. So these are the major specifications in the dental clinic point of view, which you should be noting it out. Okay. The next one is, once you know this one, first is actually we classify the child as, according to the different classifications, as this child falls into which category. Okay, so we have 3 different classifications as Frank and Winters, and then Novak's classification, and you have Agerholm's classification, okay, intrinsic, extrinsic. So by this you will classify, this is the first thing which you should be writing. First will be a definition, your factors, and then what is the classification for the special healthcare needs, okay. Then after this, how are we going to examine the child? 3 important things. First, we need to examine the general health status of the individual. The next one is the oral health status, and assess their behavior. If you take up the general health, obviously you'll be knowing when you take up the history, we just find out what is their medical history and what is the severity of it, what is the medications, how frequent any episodes have attacked, and what are the trigger factors. All those things will be taking it up. When coming to oral health, it's very important, like oral health care needs. First, what is the main concern which they have come over here, and apart from that, their dental caries, periodontal problems, and the other things will be seeing. And after all this, the most important thing is, we have one behavior rating scale. Just like your Frankel's behavior rating scale, we have one behavior rating scale and a movement scale for these children, okay. This is what it is. So this was put forth by Frankel's, modified by D. Novagashia in 2007. Your Frankel's is actually in 1996. This was later in the case of 2007. Here you have it as category 1 is clearly negative, negative, positive, very positive. So any child whoever is coming to your clinic, you're going to clinic or hospital, you're going to categorize them according to your behavioral scale. And the next one is your movements. That is, what happens is when a child, it's a cerebral palsy child or even a mentally retarded child, it's very important we need to know what is the extent of their movements. So that is how we have this classification by hoop scale actually this is. So this is violent movement, constant movements, controllable movements, and lack of movements. So these 2 classifications are very important when you write your special needs children, any student classification, okay. So accordingly, we classify them according to this, and then we proceed on to the treatment part of it, okay. So when we take up the conditions, the first one which I'm going to tell to you today is about Down syndrome. Down syndrome, they will commonly be asking you, okay. Mostly when you take up special healthcare needs, Down syndrome, they will be asking you, and these days commonly asked next question is actually autism. Okay, so first thing is Down syndrome. Down syndrome, we are studying it from BDS itself. So you know what are the general manifest. What is it exactly? Trisomy 21. So you know that you have an extra chromosome. So what next? Actually, it was introduced by Down. As simple as that. Then what else? What are the different types of it? Whenever you tell about any, any syndrome or anything else, any special healthcare you're concentrating on, it means first write 2 words about it, either a definition or something else, and then you go in who introduced it or who was the one to name it or something like that, who has contributed more to it. The next you go in for what is the major pathophysiology behind it. Here, what is the major pathophysiology? You have an extra chromosome. That is a chromosomal condition. Okay, so it can be either a trisomy 1, where you have a triplet of it, or you can have it as translocated one. It would have been translocated in some other space, or it would have been in alternate spaces. That is a mosaicism. Okay, so that is part of it. So what is next one is how prevalent it is. Okay. Always it will be your definition, and then you will come your etiology, and here before this etiology you will have your prevalence. So 1 in 1,000 of the live births are said to have this is Down syndrome. Etiology we always know, we know that it is chromosomal disorder, so automatically it is your maternal age and chromosomal aberrations and environmental factors. These are the general symptoms of it. This we already know. So what is it? Short, stout individuals, and what else we have? then you have short, stubby fingers, pimian craze, and almost all the system would be involved. So broad, flat face will be there, startling eyes, an epicanthic fold, nape, general nape, like that. And what else? High arched, small but arched palate will be there. Other dental anomalies. Very commonly seen with them is your congenital heart abnormalities, and then you have your umbilical hernia and abnormal pelvis will also be seen with them. So apart from this, these are the general things whichever we see. When you will be knowing it in BDS itself, all this. The next one would be your oral manifestations. If we see oral manifestations, and when you take up, most of these will have dental caries and periodontal diseases, but these Down children syndrome is to have more amount of periodontal diseases, okay, either because of delayed eruption or because of their immunological capabilities or anything like that I'll tell later. So they have microdontia and then partial anodontia. Crown variations are more because of the chromosomal abnormalities, hypoplasia, delayed eruption of teeth. This is the major cause for actually dental caries, and low incidence of caries with more chances of periodontal diseases. Apart from this, because of the malformations which is occurring, generally the what we see with these, because of this genetic abnormality, what happens is inside the central nervous system itself, they have more amount of triamine in phthalate. So what happens is it will be present more in the cerebrospinal fluid. So this will have more amount of rapid activating potentials also. So the sodium and potassium transfer, all these has been impaired actually. So dendrites, it will be, the whole system itself will be affected, the CNS and the higher systems. So automatically, almost all the system of this Down syndrome children will be affected. Okay, so starting from your tongue, you'll have protrude tongue as well as macroglossia, and occlusion will be because of their small mouth but high arch palate and hypotonic facial muscles. Because of that, they'll have an open mouth posture, so always they'll be placing the tongue outside. And what else? Here, eruption will be retarded, teeth will be hypodontia, and early onset of periodontitis will also be seen in these children. Okay. What is the next other thing which you should see? What is the mental retardation percentage which is present in each of these categories is very important. We see that mostly it's 25 to 50 is the mental retardation. And what are the other complications which you should be seeing is mostly cardiac abnormalities as well as respiratory abnormalities. That is a major complications with them. So all these has to be taken into account when you go in for a dental treatment. So any case, we are going to categorize them according to the mental retardation, according to their movement scale and behavior on the dental chair first, and then proceed on towards the treatment part of it. Okay, so these are some of the authors who have actually told. So it is something like less educated parents is the major cause for periodontal status. It was told by Sharma et al. And according to Dinesh Rao, they have told that it's of more of severe malocclusions are seen with these patients. And Bell in 2011 has told that you should they show high levels of tooth wear with these children because of tooth grinding and also because of the acidic environment. Okay, and Christina Maria has reported a higher bruxism with them, a gens ortho, an increased frequency of periodontitis, whereas Lee has told that it's due to the immune protection, they have low caries prevalence. Very important, like even if you know the other manifestations, external and the internal, intraoral manifestations, it's very important, like you quote at least 2 or 3 authors in each part of it. That's very important. Okay. What are the other things which you see? In the case of periodontal diseases, these children, because of delayed eruption, are the teeth which has been present over there, and that is also, it's been periodontally affected, and you see that almost all part of it will be affected. In the sense, more amount of marginal gingivitis, less attachment bone, as well as anug will be present a lot, more amount of bone loss, furcation loss, and all these causes an early loss of the teeth also. And it was Shapira who said that there is more amount of periodontal treatment has to be done with them, and it was Kichon who said that there is no improvement even after doing this, because they are repeatedly, it's because of the genetic condition, and so what happens is the periodontium gets affected even more longer period of time when compared to the, and they are very highly resistant to any of this antimicrobial or the preventive action. That's what been said by Kichon et al. Whereas when you tell up caries, we have two different authors as Desai. Here, Desai was actually into delayed eruption was a major cause for dental caries, decreased dental caries, whereas Davidovich said that it's mainly because of the salivary environment. That is a major cause for actually causing decreased caries. Okay. After these anesthetic, after these is what to tell, dental as well as periodontal, it's very important to know about this anesthetic considerations. The first thing will be actually, we know that the child is having, when you just, what to tell, when we go in for a treatment for a child, mostly these children will be going for either conscious sedation or GA. So depending upon their whether they're educable or moderate or severe form of mental retardation, here we need to keep up in mind. These are the major things which we need to know about them, because what happens is, because of the microcephaly and macroglossia, it's very difficult for us for this intubation and all those things. Apart from this, because of their endocardial, more amount of 40 to 70% of them will be having cardiac abnormalities. It can be a VSD or any duodenal atresia, and more amount of circulation defects, all these will be seen with them. Apart from this, what happens is the most important thing is they have this atlantoaxial instability. Most of your Down syndrome cases, it's very important, like you should be telling about your C1 and C2. So what happens is that it gets dislocated so easily. So what happens is the child will just have a sudden fall in the neck. So that's the reason why when you have to be very careful when you treat these Down syndrome children on your dental chair and even during intubation also, because of this atlantoaxial instability. Okay, and beyond this, subglottic stenosis is a major condition. All these will be in the respiratory conditions. Okay, so the first anesthetic consideration will be your atlantoaxial instability, and after this tracheal stenosis. Here what happens is the trachea fully what will happen is it's completely malformed, and it's all very thin and more of fibrotic in nature, and it is constricted in the apical part of it. So what happens is, what is the major consideration for you in the case of anesthesia is, for us we need to intubate using a smaller size of tube like that. Okay, and beyond this, post-operative period also they have there is a need for adequate ventilation due to increased possibility of post-intubation airway swelling as another complication with them. As I already told you, cardiac complications are around 40 to 70%, and what is the major idea behind it is that we need to refer them and find out whether any antibiotic prophylaxis is required. These days they don't go in for IE's prophylaxis, because these people, that's the latest thing. And apart from this, there is an increased morbidity and mortality with these children, mainly because of the infections that has been seen with them. Okay, and apart from this, because of this cardiac abnormalities, there is an increased blood flow towards the pulmonary vasculature. So respiratory complications get added when they have a cardiac complications also. Okay, when you take up the respiratory complications, I do understand it's the upper and the lower airway will be getting affected. Your upper airway is mainly this, it is added mainly because of your mid-face deformities and because of your large tongue and your increased secretions. Your lower airway problems is mainly because of your trachea and your alveoli. What happens is very less number of alveoli when compared to your counterparts will be seen with these children. Okay, so this is your anesthetic considerations, cardiac complications which is added to your anesthetic, your respiratory complications which is adding to your anesthetic. Okay, so this is regarding your Down syndrome. So first is your definition, and then we need to know what's the general symptoms, and after this you should be able to name 2 authors at least for caries and for periodontal diseases, and then what are the anesthetic considerations for these Down syndrome children. Is it okay? The next one is mental retardation. So mental retardation, as we know already, it's something like there is a decrease in intellectual functioning. It's not only a decrease in intellectual functioning, but also there is an impairment in their adaptive behavior. It is not only their intellectuality is less, the amount they adapt to the external environment is also less. That is what has been told by AIMD. What are the 3 levels of impairment? And actually we categorize a child, or what it has been told according to AIMD is actually that depending upon the developmental milestone, if the child is going to be considered to be less than 2 years according to the development, they are called as an idiot. And from 2 to 7 years, it is an imbecile, and above 7 years, it is a moron. So when you get a child who is mentally retarded, so what are the first things which you should be knowing? What is the etiology behind it? Of course, it's mostly inherited, and either due to a natal injury or postnatal complications, any complications due to birth or anything else, or any infections also would have caused this is mental retardation. Beyond this, first we need to categorize the child. So what is the category which we are going to use is that first is that Cattell infant scale, which is for those children below 2 years. And above 2 years, we go for Stanford's Binet intelligence test. And 6 to 17, it's Wechsler's intelligence test. Okay. And you have a Wechsler's adult intelligence test separately for above 16 years. So this is the way in which we categorize a child, whoever is a mentally retarded child who is entering into our dental clinic. Okay. Beyond this, this is how we need to know whether they are on the educable category or they are in the training category depending upon their IQ levels. So why do we need to do? But what are the general things as we see over here is something like when it is in the 70 to 80, above 70 is actually normal. When in 70 to 80, we cannot actually identify a person directly. Mostly till 2 years of age or something like that, they will be very normal. They will be something very similar to that of the other individuals, and they will be able to perform, read, write, and they will be very similar to the other individuals also. Whereas they will not be complicated things, they will not be able to do. Whereas mild is actually only after 6th standard or something, they will be showing some amount of developmental delays, and they will not be able to cope up with their reading and writing skills like that. And when you come to moderate, here they will be trainable, but still they need to have some person along with them. So these children also we can have them on our dental chair and do our dental treatment. Okay. Whereas when you come to severe and profound, severe, they need to have a trainer, but they have to assist them in for all the basic activities, but profound will be completely, they will be bound on to the wheelchair itself. Okay. So all these we need to know for the rest to understand their IQ status and their cooperative status, and beyond this, we need to know whether they will be sitting on we have to perform a treatment on the wheelchair, or we have to do it, shift them onto the dental chair, and then, or we need to go in for complete anesthesia itself. Okay. So when we have any child, and whoever is coming to a dental office, this is the screening schedule according to NIMH. So here 2 areas in the case of special healthcare children, we need to do the screening schedule. One is this mental retardation. Here it is in 4th, 6th month, 12th month, 18th, 20th month, 3rd year and 4th year. Whereas in the case of autistic children, it will be in 6 months, 12 months, 18 months, 20 months like that. Okay. So these are the 2 areas where screening has to be done regularly. When you come to the intraoral part of it, was the most common thing which you can see with the mental retardation. Obviously, when it's a mental retardation, their OHA will be very bad, and so mainly because of not their understanding capabilities, so severe ECC will be seen, and because of their nature of them, they have more amount of fractured teeth and loss of space, and poor oral hygiene will also be seen with them, with more amount of developmental defects of the enamel will be seen. And apart from this, any other specific thing which we need to tell is that they have so much amount of patients will be, 1/3 patient will be actually having a temporomandibular joint dysfunction. So, and there will be a dislocation of the TMJ also will be seen with these children, and high rates of psychiatric disorders will also be seen with them. Okay, and that's why more amount of atypical pain will also be seen with MR patients. Okay, so apart from this, we can see enamel erosion and anorexia, bulimia, and all those things are being associated with these MR patients. Okay. These are the general symptoms which you are seeing. But when you come to the dental management, as usually I told you, we find out what is their IQ status, we find out what is the behavioral status, we find out what is their movement status with Hoops movement scale, and then we just try to analyze them on the dental chart, and finally we move on towards mostly restraints is actually not for restraining them, either positioning them alone, and then finally it's actually oral sedation or GA only. The treatment will be mostly. These are the general drugs whichever is known, which is suggested for them. But the most important thing, the contraindications is what you need to keep in mind. That is mostly for upper airway obstruction cases, it has to be, we have to be very careful, and also with cardiovascular and respiratory cases, and very important when they have a history of, drug history of diazepam also. Okay, so these children, very important is periodontally as well as the endodontic management, all those things has to be done, and regularly we need to keep them because they fall in the high caries risk status. So we need to review them every 3 months and incorporate preventive dentistry inside their general protocol. Okay, traumatic injuries is another thing wherein we need to rule out child abuse also in these patients. Another important thing with mental retardation is, one is xerostomia, another is dyskinesia. That is what we told. Because of dyskinesia, they will have abnormal jaw movements and tongue movements, and that's why they have more amount of TMJ dislocations also, and there will be tongue protrusions. And apart from this, they have more amount of xerostomia because of the drugs whichever they are taking. And this is a part of the reason for increased caries also for these patients. Okay, and disability will also be seen with them. So this is regarding the mental retardation. So it is something like, in the case of mental retardation, we need to know, first of all, you'll be telling about the definition part of it, then you will be telling about how you classify them, and then as mild, moderate, severe, and the scales which you are going to use, and then what are the different from profound, mild, moderate, severe, and then severe cases also. So depending upon their IQ status and all those things like that. That will be the classification which we are going to give. And finally, what is the intraoral manifestations whichever you're going to see for these patients, and what you need to concentrate on them more will be your xerostomia, and then your dislocation of your TMJ. That is the extra points which you need to think about mental retardation. So when you take a summary of it, here you should be knowing about 79% of caries was being told as a prevalence rate by Bavsi et al. And Harwood 1995 as bulimia nervosa. And apart from this, calculus is major cause for this improper cleaning and more amount of periodontal conditions as said by Kumares in 2009 and Dinesh Rao in 2005. Malocclusion is seen in 66.2% in Mary, said by Mary et al. And 16% abnormal TMJ movements was said by Bowat et al. And apart from this, they have an uncontrolled movement of the jaws, and because of this dyskinesia, and it was being told by Ahibog as 35.7%. Because it's very important, like whenever you write your exam, this one, it's very important, like you can quote at least 1 or 2 authors for these general dental conditions, either being it's a caries or a malocclusion or a periodontal part of it. Okay. The next one is cerebral palsy. Cerebral palsy is actually, what can we tell is it's a non-progressive disorder. So what is the problem in this children is movement and posture will be affected. So what happens is that it is a non-progressive disturbance. So the child will be, that is occurring in the fetus or the infant brain itself. Okay. So what do you see with the cerebral palsy children will be some amount of mental retardation will be seen, and they will not be able to cope up with the, what it tell, their extremities, that's a major difficulty whichever we see. But depending upon their movement scale and their IQ scale, we can just, they are educable as well as trainable to certain extent for our initial investigations. So that is very important. What is the etiology for these? It's as usual, it's prenatal, natal and postnatal. So what are the major classifications which way you see is here, your spastic type, your athetoid type, and then your ataxic type. You have the other mixed ones also, but these three are the major common. 70% is the spastic type. So where does a problem occur in the case of spastic is actually your cerebellum. Whereas in the case of athetoid type, no, it is basically the basal ganglia. So if you know where exactly the problem arises, you will be able to relate it to the signs and symptoms whichever the child is undergoing. Okay, the ataxic is actually the cerebral cortex. So in the case of spastic, what happens is when you're going to tell about these different conditions, you can see that the spastic, no, it is the word itself you can tell. So more of hypertonicity will be seen. So more amount of increased tonicity of the muscle, the spastic. Whereas athetoid, no, it will be the loosen, the tonicity of the muscle will be completely increased. So open mouth condition, and then what else? Class 2 div 1. Because of open mouth condition and the hypotonicity, the child will be always protruding their tongue outside and they will be placing their open mouth condition. So class 2 div 1 will be most common with them. So that is, whereas in the case of ataxic, no, what we can see is that the fine movements alone will be affected in these child. So something like, there are other things will not be affected, not much other movement. So fine proprioceptive movements, that is for them to catch something or to move something, catch hold of any toothbrush or this one, that is the major difficulty with this child. So depending upon their IQ level, we can always train them on the dental chair. Okay. These are the different types of modifications which we need to do in order to increase our proprioception. So what are the general considerations here is actually oral aversion. Drooling is a major complication with them, and because of their reflex, there is more amount of erosion which is also seen with them, and dysphagia and UTI is highly frequent with these children. So as I told you, in the case of spastic type, there is hypertonicity will be seen. So when you tell it as hypertonicity, automatically flat anteriors, so hypertonic facial muscles, grimacing, all those things, all things which is related to hypertonicity will be seen. Whereas in the case of athetoid, it is actually hyperactive tongue showing wave-like motions. You have a difficulty in the case of swallowing, in the case of spastic as well as athetoid. Here, in the case of spastic, they will not be able to do the proper wavy motion. Whereas in the case of athetoid, here they will not be able to properly position them because of the flaccid nature of the muscles. Okay. In the case of hypotonic, it's completely relaxed. The other things is something, the other habits which is associated with them will be rechewing the already ingested food, and craving for the non-edible items is another general finding which is seen with these cerebral palsy children. And apart from this, is dental management is very similar to that of the mental retardation, but depending upon their IQ level, we can always educate them for the initial thing, and then we can go, once these restraints and all those positioners are just not to restrain their movement or to create a negative one, it's only to what to tell, this flapping one has to be positioned. But very important over here is, whenever we use this restraints also, we should be remembering that the angulation of it should be that it should be conforming to their usual way of movements like that. Because of the flapping or lateral movements, what happens is their midline or mediality would have gone. So it's very important, like we find confirmed to the what is their comfort level whenever we place any positioner and we are going to do a head positioner or even an extremity positioning like that. Okay. The next important thing which we need to tell, apart from your dental caries and your periodontal diseases, is sedation. So very important is the drugs part of it, wherein antacids and anti-reflex is very important, as I told you. And here, very important is when the use of anticholinergics, what happens is reducing the secretions. But once again, it might have an effect on the pulmonary secretions also. So that has to be taken into account. Apart from this, they have a difficulty because of this hypotonicity, everything. So there is a difficulty in going in for intravenous access also. So for which special care has to be taken. When you take up this respiratory abnormalities, there are more chances for aspiration and is seen with these children, and esophageal dysmobility is also seen with them. Apart from this, gastrointestinal, because of the lower esophageal sphincter tone is decreased, that's the reason why they go in for this GERD, and as well as they predisposed to aspiration also. And apart from this, we have our tongue thrusting. This is also because actually it's complicating the conditions for airway management. And apart from this, the trachea, upper trachea will also be involved. So placing a smaller side tube is always seen in these children. And automatically, because of this lower esophageal sphincter is actually relaxed, what happens is mostly these children will be on the feeding tube actually. So when we do the intranasal tubation, we need to keep an eye on this as feeding tube whenever we are going to have it. Apart from this, is the anticonvulsant medicaments whichever way they are using is to be into this one, because what happens is it increases the blood dyscrasias and automatically our postoperative complications will be added with them, and they have the respiratory muscle paralysis also will be seen with them. And most of the drugs which has been used to decrease their movement or antipsychotic is actually going to cause a delayed arousal from the anesthesia, and even a bradycardia, decreases respiratory depression will also occur with them. So it's very important, like we need to have an proper coordination. When we take up the anesthetic other considerations, very important is propofol is the most desirable drug over here, and for the muscle relaxant, and whenever these children are given a muscle relaxant as a pre-medication agent, what happens is it increases the secretions. So these secretions actually cause some amount of drooling or something like that. On the other hand also, for us the visibility for placing the intubation will also be very difficult with these patients. So added with the scoliosis and their movement of the extremities, so treating them with the endotracheal intubation has to be very careful with these children. Post-intubation also, it may pose difficulty due to contractures and spasticity, and there are more sensitivity, tendency to ulcers because of their sensitivity to narcotics. And another important thing with them is that their minimum alveolar concentration to the inhalation agents. These cerebral palsy children, they are highly sensitive. So what happens is there will be an initial, the arousal will take a longer time, and for them to go into a deep sedation will be less also. So that is the other important consideration with them. Okay, so this is regarding the cerebral palsy. When we take up the authors, when we can see that mostly it is related with the dental caries part of it. It is mainly because of the sugar consumption, as said by D. Camargo. And very, at least you should be telling, as I told you, you should be able to tell at least 2 or 3 authors. Christina et al. In 2010 has told that it's more of open bite, it is being seen with these children, whereas Chandana et al. In 2011 has said that this class 2 malocclusion is more prominent with them. And there are so many studies of which Boti et al. Has said that they have a high plaque index with these patients. And Anjana Aneja, once again, a routine in assessment of vision and hearing is being associated with this cerebral palsy patients. Okay, so this is regarding cerebral palsy. The next one is epilepsy. Here we know that epilepsy is your epileptic seizures, wherein here it's a neurological disease and only applied in the case of 2 unprovoked seizures more than 24 hours apart, and they are said to be non-epileptic. They have no seizures for 10 years, because in the history sometimes whenever they come into this is we have a history of no seizures of it for more than 10 years, then we just suggest them to be as non-epileptic. Otherwise, even a medication of not more than 5 years are also being categorized as non-epileptic only. So the etiology, as usual, we will be knowing that it's idiopathic and traumatic as prenatal, postnatal, and natal. That's a general etiology for them. And we classify them as a localized or generalized, and mainly depending upon the way in which it is involved. Generally, this absence of seizures will be generally seen like there is not much of a seizures which is seen in 4 to 14 years. Some 10 to 25 seconds alone, but it will occur many times a day. Whereas in the case of myoclonic, some amount of muscle contraction will be seen, but no loss of consciousness. In the case of atonic, you will have it with the neurological disease. There will be some amount of neurological disease involvement. In the case of clonic, you can see that there will be a clonic jerking will be seen on the bilateral side. Both sides will be this one. Whereas in the case of tonic, we can see that with loss of consciousness will also be gone. And apart from this, we can see that they will have an aura will be there, and a post-ictal phase will also be there. So very important, like when we take a history for these children, and we should be able to find out like what are the triggering factors, and how early does it occur, and what are the things in the triggering factors itself, as aura which can lead to a seizure, aura just goes off just like that also. What are the factors which provoking seizures, and how long does it occur, and what are the other things which has been related to their sort of like consciousness and the respiratory state of the patient. All these has to be taken into account when we take a history part of it. Mostly when we take up that is a treatment part of it, we are supposed to have it as morning appointments, because to decrease the stress part of to the child. And apart from this is any sudden movements always should be avoided. So the same way we need to have a empathic speech and slowly explaining to the child as repetitive manner as what we are going to do to them, and explain to them, keep them aware of what has to be done. And if you're going to do it in a slow and steady manner, I don't think it's going to be an issue. And apart from this, but GA is a general option, ideal option for treating these epileptic patients. And the other things which has to be kept in mind with these children is gingival hyperplasia, because of the phenytoin whichever they are using. So in these cases, it's very important, like we can refer them so that there can be an alteration of the drug also. And an importance has to be given to the preventive part of it, because plaque and calculus, and to the regular brushing techniques and all those things. Okay. Next, coming on to autism. So autism is recently most asked question actually, that's what I'll tell. So what exactly is autism? So it is not any neurological disorder or anything. It's a developmental disorder, or it's a behavioral disorder exactly. And what happens over here is that there is a difficulty in the communication, and they'll have some repetitive movements. So 3 important things which you should be having in mind is social interaction will be affected, your communication will be affected. The next one is they will have repetitive movements will be seen with them. Okay, so this is actually a complete umbrella which is having, it is autism spectrum disorder. It is an umbrella which is covering so many things. Okay, so if it is only the autistic disorder, means we have communication, language, as well as repetitive movements. Whereas you have to differentiate it with the, if it is Asperger's syndrome, we see this, these children will be concentrating on only one thing at least, any one toy or one, and this one. There is some children will be seeing only one and cartoon repetitively. So only one thing they will be concentrating. Whereas in the case of Rett syndrome, they will be child will be very normal till 6 years of age. After 6 years of age, what happens is slowly there will be a difficulty in communication and coordination with the others like that. And apart from this, what happens is even their development of their brain size also will decrease. So the another one is your pervasive developmental disorder, wherein they have a difficulty in the social communication, whereas they have a very good language skills. So it's very important, like we need to know what is the differential diagnosis when you take up autism. Okay. So this is something like, according to ASA, it is a complex developmental disability which appears during the first 3 years of life. It is a result of a neurological disorder affecting the normal functioning of the brain, and it will impact the development in the areas of social interaction and communication skills. So first, after telling what is the diagnosis, what is the definition part of it, now we go to what is the theories behind it. First is your psychodynamic theory, is mainly, what do they tell over here is, the pathological parenting is a major cause for it. The child is being withdrawn from theirs or they are completely away from the other outside environment itself. That could be one of the cause for autism. The next one is your refrigerator mother theory, wherein here the mother is very emotionless. That is, either they'll be working or something like that, so they will be not corresponding to the child's movements, or they'll not correspond to the child's speaking or this one. Generally, the mother is, when they are communicating well with the child, the amount of development will be more like that. But here, that will be actually lacking with them. The next one is theory of mind. Here, it's a deficiency state of mind, in the sense like they have a failure to read to others. They will just not concentrate on the others alone. They will be concentrating either to themselves, or they'll be away from all this. The next one is your theory of executive dysfunction. It's a complicated one, wherein here they will be able to understand, but they will not be able to execute it properly. So that is this executive dysfunction. And the next one is your weak central coherence theory. They will contest in a sequential manner, but they will not be able to think in a wider aspect. So that is the major thing with them. So, but the most accepted one is Kanner's theory, because autism itself, the term was put forth by Kanner. So they tell that it's mainly biologically based defects, or the mainly one thing which is responsible for autism. So when you take up autism, now we know what is the different theories behind it. The next one we will see, what is it? What's the etiology behind it? It's, as usual, it's your genetic, your prenatal or your perinatal, and then your natal causes, and some amount of environmental causes, mainly because the child is completely outside, away from the communication with the outside environment. So there is a systematic review wherein which they were able to tell about the different factors. So something like they have enumerated some many categories like that. So one is all these. In these categories, if the child is having at least 6 of them, the child is being supposed to be told as supposed to be affected by autism. It's one is about the social interaction. That is, if the child is able to see us directly and also to respond to our facial features, that itself is one category. The second one is if they are able to speak to us back and correspond to our answering itself. And then if they are able to acknowledge our, that is either their achievement or even the opposite person's achievement. All these are some different categories whichever they have given. And if among these, if 6 of them is at least minimally present, the child is said to be affected by autism disorder. So what are the most common things whichever you see with these children? It will be like, they will have a social deficit is the first important thing. So they will, lack of eye contact will be there. They will not see the mother itself. Even if the mother is calling by their name, we can see that these children will not be responding to their parents also. There will be a delayed speech because less of social interaction and communication. So automatically language development will be affected. Once again, speech development will also be affected. Then preference for isolation. They will not be interacting with others. They will be interested in any one object or any toy or anything like that. They will be only with that, either with a mobile or even with one toy alone. So preference for isolation, unable to empathize with others, and repetitive speech. They will be using one word or this one, and there have been incidences where a child been seeing Dora and they will be speaking only like Dora and using their words like that. So repetitive speeches like that. Mood fluctuations. All they want is actually a sameness, or they don't want to have any change in their routine. So that's a very important thing when we need to consider when we are going to treat these children also. Abnormal motor behavior, in the sense that what happens is these children sometimes, because if they are in their extent, more of when the mental retardation is more, what happens is they will bang themselves onto the wall like that. Self-injurious habits is more. They will be pricking onto their gingiva, pulling the hair, all those things will happen. Sometimes they will be flapping the fingers or the hand, or it will be a habit for them. So these repetitive movements and abnormal motor behavior will be seen with these children. And self-injurious behavior. 70% of these children will be associated with mental retardation, and 30% to 40% will have sensory disorders also. So something like certain sensations. So all your other sensations will be affected. That is, they will avoid firm foods like that. So from the first itself, the mother would be, after weaning, they will be going in for they will be mashing it and putting it in a mixie or something like that. And so they will not be comfortable with firm foods, and they will not be comfortable with the brushing itself. So they will just, it's not an, definitely negative part of our uncooperative part of treatment part of it. It's mainly because they are not able to take up hyperactive sensation inside the oral cavity. So they will not be able to take the firmness of the toothbrush, or even a spoon or a mouth mirror which is placed, or any food, anything like that. Okay, so that is a major thing. And even they have abnormal sensation to the light and all those things. And so this will be regarding the clinical features whichever you see for the autism. What are the oral manifestations? Because of the general conditions, they have a poor oral hygiene, and they have more amount of dental caries with them. Apart from this, we see that they have a repetitive movement, and that's why they will go in for this bruxism because of this tension and all those things like that. And erosion due to regurgitation will be seen. Apart from this, tongue thrusting is another common habit which is seen with these children. And self-injurious habit will be is prevalent is around 70 to 80% of these children. And prevalence of anterior open bite and delayed tooth eruptions also. This is how it's been told. 25% of damaging oral habits, and 50% of dental caries, and 65% with periodontal problems, and 25% as trauma to oral facial regions, and delayed eruption around 80% of the children. These are the signs and symptoms which you need to be seeing with these children, starting from the birth itself, and with young children as well as with teenagers. That is how they are able to interact with the mother and to the external environment. Finally, when we come to the dental management part of it, it's very important, like we need to, here we have many things like what to tell. First is your pre-visit parent consultation. Wherein here, apart from the other special children, these autistic kids or something like, they want the sameness, that environment itself. So incorporating them into our dental clinic is very important. So pre-parent consultation and home preparation. That is, here what do we do is that we take up pictures of the dental clinic and the procedures whichever has to be done, and that is stuck into photographs and made into an album, and that is being shared with the parent, and first explaining to them, and then they actually incorporate that into their children's daily characteristics, a daily routine, and that will happen, that is desensitization for at least a month, and only then they will be able to sit into a dental chair itself. It's not that they are not uncooperative, it's very important, like we need to desensitize them to the newness of the dental procedures as well as the dental environment. Okay, so that has been done, that is called as visual pedagogy. Okay, this was introduced by Bachman in 1999, wherein you have a photo books has been given. But later they found that video modeling was better when compared to visual pedagogy. So here, video modeling, either a self video or even a video modeling point of view. Another person would have been doing a video that they would have been enacting the dental procedure, that would have been. So this has been explained to the patient or the autistic child as how they are supposed to behave over there. And apart from this, we have TEACH. This TEACH is actually treatment and education of autistic and related communication and in a handicapped children. It was introduced by Shopler. This is exclusively for autistic children, wherein here they are incorporating desensitization along with visual pedagogy. Apart from this, you have your applied behavior analysis, and applied behavior analysis, you take up a simple behavior, something like toothbrushing or something, and then we split it up into different parts, and we encourage them to do in these simple procedures or the different parts so that they get it into the normal routine, because grasping the toothbrush itself is a very big difficulty for these children. Okay, and apart from this is said environment. When we treat these children, it's not like the anxiety of them is mainly because not only for the fear of the dental treatment as well as fear of pain or anything like that. Apart from this, even the sensations whichever is present, the sudden lights and all those things. So when you're supposed to inspect a child, autistic child, we never use our dental chair child. We use a overhead light will be given, and after that, and also we need to do a slow and steady movement of all your moving your handpiece or moving your light or even any other equipments also, because very important with this autistic child is that they have peripheral vision. So what happens is, even if you move something behind them, they will lose the trust as you are actually doing something else. So that's very important with them. Apart from this is making them understand things and repetitively explaining them what has to be done and what is going to be done and how are we expecting them. That is repetitively we are explaining to them, and then we can have their cooperation in a sensory environment according to the sensation whichever is affected. That is a shade environment, that is a Snoiseland environment, wherein you have LED lights and all those things will be activating their light sensations, and it will calm the child actually. Okay, so this is regarding the autism. Okay, so at least there should be 2 or 3 authors when you were able to tell about any special child patient. So here 75% of autistic childs, they suffer from moderate range of mental retardation. It was put forth by newspaper, and the amount of temper tantrums and self-injurious habits are 7.5% as told by Kleinu, and Shavo Y told that there is more amount of mental retardation which is seen in female. Apart from this, as RAID has actually told, and they made a prolonged study wherein they were able to tell that the preventive part of these autistic children, they are less use of fluoride has to be done, because it is actually more of toxic for these autistic children, either because of the nature or something like that. And apart from this, even amalgam, they don't go in for composite because of the carcinogenic nature according to them, because they are highly sensitive, and more of GIC or amalgam only was being considered. And apart from this, they have more amount of sensitivity to gluten and casein. So what happens is they have an internal leak, as I already told, like more of erosion and all those things. So what happens is gluten and casein will just wash out, and it will affect their brain system. So what all these things can affect their brain system has to be completely avoided. So fluoride itself is actually a question of this one with these autistic child like that. Apart from this, Raposa found that books of pictures like this PECS, that is picture education system, was better acting and reduces anxiety in these children. Okay, so this is regarding autism. So you know what is autism, and so the classification of it, the spectrum of it, and then what are the other considerations which you should be seeing with an autistic child, and finally 2 or 3 authors regarding it. Okay, going on to hearing impairment, wherein hearing and speech is actually it's a clinical condition in which they are unable to detect or perceive the sound. It can be either a conductive one or a sensory neural one. That is conductive one, in which here they will not be able to, there is some deficiency in the impulses which is being transferred from the outside to the inside environment. Whereas in the case of sensory neural is inside, that is, they will be able to hear, but they will not be able to process it properly. That reflexes would have been affected. That's a major thing with them. And the classification exactly is mild, partial, severe, profound, wherein depending upon whether they are hard of hearing or if they want to have a hearing aid or difficulty in learning language, lip reading, and any manual method. So what is the etiology? Apart from your genetic and your drug induced, you have your measles, mumps, and trauma could be the major cause for it. What is the communication method? Hand signs and lip reading is the most commonly used one. When we see the oral manifestations, it's mostly mouth breathing is said to be seen with them, along with xerostomia, an increased prevalence of dental caries and periodontal infections, which is not related with this, with the hearing disorder, and almost it's mainly because of their negligence. So dental consideration is to gain trust with them through communication and do all the behavior modification techniques and early morning appointments and avoid long appointments and emphasize on the preventive strategies and avoid macrolide antibiotics because they are supposed to affect the inner ear. Okay. So visual impairment in which you have a functional limitation of the eye due to disorder of the disease. There is a visual handicap, or in the other words, wherein here it can be a low vision or a blindness. So the etiology is albinism, cataract or retinitis, depending upon whether it is a central nervous system involvement or it's a diabetic retinopathy over here. And diabetic retinopathy is another more common cause of it. Oral manifestations, no direct influence in the oral cavity. They have a poor self-care. It's a major cause for it to oral hygiene. And apart from this, they have xerostomia. That's a major cause for dental caries in these children. How are we going to manage them? Establishing a proper communication, knowing the preferred way of communication, and slowly introducing them and going in for Braille method. And as usual with these children, avoiding strong lighting and doing all the behavior shaping methods and using audio analgesia. And when we take up these children, one thing we need to remember with them is I stumbled is one thing which you can have. One is images, your sign language, and then T is trauma, and U is completely unaware of things, and then M is using models, give them related breaks during your treatment. Finally, they will concentrate too much on your lip movement, so it's very important, like you emphasize on the lip movements, okay, and being enthusiastic and desensitizing them is another thing which they use it over here. And then when we come to the studies, we see that children with sign language had mediocre dental hygiene, as said by Maria Moyne in 2024, whereas Saikran found that video modeling was better, and they showed a decreased plaque scores when compared to the sign language. And apart from this, Alyami et al. Has reported dental caries as a common issue affecting 65% of the children with hearing impairments. Okay, so this is regarding your special children. And I'd like to add one more thing about drooling alone, because drooling is one short note. Sometimes you can get it. So what is drooling? Drooling is nothing but siluria, or what can you tell? It's unconscious loss of saliva. So what is how are you going to, when most of these mentally retarded children or any child who's their central nervous system is affected, automatically they will have this drooling as a symptom, which is seen in cerebral palsy patients, mentally retarded patients, some amount of autistic childs will also be seen. And so what is a major thing? How are you going to categorize them? You have mild, moderate, severe for them. If the amount of saliva is present till the vermilion lip borders, it's mild. And if it is going till the chin, it's going to be moderate. And if it is dripping onto the, on the cloth, it's going to be severe. So the etiology is either a neurological etiology, or it can be in a language difficulty. In that case, that is autism also. Then apart from this, what are the factors which you have to consider? Integrity of the oral structures is wherein here hypotonic lip muscles or a hypotonic tongue and orofacial structures, all these would be an added factor which causes drooling, apart from your central nervous system factors. And oropharyngeal motor function is actually centrally involved, whereas orofacial sensory perception, that depends mainly upon their sensation. That is how much amount of increased sensation which they feel towards it, and rate of salivary secretion. Here we see that generally it is 1 to 1.5 liters, and 90% of it is actually contributed by your major salivary glands like your parotid, submandibular, and sublingual gland. And but you have the less of 10% of that is 0.4, which has been contributed by your minor salivary glands. So any surgery or anything like that, it has to be done only after 5 to 6 years of age. it is a very common component. Drooling is a common component or very physiological within the first 18 months age of any child's development, whereas any surgical or any intervention has to be done only after 4 years of age. And also we see that what the major part of treatment is, one is actually we train for behavioral therapy. Behavioral therapy is something like we split generally in swallowing we have 3 different phases. So we have to make the child understand that they're placing their tongue and pressing on to the hard palate just behind their incisors is the most important and the first important step. But this mainly depends upon the educable nature of the child, their IQ status, and how much they are cooperating, along with the parents' coordination also. So that is the behavioral therapy. The second one is the pharmacological, wherein here we give anticholinergics drugs we generally prescribe. But once again, that anticholinergic drugs has to be taken in caution, because in the case of CP patients, anticholinergics is said to cause respiratory spasm also. So that's very important. And apart from this, surgical. In the case of surgical, what happens is one thing which we can do is we can ligate the duct, or we can completely remove the parotid glands, or we can just divert the secretions onto the fossa. That is the fossa which is covering the gland actually. So very important is surgical is done at the very last resort, only after the adult age, and that too only if the child has major complications because of this drooling. And once again, and this is the last slide. So we have the other complications with surgical is actually xerostomia. Because of this, we have xerostomia and ulcerations, and there'll be ballooning effect and all those, the other complications with drooling. And orthodontic is actually, we have a Castle-Morales appliance has also been advocated. It does, this has been tried with patients, and it has been found to be having a positive impact. So this is regarding drooling. So this is regarding, these are the things which I'm enlightening you for special child. I think you would be knowing it already. These are the few factors which you should be keeping in mind. The way of your presentation started with your definition or something like that, with your etiology and the general factors, the systemic factors, and then you go in for oral factors. Try to incorporate at least 2 or 3 authors at the end of your thing. Is it okay? Thank you. Thanks a lot.
Thank you so much, ma'am, for the insightful session. Now I would like to invite Dr. Jessie to present ma'am with a memento of appreciation. The lunch is served in the dining hall and the ground floor for the speakers, and for the participants, it's in the same place as yesterday. Thank you. is Dr. Dhanraj Kalaivanan. We are honored to welcome you, sir. Dr. Dhanraj is a reader at Satyamba School of Dental Sciences, Chennai, and the founder of Dharini Divine Smiles and Smile Kids and Adult Dental Clinic, Madipakkam. He completed his BDS at Tamil Nadu Government Dental College and MDS in Periodontics at Bapuji Dental College, Davangere. With over a decade of academic and clinical expertise, Dr. Dhanraj's interests include early childhood caries, dental trauma, myofunctional orthopedics, and behavior management. He is a resource person at national and international workshops. He has authored chapters on 3D printing in pediatric dentistry and reviews for several reputed journals. A life member in multiple professional societies, Dr. Dhanraj combines evidence-based research with innovative preventive pediatric practice. His recent studies on screen time and early childhood caries, as well as his contributions to value-added courses, reflect his passion for advancing pediatric dental care. We're delighted to have him here today.
Thank you. Shall we start? Yeah, okay. Very good afternoon, one and all. Good afternoon. Okay, after sumptuous lunch, it's very difficult for everyone to listen, but I make sure that I'll cover it maximum because dental traumatology is altogether a different topic, and when you analyze that, it doesn't come much on the theory part. Mostly if you see it, it may be coming as a short note or most probably come as an essay, most probably in paper 2, that is clinical periodontics, as well as in paper 3 as a short note sometimes. Yeah. I used to start this with a quote: definitely believe in yourself, definitely you can achieve it. We have achieved it at the last minute, and you can also achieve it at the last minute. So no need to worry about it. Okay. Thanks for the brief introduction, Doc. I'm a reader in Satyabama Dental College. So, and I thank once again for the organizing committee of SPARC, Dr. Deepa ma'am and Dr. Mahesh sir for giving my name and making me to present here. I'm going to talk a little bit how to revise a broader super specialty topic almost. It's traumatic dental injuries to primary and permanent dentition. I'll make sure that I'll finish it within 45 minutes to 1 hour. Okay, on time. Okay. Okay. So when we think about how to revise dental traumatology, so first you need to be very, very confident about what you need to know, that is basics. So analyze the question and papers and try to know about the clinical guidelines, which is International Association of Dental Traumatology Guidelines, which was published in 2020. Okay. Analyze the question papers accordingly for the recent past 5 years. So mostly it may be a clinical based questionnaire, either how to manage an Owl's tooth or how to manage an Ellis class 3 or Anderson's complicated crown fracture or an luxation injury. All those things comes in a clinical based question as an essay. Or it may come as a prevention of dental trauma is a short note in paper 3, or it may be recent advances or anything with respect to paper 4 as well, even sports dentistry as well. Okay, so as I told you how to revise it, so you need to be knowing much about the recent clinical guidelines, and then focus on the recent studies which is happening in the field of dental traumatology that may be desirable to know, and then focus towards the examination. So we'll start with it. So you know it very well that dental trauma can be classified into simple, that is traumatic dental injuries can be classified into hard tissue injuries and soft tissue injuries. So the prevalence, which is very, very important for you, because prevalence, the evidence-based dentistry shows that in permanent teeth, most injuries are commonly tooth fractures in permanent dentition, followed by displacement and combination injuries, according to recent IADT guidelines 2020. So when we think about this, we have to know about what is the recent question can come up upon this hard tissue injuries. The most commonly used classification systems that can ask as a short note, or a recently used classification systems or recently used indices for traumatic dental injuries. So the oldest one was given by Ellis in 1950, who classified traumatic dental injury first, and then followed by an Ellis and Davy classification in 1970, followed by Anderson classification in 1981. So if they ask you a question about, what are the classifications used in dental trauma? Suppose something like that. So what could be your contents? So the introduction may be why there is a need to be, why you need to classify dental trauma. You can add as an introduction, followed by the evidence-based prevalence and incidence of dental trauma injuries like luxation injuries prevalence, followed by the hard tissue injuries prevalence according to the recent IADT guidelines 2020. Then you start with the most commonly used classification, that is Ellis and Davy, and followed by the Anderson classification. And then you can go ahead with the history of chart of classifications which has been happening, because 54 classifications till date are available for the classification of traumatic dental injuries, which starts from 1951 till 2022. Okay, so we'll give you the history chart of classification and what are the new classification systems you can end with, and with the recent conclusion and references. So I'm not going to much talk about it, because you know about it, the Ellis classification system, class 1, class 2, class 3, which was done in 1970, where they gave it like a simple crown fracture followed with a little or no dentin affected in class 1, whereas extensive crown fracture with considerable loss, and class 3, class 4, class 5, class 6, and class 7 and class 8, which class 9 comes under the traumatic injuries of the primary dentition. Whereas in Ellis Davy classification, modification, what did they add? In class 8, instead of if you see in that class 8 here, only the complete crown fracture and its replacement was given in Ellis classification, whereas in Ellis Davy, it was crown en masse in class 8. That was the difference. And then came the Anderson's classification, which is still now followed because it's the most complete clinical classification till date. And it was subdivided into injuries to hard tissues and pulp, which is divided into crown infarction, uncomplicated crown fractures, complicated crown fractures, and uncomplicated crown root fractures, followed by complicated crown root fractures and root fractures. And then the injuries to the periodontal tissues, along the concussion, luxations, all the types of luxation, followed by avulsion, and the injuries of the supporting bone. So these are the basics of the Anderson's classification. And then when we see the history of the chart of the classification, you can see that from 1955, there are classification by Sweets, by Rabinovich, by Bennett's, Ulfon, and then came the Ellis, and then came the Garsha-Godai. There are so many classifications till now, and there are separate classifications for the anterior teeth alone by Spinas. So you can see that in 2002, there was a classification by Spinas in 2002, then a McDonald classification, and now you can see the recent classification which is coming as NAOD, that is in ICD-11, followed by the Eden-Basil's Dental Trauma Index, which is the recent classification which happened in 2021, followed by the modified Eden-Basil Trauma Index, which comes under 2022. Okay, so these are the recent history of the classification from 1955 till date. So what are the limitations of the older classification, which is the most commonly used classification you can write about, then that is which is Ellis Davy, where we found out that there was a simple and an extensive, because it was a more judgmental and it was subjective interpretation criteria, which was the drawback of Ellis and Davy classification. You can mention that as a drawback. And whereas Anderson, it told us complicated and uncomplicated, which was a little bit confusing for the clinicians as well as for the researchers. But Anderson more clearly he justified that it is more pertainable to the clinical and therapeutic based in classification. So these are the history and the drawbacks of the older classification. Until date, what are the classification systems available? So when you see what are the total classification systems used till date, There is an article called A Systematic Review given by Felicino in 2006, where they compared with till 2003 what are the classification systems used in the studies, and there was almost 54 distinct classification, and you can see now that it's the Anderson classification dominating there. So that's why you can show that why it is most common classified systems. These are the studies, and then we are going into the recent classification system, that is the ICD-11 NAOD classification, Eden-Basel Dental Trauma Index, and modified Eden-Basel Dental Trauma Index in 2021. So what is ICD? ICD is nothing but it is a WHO classification of the International Classification of Diseases. So it was first involved in 1995 by WHO, but in 2018 they followed the Anderson's classification and it was named in the ICD-11 book. Okay, but it had a limitation in 2018. There was no inclusion of the subgrouping. This is the one of the limitation of the previous WHO classification, that is ICD-11. So there was no subgroups for dental trauma. All hard tissue as well as the soft tissue injuries were put in separate classification, and hard tissue injuries were coming under the head injuries. So that was the limitation in 2018. So you can see that that injuries to the periodontal tissues were called under the dislocation of tooth, which was placed in the capsular joints or dislocation or joints of ligaments. So they completely had that in a separate group which is not related to dental at all. So that was the drawback of ICD-11 2018. So then in 2022 what happened? The IADT, that is International Association of Dental Traumatology, put a proposal number 2130 to addressing these limitations, and then came the NAOD, that is a separate classification for dental trauma in WHO classification, which happened in 2022. So if you see this chart, you can understand that pretty well. That is, if you see that the NAOD classification, where the traumatic dental injury has an separate NAOD point O. You can see that. So that gives you that. So NAOD point O, that is for the hard tissue injury, and the enamel fracture combines like O1, that is 0.02, 0.03 until then. And you can see a second group here, that is the injuries to the soft tissue and the supporting tissue, which is given as NAOD point 10, which is the injury to the periodontal tissues. From there it is 1112. So this is a separate classification which is included in the WHO, which was a great victory for the dental professionals. So which is very, very important. Once next after this 2022, the NAOD classification, another important classification which came under is Eden-Basel Dental Trauma Index, which is a 5-digit index, and who gave this? It's Dr. Ees Eden and Mehmet Baysal. They are from Turkey, that is from the EJ University, Izmir, Turkey. Okay, it's a 5-digit index where you can see that the 5 digits indicates what? The first digit is the number of the tooth which is affected, that is in the FDA coding, and the second digit indicates you from 0 to 5, that is it can be a 0 to 5. 0 is no trauma, that's a, and then the 1 comes the uncomplicated crown fracture, that is involving enamel. Then 2 indicates that enamel and dentin, followed by 3, and 4 and 5 are the crown root fractures, which is complicated and uncomplicated. You can see that in the picture. And then the third digit indicates whether there is an associated luxation injury or not. So which is indicated in 0. So the second digit indicates the 0 to 3, whether there is an associated root fracture, whether it is in the 1 indicates the apical third, the 2 indicates the middle third, and the 3 indicates the cervical root fracture. And the third digit indicates the luxation injury, where the first letters are N is none and C is concussion, luxation or extrusive luxation, or lateral luxation or an avulsion. And then fourth digit indicates the maturity of the apex, that is whether it is an open apex or a closed apex. I stands for immature, M stands for mature, R stands for resolved. And the fifth digit is indicates the alveolar process fracture. If the tooth involved has an associated alveolar process fracture, then positive indicates that there is a fracture, negative indicates there is no alveolar process fracture. There was a modification once again in 2022 where they included one more digit. Now the 5-digit index has become a 6-digit index, where the abrasion are the associated soft tissue injuries. That is, the surface abrasions have been coded, that soft tissue injury, where you see a lip abrasion from, there is no, then it is 0. When you have an intraoral avulsive injuries or the lacerations, which has been rated from 0 to 8. So these are the recent classification systems till date for the dental trauma. Now moving into the hard tissue injuries of the permanent dentition. You know that, so it is classified into uncomplicated crown fracture and complicated crown fracture, which involves pulp, and the crown root fractures and the combination injuries. So what does the IADT guidelines says it? So when there is an uncomplicated crown fracture, if the tooth fragment is available, it can be bonded back to the tooth, and depending upon the extent of the location, it can be smoothened or a composite resin can be placed. Whereas in the uncomplicated crown fracture, the involving dentin, the same thing. Here the important point is the rehydration. If the fragment is not available, it can be rehydrated by soaking in water or saline for 20 minutes. So that is very, very important. So from this hard tissue injuries, there can be another short note or an essay on this, what are the fragment reattachment techniques available in the literature. So if you see into the fragment reattachment, so there is the history telling that Edelman and Chosek, he was the first who published a case study on fragment reattachment treatment. There are different techniques of fragment reattachment available in the literature, which is called as simple reattachment, enamel beveling, V-shaped internal and enamel groove and dentinal groove, and then external chamfer, over counter, vertical groove, and pinholes. There are almost 8 types of reattachment techniques which is mentioned in the literature. So which is very, very important. And then you can see about what is the advantage and the disadvantage of the reattachment techniques. Whereas the simple attachment, which is a very minimally invasive, no preparation of the fragment or the tooth. Whereas circumferential enamel bevel indicates that it should be beveled circumferentially 45 degrees across the tooth as well as the fragment, and more blends with the fragment. The only problem is the discoloration of the composite interface. And then you go into the internal enamel groove that is done on the inner surface, which is called as Simonson technique, and internal dentin groove as well as 1 mm and depth and width. So the disadvantage of both of these techniques, after preparing the groove, there may not be a perfect fit of the fragment as well as the tooth surface. So there may be more amount of composite interface in between. The other external techniques, if you classify it, there is an external chamfer which was given by Davis et al. In 1983, and then an over-contouring technique. And there is a pinhole on the vertical grooves. You can see a vertical pinhole groove, that is, there is a pinhole in the dentin connected by a groove here. So you can see all these vertical grooves. So you can, this is a pinhole technique as well as the vertical groove technique, where you see the bonded fragment along with the vertical groove where a fiber post has been attached. So these are the examples of reattachment techniques for the enamel, that is hard tissue injuries, that is complicated or an uncomplicated crown fractures. So what are the factors influencing the success of these reattachment techniques? So if you see, the technique plays a major role. As we talked about, there are 8 techniques mentioned in the literature. And then rehydrating the fragment, there are different time protocols for rehydration, whether in IADT guidelines it says around 20 minutes, whereas in certain literature it takes around 1 hour. So you have to, there is no clear-cut criteria whether it is 20 minutes or 1 hour, and the intermediate material, whether it's a composite material or a resin cement or the class ionomer interface, may also influence the success of this reattachment technique, and the materials used as a bonding agent. So most of the literature states that the total edge adhesive plays a better role when compared to the self-edge adhesives, but still there are many controversies. So one of the important the factors which is influencing, that is what? The hydration of the fragment. Why the hydration? They may ask you in a viva, so what is the reason why we are rehydrating the fragment? So if you see that when the fragment is retrieved and it has been kept dry, it makes the dentinal tubules open. So when you attach the bonding agents, we apply the bonding agent, the enamel tubes are open and it is blocking the penetration of the bonding agent. So which may not improve your bond strength of the reattached fragment. Whereas once you rehydrate it, it it expands the matrix, the dentinal matrix expands, the tubules becomes open very well, the bonding agent penetrates deeply, and then leading to a good fracture resistance. The deeper bonding penetration helps in the better fracture resistance of the reattached fragment. So when you see into the studies, what are the important protocols in rehydration? As I told you, IIDT guidelines says that it is 15 to 20 minutes, whereas the other article says that 24 hours has a better success in fragment reattachment for the rehydration. And if you see the failures, the survival of these reattached fragments, when you see a minimum, a recent article states that in 2023, so minimum of 2 years are you followed up the reattached fragments, and most of them are restorative and biological failures. And what do you mean by restorative failure? The fracture of the attached fragment, whereas the biological failure is it leads to a complicated crown fracture done with a reattachment may lead to a necrosis, pulp necrosis. So that is called as considered as a biological failure. So you can see that what are the complications of the bonded fragment, and which type of another important study which is telling that in the recent analysis, meta-analysis in 2024 in the Journal of Evidence-Based Dental Practice, more failure is associated in this reattachment is seen with complicated crown fracture with no reinforcement, whereas less failure is seen in uncomplicated crown fracture with reinforcement. What do you mean by reinforcement? It is nothing but a fiber reinforced composite or a groove technique, something like that. That is called as reinforcement. Okay, so this covers the reattachment part, whereas in complicated crown fracture that is involving enamel, dentin, pulp, so the IIDT guideline says that if the patient is having an immature root and apices, it's very, very important to preserve the pulp. So mostly partial pulpotomy or pulp capping is recommended, particularly in complicated crown fracture. And if the tooth fragment is available, yes, still you can do a fragment reattachment. So the favorable outcomes until now are the important criteria. So if it is associated with a luxation injury, so you need to follow the protocol of the luxation injury regimen rather than the complicated crown fracture regimen. So that is the important guideline which needs to be, and it needs to be a longer follow-up should be needed, and the prognosis of such complicated crown fracture along with the luxation injury, the prognosis will be questionable, which is very, very important. So this is IIDT statement. What is American Association of Endodontic statement on the type of pulp therapy in immature apices? So if it is in pinpoint pulp exposure in a complicated crown fracture with no surface decontamination and no time lapse, so DPC is recommended. Whereas if there is a time lapse, the time lapse is nothing but only 1 to 2 hours. If the patient comes after 2 hours, you see a visible contamination, definitely you have to go for a partial pulpotomy. That's the important thing which we wanted to tell here. Partial pulpotomy, either larger pulp exposure or there is a time lapse, or if you see a visible surface contamination. So if the pulp hyperemia or bleeding is uncontrolled in a partial pulpotomy case, you go for a cervical pulpotomy or a complete pulpotomy. The American Association of Endodontists, even in closed apices, they ensure that RCT is indicated only when there is a loss of tooth structure which needs a post. Until then, you have to try for a more conservative pulp procedures which are pulpotomy or partial pulpotomy. Okay, so that's what the AAE recommendations. Another important recent study in 2025 August, which has been published recently last month, it tells that partial pulpotomy is successful in permanent teeth in dental injuries, trauma-induced pulp exposure, which is a very, very important article. You can, if you don't have an access to this, please mail me, you can get the access. Okay, so what is the crown root fractures? Next, what is the IIDT guidelines on crown root fractures in permanent teeth? So it can be classified into complicated and uncomplicated crown root fracture, is it not? So when you see that the only injury where CBCT is recommended is crown root fracture, because crown root fractures can be used for better visualization of the fracture path and it can also determine the treatment options. If it is an open abscess, you have to go for a partial pulpotomy, and if it is a closed abscess, it depends upon the patient's age and the extent of the fracture line. So you can go for either a fragment reattachment, or you can go for many options like gingivectomy, ostectomy, and even an orthodontic extrusion or a surgical extrusion. So when you compare this fragment reattachment for complicated crown root fracture, a multi-visit approach is having a lesser complication when compared to a single visit approach, and the fragment reattachment is similar efficacy. So if you see the same, Nitish Tiwari has had a separate similar hydration protocol where he changed the temperature and he kept the humidification chamber to keep the rehydration protocols. There it went well with the help of the humidification chamber. The rehydration played an increased fracture resistance of the reattached fragment in crown root fractures. Okay. So as I told you, so either you can go for a fragment reattachment or other options in case of closed abscesses such as gingivectomy, ostectomy, surgical or orthodontic extrusion, or intentional reimplantation with 360-degree rotation, which has been mentioned in one of the literature. And if there is severe associated bone fractures, then you can go for an extraction or an autotransplantation, which is beyond the scope of this session. Okay. So you can see, you can look into this. In this case, they have tried almost all. They have tried an extrusion, they have tried an intentional reimplantation with 180-degree rotation. I have also attached this as a references, and I will be sharing this article with you. So you can look into this article which is a case report which was recently published in 2024. So what is the evidence of crown root fractures in primary teeth, evidence of management according to IADT guidelines? So if you see a crown root fracture in a primary dentition, the management is, if the tooth is restorable, you can use a glass ionomer or a strip crown or an aesthetic crown. If it is complicated, you can go for a pulp therapy and follow the same. Okay. If it is unrestorable, if there is a severe extent of the crown root fracture, definitely you can go for the extraction. So this tells you the uncomplicated crown root fracture, and this is a complicated crown root fracture. One of the important part of the diagnosis of crown root fracture is the apical extent of the fracture line is not visible, and there will be attached loose fragments in the gingiva, which is an important diagnostic criteria for differentiating crown fracture and crown root fracture. Okay. And another important, whatever hard tissue injuries happens in the primary teeth, the patient's post-operative instructions are very, very important. Make the patient not to traumatize the injured tooth further as per the IADT guidelines, and whatever hard tissue injury, either it may be a complicated or an uncomplicated crown fracture in primary teeth, encourage gingival healing and prevent plaque accumulation over the injured tooth by applying 0.2% chlorhexidine mouth rinse or a swab. Okay. So next, in primary teeth, what is the evidence of guidelines management for root fractures in primary teeth? So there are three options. So you can see that there are three clinical scenarios. If the coronal fragment is not displaced, there is no treatment required for a root fracture. And if the coronal fragment is displaced, and if you have leave the coronal fragment and it is not excessively mobile, then you can leave the coronal fragment to reposition spontaneously, and even if there is some occlusal interference. And if the coronal fragment is extremely displaced and it is interfering with your occlusion, you have to reposition it under LA, or either you can extract it if it is interfering with the occlusion and leave the apical fragment to be resolved. If you are repositioning it by a splint, you have to splint it. The only hard tissue injury in primary dentition which requires splinting is root fracture, which is for the duration of 4 weeks. Okay. So the other soft tissue injury which requires splinting in primary dentition is lateral luxation. So this is very, very important. So, okay, so which is very important to remember. So hard tissue injury, only one, which is root fracture, whereas soft tissue injury, that is lateral luxation. Yeah. So going into the luxation injury, we have covered almost what is the evidence of management according to IADT guidelines in primary dentitions as well as permanent dentition. So we are going into the luxation injury. So in luxation injury, all of the injury can come as a short note or an essay. What is the sequelae of injury to a primary teeth? So this can be coming as an essay. So if you see that, so most of the luxation injury which causes sequelae to the successor teeth are the intrusive luxation, the lateral luxation, the extrusion, and mostly the avulsion. So you need to write all these injuries and then what are the sequelae noted followed by the evidences. So which is very, very important. So I'm not going to much talk about on the concussion and the subluxation because there is no treatment or required, only a soft diet and a review after 4 weeks. And subluxation is nothing but there is an injury to the tooth supporting structure without displacement of the tooth. So an important thing with respect to the permanent dentition, many think that 2-week splinting is must in subluxation. No, according to IADT guidelines, recent 2020 guidelines, a flexible splint for stabilizing the tooth for 2 weeks is needed only if there is excessive mobility of the injured tooth or there is tenderness while biting on the tooth. This is the important criteria which has been given in the 2020 IADT guidelines. So the lateral luxation, the management is splinting for 4 weeks. If it is an open apex in permanent teeth, you have to go for an revascularization. If there is a chances of pulp necrosis, you have to go for apexification. Whereas in closed, you have to check if it is non-vital, you have to place an intracanal medicament if there is an external resorption happening and then go ahead with an RCT. So the important thing which is told in the lateral luxation, post-lateral luxation, definitely you have to go for a review for 2 weeks because there is a more chances of pulp necrosis. As I told you, if there is an incomplete root formation, go for more of the apexogenesis followed by if it becomes necrotic, go for apexification. Okay. Going for the extrusion, that is with the displacement of partial dislocation of the tooth out of its socket. According to the IADT guidelines, the splinting is for 2 weeks, followed by 4 weeks if there is any associated alveolar fracture. And evaluate the pulp based on the apices. You can go for an conservative pulpotomy or for the revascularization. If it is for closed apex, you go for an apexification or an RCT. Okay. The most important thing for in permanent teeth, that is intrusive luxation injury, where the displacement of the tooth in an apical direction to the alveolar bone. Usually the periodontal ligament space will not be visible, and the management is depending upon open apex or closed apex. Suppose in permanent teeth, if there is an open apex, you have to wait for the re-eruption up to 4 weeks. The spontaneous re-eruption for all intruded teeth independent of the degree of intrusion. Then if there is no eruption for 4 weeks, then initiate orthodontic extrusion, which is very, very important in case of open apex. Okay, so if you see you need not start any pulp therapy unless you see some resorptive process. In open apex, always go for a pulpotomy for an apexogenesis. If there is a non-vitality, you can place an intracanal medicament for a period of 3 to 6 months and then go for an apexification. In mature teeth, it depends upon the degree of intrusion. Remember it, in open apex, independent of the degree of intrusion, 4 weeks for the re-eruption and then followed by orthodontic extrusion. Then if it is in mature teeth, if it is less than 3 mm, it is called as mild intrusion. Okay. If it is 3 to 7 mm, then it is called as moderate intrusion. And if it is more than 7 mm, it is called as severe intrusion, where you need to go for surgical extrusion. Whereas in less than 3 mm, it is wait for 8 weeks for the re-eruption. If there is no re-eruption, then you have to go for a surgical extrusion and then splint it for 4 weeks. For moderate intrusion, go ahead for either surgical or orthodontical extrusion. During the extrusion, if you see that if there is any pulp necrosis, then go ahead with an placement of an intracanal medicament and followed by an RCT later. Okay. So suppose if there is a combination injury, if a question comes like a combination injury, that is nothing but a complicated or uncomplicated crown fracture along with an associated luxation injury. So the prognosis is worsen according to IADT guidelines, the follow-up regimen will be prevailing for a luxation injury rather than a complicated crown fracture or a crown root fracture. Okay, so suppose, let's see a question here. When I analyzed one question, so can you see that? So a management of a 9-year-old girl with severe intrusion of a left maxillary lateral incisor along with an Ellis class 3 fracture. So this clearly tells that it's a combination injury. So you have to write about what could be the contents. Let's analyze that. Okay, see the contents here. So you can write as a clinical scenario with a diagram indicating that a 9-year-old girl, because it's an open apex case. Then it's told that it's class 3. That means it's a complicated crown fracture. Then you have to go for either pulp capping depending upon the pinpoint exposure, or a pulpotomy followed by partial or a complete pulpotomy, and then IADT guidelines on that. Then you can do that. And you can go also talk about fragment reattachment techniques if the fragment is retrievable. Yes, exactly. Then follow protocol according to the IADT guidelines, because it's a combination injury. The luxation injuries protocol will provide. Now it's an open apex. What will be the open apex? You have to wait for the repositioning. Automatic, that is, we have to wait for 4 weeks. There is no re-eruption, then go for an orthodontic repositioning. Exactly, that needs to be done. And then you can add that, because if you are going with a combination injury and it's also a severe intrusion, you can add CBCT as a guideline. So all these things can be written in an essay, and this will fetch you the best marks. I hope you will understand that. Okay, so now going on to the CBCT and the radiographic guidelines. So what is the guidelines on radiograph? They may ask you a short note. So guidelines on radiograph during dental trauma. That can be a short note. So what is the IADT guidelines? One parallel periapical radiograph through the midline, and then one parallel periapical radiograph aiming at the lateral incisors and the left lateral incisors. That is called as eccentric periapical radiographs. That is 2 eccentric periapical radiographs followed by one maxillary occlusal radiograph and another one parallel periapical radiograph of the lower incisors. Even if it is the upper incisor is injured, we have to concentrate also with the lower incisors. That's the IADT guidelines. Next is CBCT indications in dental trauma. As a short note, you can recommend what are the injuries recommending for CBCT injuries. So ideally, according to IADT guidelines, it's root fractures, crown root fractures and lateral luxations are indicated, and CBCT is indicated to determine the location, extent and direction of a fracture, and as simple as possible, 3D CBCT is indicated only when the the image is likely to change the management of an injury. You thought that it is a complicated crown fracture, but your CBCT told that it is a complicated crown root fracture. That means it is going to change. That means that is indicated according to IADT guidelines. So these are the important points which I wanted to cover on CBCT guidelines. Next, another important short note which comes mostly in the paper 2, that is splinting in dental trauma. So splinting in dental trauma, so mostly, which is an important process, you can write about the ideal properties of a splint, blah, blah, blah. And then most important thing which I wanted to cover is the duration, which is very important. You can write like this. This tabular column will be very good for you. According to IADT guidelines, what is the splinting time? As I told you, to keep it very short, you can combine another important table. So this is better. So where you can use primary as well as the permanent tooth injury. The only permanent teeth soft tissue injury which requires splinting is lateral luxation, as I told you, which is for 4 weeks, and another hard tissue injury is root fracture. So the rest all need splinting in permanent dentition. So what are the types of splints? You people better know it. That is the wire composite splint along with E-chain also is nowadays recommended. The nylon fishing line splint along with the orthodontic brackets along with the passive ligature wire, and if the newer advancements you know, that is called as titanium trauma splint. The titanium trauma splint, which is made up of, which is available in the market of 100 mm length and it is 0.2 mm in diameter. So these are all the things you can write. So wire composite splints, all that we have included here. So also one systematic review, you can quote it, which is recently published in 2023, where the splinting is indicated. And then most importantly, you come across this question every time, even in UG as well as in the PG exams now, that is the management of avulsion. Okay. So write in detail the clinical protocol for the management of X-articulated permanent central incisor in a child. It didn't mention the child whether it is open apex or closed apex. So we need to write both the management. Okay. So the contents for that, you can see that you have to introduce why the avulsion is very important, and the prevalence of avulsion according to recent IADT guidelines, it's around 0.5 to 16%. So the first child followed by the clinical guidelines, the storage media you can add, and then the antibiotic protocols, what is indicated, and what are the patient instructions, and what are the healing complications of avulsion, followed by conclusion and references. So these are the contents. So what is the first aid for an avulsed teeth protocol? So make sure this is according to IADT, ensure the patient remain calm, handle the tooth, locate it, and handle it by the crown to avoid the root damage, clean the tooth only in milk, saline or saliva if dirty, then reimplant it and secure the tooth by biting on a gauze, and if not, then replace it in a, plant it in a suitable medium, transport it and come to the dentist. This is the flow chart for the first aid. Okay. You can write like this, or you can write it as a point. And then you can go for the clinical protocol. Based on the clinical protocol, there is most important thing is the choice of treatment depending upon the open apex or the closed apex, as well as the extraoral dry time. The extraoral time is time out of the mouth, also along with the time in the storage media, whereas dry time, which is very, very important, according to recent IADT guidelines, 30 minutes is the critical dry time, not 60 minutes. Okay. The three conditions, the PDLs are most likely to viable, and if it is less than 60 minutes placed in a storage media is the second condition, and more than 60 minutes it is dry time, which is non-viable. So these are the three conditions based on dry time. So according to that, based on the closed apex or an open apex, the management, the most important thing which I wanted to consider here is the splinting is 2 weeks, and if it is alveolar fracture, if it is 4 weeks, and whether it is open apex or if it is particularly in closed apex, after 2 weeks the endo treatment is initiated. So place an intracanal calcium hydroxide medicament. If the dry time is less than 60 minutes, which is in closed apex, the same protocol, and they examine the alveolar socket and splinting 2 weeks and 4 weeks, and antibiotics and tetanus protocol, the same protocol for the greater than 60 minutes as well. So in open apex, the chances for revascularization should be given more prioritized rather than for going for an root canal treatment. And if there is no chances of revascularization, and when you see some external resorption, then you have to start with an apexification procedure such as placing an intracanal medicament. So they can also ask you what are the complications of delayed reimplantation. So there are 3 complications most commonly. The first is an ankylosis, which is considered as a favorable prognosis, which is called as functional ankylosis. And then the other one is replacement resorption. There is a complete replacement of the PDL by the bone cells, which is called as replacement resorption, which you can see here, the complete replacement resorption which is happening in 1-1. And then you can see then external inflammatory resorption, where there is a complete dissolving or the complete eroding of the PDL cells by the resorptive osteoclasts, which is called as external inflammatory root resorption. So if you want to further dwell in deep, a very good review article by tooth resorption by Paul Abbott, so which is an open access article which can be available. So you can look into it, what are the types of resorption followed and delayed reimplantation. It is given very clearly. Okay. So what is the stand of IADT guidelines in systemic and topical antibiotics? Still there is highly questionable, it's very controversial, but the first choice of drug in avulsion is amoxicillin and penicillin, followed by doxycycline, and tetracycline is not recommended in children less than 12 years. And still the effect of soaking the tooth, the delayed reimplanted tooth in an topical antibiotic like tetracyclines or a combination of triple antibiotic paste, still it is not recommended because there is no clear-cut evidence on the effects. So you can see that there is no clear evidence. You can see a recent article. There is no clear evidence on the quality of systemic or topical antibiotics in delayed reimplantation. And another important question which comes, storage media for owl's tooth. So this is an important short note, or sometimes it comes as an essay as well. So you can start it like an ideal properties followed by the classification based on the constituents, that is physiological, hypertonic or non-physiological. Physiological is nothing but which contains the solute similar to our human body, which is called as physiological media. When the solute is higher concentration, it's called as hypertonic, which is no way related to body fluids, is called as non-physiologic. Based on the origin, it can be classified into natural or synthetic storage media, and you can conclude with the recent advances. So these are the classifications based on the origin, natural and synthetic. I'm not going to dwell in deep with it. And the recent storage media which has been come is delphinidine, which is from blueberries, which is an antioxidant, proanthocyanin. So this has also been tried as an storage media, which you can add it as a recent article. Okay. So the luxation injuries in primary teeth, the prevalence of luxation injuries in primary teeth accounts for around 23% according to recent systematic review by Patnana et al. In 2021. Okay. So we talked much about the lateral luxation, that is here also the only luxation injury in primary teeth where the splinting is for 4 weeks. The lateral luxation has a poor prognosis, definitely it should be followed up till 1 year. And the most important thing, in intrusion luxation, the most important protocol, you know that if the tooth apex is not visible, that means it has been going more labially and it is not injuring the permanent tooth in intrusion of primary teeth, whereas it is, the apex is visible, that means it is impinging on the permanent tooth germ. So earlier it was told that when it is impinging on the permanent tooth germ, it was advised for extraction of the primary tooth, but nowadays it's not recommended. So whatever it may be, it is advised for the waiting for the re-eruption up to 8 weeks. Okay, so that is the important criteria which is for the IADT guidelines. And the management, spontaneous re-eruption of the intruded tooth, maximum it can take up to 1 year. Okay, so that's what I talked about, why these luxation injuries which I was telling about us. They can be a essay question, discuss the sequelae of trauma to primary teeth and its complication. So, and its management. So in this question, how can you write it? You can go ahead with first the luxation injuries, which are more common for sequelae of that. That's most commonly lateral luxation, intrusion and avulsion. And then what are the sequelae? You can see quote a recent study, that is impact of traumatic injuries to the primary teeth. So the most commonly developed are the enamel discoloration, followed by hypoplasia, crown dilaceration, root duplication or dilaceration, eruption disturbances and odonto malformation. So you can see that the luxation injuries are the first, that is the intrusion is having a higher percentage of sequelae, and followed by the avulsion and then subluxation and the rest of the hard tissue injuries having an effect on the permanent dentition. This is according to the recent retrospective cohort study article. Okay. If you see another article by Mausumi Goswami in 2021, the outcome of this luxation injuries on the permanent teeth. So the most common complications seen are the pulp canal obliteration and the necrosis and the tooth loss. So these are the common sequelae happen. Okay. So this covers about the sequelae of the luxation injury of the primary teeth to the permanent teeth. So there may be also another questions coming under, that's how the dental trauma can be, prevention of dental trauma as a short note, or they may ask you as role of pediatric dentistry in dental trauma prevention or sports dentistry as a short note. So in that you can add as a content like sports dentistry as an introduction, followed by the mouth guards definition, ideal properties of mouth guards, types of mouth guards which are available, and what are the mouth guard materials, manufacturing techniques like polyurethane, EVA. There are many manufacturing techniques such as the vacuum vacuum, and there are many techniques, manufacturing techniques of mouth guards, and there are recent digital mouth guards which can be fabricated by using CAD/CAM, and all these can be added in the contents. Okay, there's a wonderful article, review article, which I have added in the reference. You can see that Roberts, this gives you a complete overview of the mouth guards and its fabrication and the recent trends, which can give you an overview to write an essay on it. Okay, so the classification of the mouth guards, the stock, mouth formed, which is further classified into thermoplastic and chemical setting, and the vacuum formed, which is the custom mouth guard, which can be further classified into vacuum formed and model formed. Okay, so this covers the entire dental trauma topic. That mostly it covers almost the luxation injuries, the heart tissue injuries, and the prevention of dental trauma, the mouth guards and its classification. You can scan the scan code. All the reference articles and the articles are open access or closed access also can be accessed through the scan code. If you need it, I can share it to your faculty so that they can share you. Thank you.
Thank you so much, sir, for the wonderful presentation. I would like to call upon. Questions? Yes.
That's what, there are two protocols which is not clear cut. One is called 20 minutes they can, otherwise they are told it 24 hours. According to IADT guidelines, it tells 20 minutes if there is immediate, they visit the dentist. Otherwise you can place it in saline for 24 hours. So why, what is the reason? Which we have told that the dentinal tubules, that is the reason. Yeah. Still there is more research going on. Still there is no clear cut evidence that whether 20 minutes is better or 24 hours is better. So there are more. Even the temperature, now you saw a recent study that the temperature, maintain the temperature for the humidification also plays a major role in the reattachment success.
Okay. Now I would like to ask Dinesh sir and Ega sir to come and present the memento to sir. And now, to add some fun, excitement, and test your knowledge, like how much you have absorbed from this session, we move on to our last session, the quiz. I would like to ask Ega sir to continue with the quiz.
So good afternoon. Hope you all had a brainstorming session for the past 2 days, and let us test our knowledge, like how much we know, in a fun-filled way. So we will have a quiz now. So everyone make arrangements like group in a group, like forming with your college. For example, where is SRM Ramapuram? SRM Ramapuram, anyone? How many of you are there? Two. Okay, you two will be there. Okay, which college you are from? Ramchandra. Okay, like you can be 3 or 2 from your college can be in a group for the quiz. Okay, so Ramchandra is there, SRM Ramapuram is there. Next, Meenakshi, who is the 3 or 2 who is going to attend the quiz? No, only 3 or 2 participants. Okay, decide. Next, you are from? RV Dental College is here. Number 4. Wait, other college. You are from?
Vivekananda.
Last. Vivekananda, okay. Then SRM Katangalattur here? No? Saveetha. So you are 6 teams, right? So Saveetha only 3. 3 people.
EGPG.
So whoever is going to participate in the quiz, please come and occupy in the front. EGPGs will attend the quiz now. Yeah, I told Vivekananda. Please come forward.
Fast.
From Ramchandra, 4, okay, any 3 can be there. You 3 will be here. So Ramchandra will be team A. Team B will be Saveetha Dental College. Who are going to be the 3? Team B will be Saveetha Dental College. 3.
Makes it 1, 2, 3 like this. You will not be able to make them 1, 2, 3, 4, 5. No? Because there, Savita, all will get.
Only 3. You should.
3 only.
3.
Per college, 3.
3. Okay, so 1 will be Ramchandra, 2 will be Saveetha. Team number 3 will be SRM Ramapuram. Yeah. You can come in the front. Vivekananda came here, okay. EGPGs are attending. Okay. So Ramchandra will be team 1, Saveetha will be team 2, Meenakshi will be team 3, SRM Ramapuram will be team 4, Vivekananda will be team 5, and RV College will be team 6. So 6 teams, you will have 3 rounds. So for the first round, each question you will get 5 marks for the right answer. If team A is not answering, the question will pass only to team B and half mark will only be given. Okay? No negative markings, only positive marks. And in the first round, you will have 3 set of questions, just basic questions. Every team will get 3 questions in the first round. And second round, you will be having 2 questions. And in the third round, you will be having a picture-based question and author-based question. So it is going to be 3 rounds. And who is going to top will be announcing the winner and the runner. That's all. Tiebreaker will decide it later. And pass question only to the next team and only half mark will be given. Prompting is not advised. Okay? So avoid prompting the answers. Have the mic and pass it. Next.
Okay, hello guys. Can we start? Okay, can we revise team numbers first? One is Ramchandra, second is Saveetha, third is Meenakshi, fourth is SRM, fifth is Vivekanand, sixth is Bangalore. Okay. Huh?
Ma'am, will it be projected over there?
Yeah, photo will be projected here.
No, we can't see.
Later we'll.
Oh, right now nothing.
First we'll play round one. Then we'll. Okay. Starting with the round one, Team A. First question is. Dash was the first to describe the combination of composite restoration and a sealant, PRR. You have to name the author.
Simonson.
Very good. Year you can say. No bonuses, but still. No? Okay, great. 5 marks, Group A. Group B, Team Saveetha. Your question is, the primary dentition calcification of maxillary central incisors begins at approximately dash months in utero. Months. No. Pass. Pass to one answer only. Pass to Team C. Any guesses? No. Again, I'll pass. Pass to Team 4. Only one pass. Okay. I'll say the answer also. The answer bolna. Okay, so you guys know? No. One more guess? 14 months. That's the correct answer.
14 months. In utero, 14 months.
Yeah.
Question is only wrong. Repeat the question.
Months is there.
14 months in utero.
Siri, okay. Next. Siri, group 3, your question is, gum pads are divided into 10 segments by grooves called name of the groove.
Is dental groove in
Huh?
dental groove?
No. Passed to group 4. No. Next. You get 2.5 marks. Correct. Okay, team 4, SRM. Your question is, incisal liability is about dash mm in maxillary arch and dash mm in mandibular arch. I'll repeat the question. Incisor liability is about dash mm in maxillary arch and dash mm in mandibular arch.
1.7 in maxillary.
No.
3. No.
Mandible? No.
Are we saying ulta?
Pass? Correct. Very good. Group 5, your question is, leeway space of Nance is utilized during the dash transitional period.
Late mesial shift.
Which?
Second transition.
Correct. Good going. Sixth group, your question is, fifth generation sealants have dash property. Fifth generation.
Fluoride release.
Correct. Very good. So the first round is over. Starting with the second round. Your first question is, for the second round, the tip of fissurotomy burr is dash mm. Take a guess.
0.3 mm.
Correct. Okay. Group 2, your second round first question is, according to IADR sealant synopsis, in primary tooth, acid etching is done for dash seconds, washing is done for dash seconds, and drying for dash seconds.
30 seconds, 15. 30, 15.
Correct.
30, 15.
30, 30, 15 is the correct answer. Group 3, your question is, dash first prompted the use of table salt as a vehicle for fluoride. I'll repeat the question. Dash first prompted the use of table salt as a vehicle for fluoride. Try, give an answer. There's no negative marking, just try. No? Okay, pass. Group 4. It's the author name. Yeah, of course. Pass. Audience? Correct. Wispy. Okay. Team 4. Your question is, Nalgonda technique was first developed in India in dash year. Come on, take a guess. There's no negative marking. Take a guess.
1954.
No. Pass. No?
No idea.
Guess?
960.
Close, but no. 1975. Okay. Now the question is for group 5. Your question is, Knudsen and Feldman recommended a technique of 4 applications of 2% NF at weekly intervals in a year at intervals you have to mention.
3, 7, 11, 13.
Perfect. Okay. Okay, group 6, your question is, Dash coined the term ECC. Really easy.
Davis?
Yeah, correct. Okay, here ends the second round. We'll start with the third round. Okay, your first question is for the third round. Maintenance drug for GA through IV is Dash.
Fentanyl.
No. Pass. Through IV.
That is.
Propofol or propofol.
Say.
No, one second. It is Midas or Propofol?
They have already told.
You can do through IV. Propofol.
Correct.
Oh, yeah.
Okay. Next question to group B. The blood gas coefficient of nitrous oxide is Dash. Number you have to.
0.38.
No. Close but no. Group pass. Group 3.
Point 0.48.
0.447, but I'll give it to you.
Thank God.
Okay. Group 3, your question is, the duration of action of chlorohydrate is dash hours. You have to give a range. You can give a range.
4 to 6 hours.
2 to 5 hours is the answer. 4 to 6 hours. Half marks? Okay, we'll give half marks. Okay, next. Group 4. Your question is, voice control was given by? Come on. Come on, give an answer.
Evand or
Huh? No. Pass.
pin cam.
Correct. Group 5, your answer is Dash was the first dentist to use nitrous oxide.
Horace Wells.
Correct. Super. Team C. Huh? Answer is Horace Well. Team 6, the last question. Oligodontia is the term used if dash or more permanent teeth are missing.
6.
Correct. Okay. So the round 1 is over here. We'll proceed for the round 2nd. We'll announce who's in lead.
Third is Saveetha with 12.5.
Okay, so in this round, you will be given 3 sentences. Every sentence will have 1 clue. You have to deduce the answer. Okay? Got it? I'll repeat. In this, you will get 3 sentences. Every sentence will have 1 clue that will lead you to answer. You have to deduce the answer. Correct? I'll give an example. I affect 6 to 9-year-old the most. First. Second, I make restorations fail more often. Third, post-operative breakdown is a hallmark feature. MIH. Like this.
If you are going to take the 4th prompt, this is going to be evaluated for 10 marks. If you are taking the 4th prompt, you will get 8 marks. If you are going to take the 5th prompt, you will be getting 6 marks. 3 prompts will be given for every team. 4 and 5 is your choice.
3. Pass is not. Pass is there? Pass is not. Pass is not there. Okay? We'll start. Okay. First, I am used in pediatric pulp therapy. I have excellent sealing ability and bioactivity. My biggest drawback is long setting time and discoloration.
MTA.
Correct. Okay. Team 2. Your question. Vlada, super. Okay. Team 3. I am preventive strategy. I involve restorative proximal lesions using only hand instruments. I use GIC as my main restorative material.
ART.
Correct. Group 4. My radiographic sign is the ballooning of the canal outline. I occur due to chronic inflammatory stimulation of pulp. In primary teeth, I often indicate pulpotomy failure. My radiographic sign is a ballooning of the canal outline. Okay. I occur due to chronic inflammatory stimulation of pulp. In primary teeth, I often indicate pulpotomy failure.
Internal resorption.
Correct. Team 4, team 5. Okay, I am a cognitive approach. I make use of pre-appointment preparation videos. I reduce anxiety by familiarizing the child with the dental sitting.
Modeling. Modeling.
You told? Okay. Correct. Next. My pH is initially very high. I promote hard tissue formation and act as an antibacterial. I was once the gold standard for
Calcium hydroxide.
apexification. Correct. Move to throat. Where's the... Okay, we'll start with the third round. Can you see the picture? Okay, what's the answer?
Smart bus.
Correct. Team 2, you have to. What is A in that? Correct. Team C? Come on, take a guess. Mini dam, correct. Team 4? Name the scale. Very easy scale. There's no negative marking. You can answer something.
Face is imaging scale.
Huh?
Face is imaging scale.
No. Anybody? Correct. Team 5, which modification is this?
Main space maintained.
Correct. Team 6?
Intranasal midazolam spray, we use that. Atomizer.
Correct, correct, super.
So this is going to be the last round. It is going to be very simple, but not easy to find. I'll be telling you the name of the book, and you should be telling the authors. Standard textbooks. I'll start with Team A. Pediatric Dentistry, Infancy through Adolescence. Any two? Good. Yes, right answer. Team 2. Pediatric Dentistry, Total Patient Care. It is a standard textbook. Any guesses from the audience? It is Stephen Way. So number 3, I think it's going to be easy for you. Fundamentals of Pediatric Dentistry. Answer? Matthewson. Okay, any other author? Matthewson and? Oh, you are going to? Yes, correct. Give marks for Team C. 4th team. Dentistry for the Child and Adolescent. No. Anyone? Dentistry for the child and adolescent. McDonald's. Pediatric operative dentistry. Yes. Pediatric operative dentistry. Any guess? It is one of the oldest textbooks. Kennedy. The last question. Textbook of clinical cardiology. Famous author? Yes, correct. So we are done with the quiz, and now we will have the results of the quiz, and the first prize team will be getting a gift from the team, organizing team. Oh, there is a tiebreaker. For second question, first. Okay. Any guesses for the first place? Who got the first place? No. The last team got the first place. Yes, yes. RV Dental College from Bangalore got the first place, and we have a tiebreaker for the second place. Team A and Team E, which is Vivekananda Dental College and Ramchandra Dental College, have finished second, and you will be having a tiebreaker round. Deepa ma'am will be asking a question, and it's going to be like a buzzer round. Whoever is raising the hand and telling the right answer, and you will be getting the second place.
The first to answer will win, right? Okay. By what duration the discoloration of SDF vanishes from the tooth surface? SDF. It causes some discoloration, isn't it? So by what duration do we expect it to disappear or at least fade away from the tooth surface? Anyone can answer, right? No, the team 2E. Okay, what is now added to SDF to make it not? They answered first, right? Kai tuk nala. So we go with them. Congrats. You're from Vivekananda. Congratulations, Team Vivekananda. Thank you.
So I call upon Dr. Deepa ma'am to give away the prizes for the first place and the second place. Okay, Sunny sir, please come onto the stage to give the prizes. First place goes to RV Dental College from Bangalore. Wait. You are having a gift from Kiddo Dental that will also be handed over by you to you by Dr. Sunny. Sir, this to them. And the second place goes to Vivekananda Dental College. Thank you, sir. Now we have come to the end of a 2-day rapid revision program. The 7th edition of SPARC is to the end now. And I call upon our HOD, Dr. Deepa ma'am, to give a vote of thanks.
So, to give the vote of thanks, I want to know from you all, from your side, how did the 2 days go for you all? A louder one. You need the mic? Yes, please tell. Was it useful for you all? Yes. So you all have learned something, at least to know how you all have to go forward with your preparation for your exam? Yes? Okay, good. So to thank you all is to you all that you all were alert in these 2 days. So thank you for that first. And then please convey my thanks and best wishes to all your heads personally from our team, Saveetha Pediatric Dentistry team, to your heads and to all your staffs, that we are very thankful to them for sending us you all here. Okay, will you all do it? Yeah? Okay. The next thing is, yes, I have to thank my staff and my postgraduates who have done a wonderful job to make this program a successful one, as well as the first years who had just joined now. They took up most of the responsibility to do it, so it was too nice of them. Thank you. And the second years were just left the first year. They also did a very good job doing the conducting this program, bringing us speakers. So all takes a lot of effort and time. So thank you for it too, each one of you. Thank you so much. And of course, my third years, they have to study. So it's okay. And to all my staffs in particular, I need to thank Dr. Mahesh, Dr. Ranjit, Dinesh, and Dr. Ekambereshwar, Maria, who had taken an extra effort to run this program in all possible ways, in small, even things that had to be done, so that this program will be helpful and beneficial to you all. It's not just conducting a 2-day program and leaving you all sitting here bored and not taking anything home. So that's not going to be useful. But my entire team was there to back up, even in the most hardest times, to make this program a successful one. So thank you to my team. And of course, I have to thank the management of Saveetha Dental College for giving us a platform for what we are today, for grown up for all these while, and a very good environment, right? And 2 days in the same place would have been boring. So 2 different places. Yeah, thanks to the team which has been streaming our program online. I do not know how many of you all saw it, but it is very, very clear on the YouTube. The video as well as audio is very clear, which we did not expect so much. So thank you, sir, for it. And of course, the people who have not been mentioned here, but have done something for this program, a heartfelt thanks to every one of them. And hopefully the next SPARC also, we get the same response from everyone. Yeah. Thank you so much for coming once again, each and every one of you all. And please convey our regards to your staff members, everybody. We cannot meet them in person and thank, but I consider you all to be our messengers. Isn't it? You all will do it? Yeah. So please thank not only your heads, your other staffs also. Fine? So please inform them our love and regards to all of them. Thank you so much. So I have sent a feedback form there. So my vote of thanks will complete once you all complete the feedback form. So we can give away the certificates to you all. Okay, I'll give you 5 minutes, 2 minutes time, only 2 minutes. Complete that feedback. We'll start with the certificate distribution. Right? Thank you.
Okay, now I'll start calling up your names. Please come one by one. Yeah. I'll request Dr. Lavanya to please present the certificates to the participants. Dr. Aishwarya Parambat Sridharan. Dr. Midila John. Dr. Apurva Goswami. Dr. Arunika Bedre. K. Aishwarya. Dr. Apurnika Bedre. Arunika Bedre, sorry. Dr. K. Aishwarya. Dr. Sri Harita. Dr. Ram Chidambaram. Dr. Kuhila Panja. Dr. Lalita Priya. Dr. V. Ratina. Dr. Kulina. Dr. Akanksha. Not there. Dr. Sandanam. Dr. Pratyakcha. Dr. Celia Rose. Dr. Vaishnavi. Okay. Now I would like to, yes, Dr. Vaishnavi. Thank you so much, ma'am. Now I would like to ask Dr. Ramesh to continue. Dr. Shushmita. Dr. Monica. Dr. Esther. Dr. Sarah. Dr. Nivedita. Dr. Soumya. Dr. Rasika. Thank you so much, sir. I would like to ask Dr. Ranjit to continue the certificate distribution. Dr. Geetanjali. Dr. Kirubashri. Dr. Swarnima. Dr. Khushi. Dr. Jayashri. Dr. Khushi Parmar. Dr. Manisha. Thank you so much, sir. I would like to ask Sunny sir to continue the certificate distribution. Yes. Dr. Harsh. Dr. Badusha. Dr. Suyog. Dr. Tendril. Dr. Pragati. Thank you so much, sir. Now I would call upon Dr. Dinesh, sir, to continue. Dr. Bhuvaneshwari. Dr. Sai Kirtana. Okay. Dr. Soundarya. Dr. Ashish. And Dr. Parkodi. Okay. And Dr. Ayushma Chakrabarti.
Dr. Shambhavi.
Okay, now we all will have a group photo. So, everybody can arrange themselves in appropriate positions, please.